We hope that you enjoy the conference today. Make sure you get the materials at the front desk. If you can, join our social media conversation at CMDA honoring our why. Enjoy the day. Thank you very much.
Thank you.
Morning, everybody. 30 years. How about that? 30 years we've been doing CMDA. Amazing. And I believe this year we have a record number of registrants, if I'm not mistaken. So, um, one of the main reasons our past presidents, super champions for everything we do here. And so it's wonderful to see everybody. Another reason we have such a great turnout year after year is because of our speakers. And so I want to introduce Dr. Carrie Levy, who's going to come up and talk about Alzheimer's disease. So, without further ado, Dr. Levy.
Thank you. Um, I love that we have a hand mic. It feels like karaoke should happen at some point, right? So thank you for having me this morning. Those quotes are beautiful, and the Wordle or not Wordle, whatever that thing is, was really what's it called? I don't know. Cloud, a word cloud. Thank you. Was really beautiful and really reflects why it's so fantastic to be in this room with these people who have been amazing mentors to me and friends. And so I'm very, very happy to be here. So we're going to talk about biomarker. And I know in long-term care, this is not the most important thing we're doing right now, but it's coming. And so I wanted to present a case this morning that's very particular to long-term care and also to just give you a preview of what's happening with these biomarkers, because I do think that they're going to be more and more a part of our lives. And by virtue of a person who's involved with older adults, I'm guessing you're getting questions about this from your loved ones. This is designed to help you as you answer those questions from loved ones. So we'll go ahead and go to the next slide. Am I changing slides? Oh, it's so discreet. Wow. Okay, look at this. It's tiny. Okay. So the case presentation today is of a gentleman named Daniel, and he's the son of one of the patients you're admitting. His 78-year-old mother is coming for rehabilitation. She's just been in the hospital. And while she was in the hospital, they said she had dementia. This was obviously very upsetting to the family. And the hospitalist said, yeah, she had a mini cog and 0 out of 3 recall on her 3 words. So they were worried that she had Alzheimer's. And so Evelyn, importantly, the patient, is caring for her disabled daughter who has Down syndrome. And so they really need to know whether or not this diagnosis is accurate or not. And so Daniel worries he's got this sister who is not very helpful, which sometimes happens, and she's always been very jealous that Sarah got a lot of attention and wants to sort of disrupt all of that and kind of has her whole life. And he's worried if she has dementia, the sister's going to come in and be a real problem. And so he says, is there any way we could just do some biomarkers? I hear these are very good tests for dementia. So could we do that? And then I'll know kind of which way to go. And if it's positive, if it looks like she has dementia, then I need to, swing into action and try to arrange care for Sarah. And if not, obviously we can move forward as we have with the beautiful care that her Sarah's mom provides for her. So I'll have you just think a minute about a few questions. And some of you, I'm guessing, have seen a little bit of this literature. Others are just beginning to hear about it. And so this is your patient, and you're being asked this question. And so if you had an individual who had a 0 out of 3 on their mini cog, how good a test is that? I'll just have you think about these things, and then we'll come back to them at the end. So what do we think about that? It was in the hospital setting, but she wasn't able to recall any of the items, of the 3 items. So how helpful do we think that information is? And then what are we going to advise the two of these folks in terms of her caregiving and her ability to caregive? If we were to get a biomarker and we found that it was positive, then what do we say about her ability to continue caregiving? And so these blood tests are available. You'll learn a little bit more about their expense and whether or not they might be helpful. But I'll just have you in your mind sort of think through for a minute what you would do with this question. So these blood tests for dementia have made the New York Times and various other outlets. You'll see this article here, a blood test that accurately diagnoses Alzheimer's 90% of the time. And anytime I see a headline like that, I think, really? Really? Is it 90% of the time? That doesn't sound really possible. So we'll talk through that. And we know that Alzheimer's disease is characterized by the accumulation of amyloid plaques and phosphorylation of tau. We can right now do a PET scan, or we can take a CSF sample and diagnose, Alzheimer's with these various tests. Those are the gold standard. But now we have a blood test, which is obviously much easier than CSF or getting a PET scan arranged. And so let's just talk through this so you feel like you have a little bit more command over these data. So the specific article I'm going to talk about is this one that was in JAMA, and it was entitled Blood Biomarkers to Detect Alzheimer's Disease in Primary Care and Secondary Care. And I'll tell you just a little bit about the structure so you know how the study was set up, and then give you a sense for what the results showed. So the design was there were 1,213 Swedish patients. So of course, anytime you're reading these studies, you want to think about who is in it, and is it like the person that you're treating in this moment. And they'd had cognitive symptoms. They had several biomarker cutoffs that they used that had previously been established. And they had two cohorts. They had a primary care cohort and they had a secondary care cohort. And these were folks that had gone to a specialized memory clinic for care. This prospective blood test was done in those two cohorts. And what they were looking for is the p-tau 217. And they looked at that alone or in combination with amyloid beta 4240. So we'll just call that an amyloid beta ratio. And essentially, these are the two tests that they looked at in this particular study. They also looked at the CSF markers and the PET scans, and those were really the gold standard. The PET scan is difficult to get, but of course this was a study, so they had access to them. So the outcomes were Alzheimer's disease pathology and this abnormal amyloid beta ratio. And then they also looked at the p-tau 17 to say, is this a good biomarker? Should we be using this? And then they looked at clinical Alzheimer's disease. So the results, the median age was 77. So certainly our patient falls in that category. And as the New York Times article would suggest, the sensitivity, specificity, positive predictive value, and negative predictive value were all 90%. It's hard to believe, but I'll show you some of the data in just a moment. What's really interesting about this study is they also had primary care physicians diagnose the Alzheimer's, and they had dementia specialists diagnose Alzheimer's. And so the primary care physicians were about 61% accurate. Dementia specialists were about 73% accurate. And we know that test sensitivity is going to depend on prevalence in the community and also on the level of complaints. So those who had subjective memory complaints who did not meet formal diagnostic criteria, the test wasn't as good in those individuals. But for those who had met criteria for dementia or mild cognitive impairment, the test was very, very good. And that was true of the amyloid beta ratio and also the p-tau 217. So if you've if you've looked at this literature at all, there's a ton of different biomarkers, and it's a little bit difficult to know which ones to get at this point. But these are two that keep popping up as pretty helpful biomarkers. So just wanted to show you a little bit about the test or the study characteristics here. Mini mental status exam of 27 on average. And then you see there were 27% of individuals who had subjective cognitive decline, 45% with mild cognitive impairment, and 28% with dementia in the primary cohort. And then in that secondary cohort, a larger percentage had mild cognitive impairment and dementia. They were in specialty care, so that makes sense. But just to give you a sense of where these folks landed. And then these receiver operator curves, nothing special in terms of the sophistication of this, but just to show you that if it were on the dotted line that goes through the middle, that would not be helpful at all. And the higher the curve, the more accurate the test. And you can see these all look extremely accurate. So this is, they call that one that's the ratio and a combination of the two, the APS2. So you'll see the test characteristics for that are very, very good. And that was true for the primary care group and the secondary care group. You can see it's really quite similar across the whole spectrum of patients who were studied. So the bottom line is really good, very predictive test. And here we've got the performance of the test with a certain cutoff value that they had defined. And the idea here is that the yellow dots are with this APS2 test, which is a combination of the amyloid beta and the p-tau 17. And then the blue ones are the p-tau 17. And you see basically really good, like in the 90% range for both of the tests. And then if you look at a second cutoff value approach, you see similar findings, little bit less, or excuse me, a little bit more specific in this particular cutoff value. But bottom line is really good test. And then the blue dots here on your left are when a dementia specialist was diagnosing the Alzheimer's, and then the yellow and the blue were the APS2 and the p-tau 17. So again, you can see more sensitivity in the group, more specificity in the biomarker group, and really it played out to be quite a bit better than a dementia specialist. And then for the other one on your right, this was primary care. So if you had a primary care doc working to diagnosis in the office, this is what you see. And again, we're just unfortunately not as good as these tests. So this is really surprising, and it's a little bit depressing because you'd like to think you're better than this in your office diagnostics. But it's also helpful that we now have something that's more accurate and probably be going to become more available. So really pretty impressive results in this particular study. And then importantly, this is an important message, a take-home message from this discussion, is that if somebody had subjective cognitive complaints, they just felt like their memory wasn't quite as good, but they didn't meet the specific dementia criteria for either mild cognitive impairment or dementia, the test is not as good. And so this is important because you'll have a lot of folks who just, their memory doesn't seem great, and they come in and they say, could you please do that blood test? And you should, until you have done some more diagnostics, until you've done an office workup. So we're still needed, I guess, is the point of that, because we do need to get the right people to these tests and not just take anybody who is a little bit worried about their memory. So the test is not as good in that group. So in summary, we've got these two tests. We have the p-tau 17 and we have this APS2. Hopefully those diagrams showed that these are pretty darn accurate. They're better, sadly, than primary care or dementia specialists, but I think they can be used in conjunction with the things that we do. These are not FDA approved, and so they're not covered by insurance yet, but there's work to do that to get them FDA approved. And so the pretest probability again matters. So it's just like somebody with a pulmonary embolus. You don't want to send them for testing unless you're quite sure they have a pulmonary embolus or worried about it. And the same is true here. So we want to send the people for these tests who we think we are worried about. So in those groups that we have either MCI or dementia, the sensitivity and specificity of these tests is 90%. It's not the case if the prevalence is lower. So you see if the prevalence is only 10% in a group, the predictive value really plummets and goes to 50%. So you're only going to be right half the time. So this is, again, the big message here is to make sure you're sending the right folks for these biomarkers. The tests are available. You could go, in fact, I'm actually planning to go to LabCorp and ask for it and see what happens just as a learning experiment. I understand they do have it available. We're not ordering these a lot at the university right now. Really, it's the neurologists that are using these. But just to let you know, the Precipity 82 test is about $1,450. They have a test for p-tau 17 and that amyloid beta ratio, and it's only available with a physician's order. Quest has something called the AD Detect. This is available without a doctor's order. And again, I think it would be interesting to do the experiment and just ask for it and see what happens, because you can do that these days. And then there's a number of other labs there that have it available. So, just to let you know that folks may be coming to you saying, "Hey, I got this test. What do I do with the results?" I actually got a call last week from a friend, and she said, she was worried about her parent. Her parents had dementia. She was worried about it in herself, and she went and got this test. So she called and said, "What do I do with it?" So people are absolutely doing this, and I suspect, given your expertise, you will continue to get questions about this. Blood test is so easy. PET scan is really hard to arrange for and is expensive. So, what does the Alzheimer's Association say? They recommend that testing be used by medical personnel who have specialty training and who are seeing patients with memory complaints. So, right now, neurology or people who have geriatric expertise. As I mentioned, none are covered by insurance yet, but we have two different companies who have expedited approval processes in place. So, I expect through the breakthrough device mechanism, these will be available probably within the year. So back to our case presentation. What do we tell Daniel? Should we order the test? So she was diagnosed again in the hospital. She had a 0 out of 3 on her mini cog, and that's a pretty. I mean, that would be a positive screen, right? If you have a 0 out of 3, then you go on to more formal testing. We could absolutely do some more formal testing. I always worry when people are in the hospital. Did they have delirium? Were they anxious? Is this really a good test? A good test of what's really happening in the real world? So we could absolutely do some more and should do some more testing with her. But the mini cog is pretty good. And so as far as advising them on what would happen if they got this test and then they were trying to use that for her future, we really have no idea how quickly, of course, the dementia will progress. Let's say her test is positive and looks like she will go on to develop Alzheimer's. Is that a year? Is it 2 years? Is it 10 years? We absolutely don't know that yet. So the value of that may or may not be useful. She could have a blood test. It's available. They could pay out of pocket for it. And so if that information would be helpful to them, they could absolutely seek it. So I'll just let you in your own mind answer the question of whether or not you think this would be helpful or harmful. I would worry that positive test would give more ammunition to the sister who wants to meddle in this relationship, and so I'm not sure that that would be helpful, and probably would end up following clinically and trying to keep this really lovely relationship that mom and her daughter have alive and well. So that is our biomarker presentation. So I hope that's helpful to you as you get more questions about this. I think there's no question this is going to be more and more a part of our world, and so it's nice to know what the early data are so that you can keep up on the literature. So that's it. Okay.
Thank you very much, Dr. Levy. At this moment, I just want to introduce you all to the gentleman at the back of the room, Adam Euros with Cloudwave Solutions. He's managing our AV today. So thank you, Adam. And I heard that there's some sound issues. Just let us know. We will be working a little bit on the sound during the break. At this time, I'm going to invite our next speaker up. You guys know that we're CMDA, the Colorado Society for Post-Acute Long-Term Care Medicine. We are the Colorado chapter of PALT Med, national organization, Post-Acute Long-Term Care Medical Association. And you may not know this, but right here in the room today, we have some past presidents of PALT Med. We have a couple of future presidents of PALT Med. And our next speaker, who is going to talk about stewardship of antithrombotics, is the current president of PALT Med, Dr. Sabine von Price.
Let's leave that. So that we're dealing with tech. So it's you can just okay. Well, good morning, everyone, and I am so excited to be at Colorado and be at this beautiful meeting. Colorado, you look beautiful. You're wonderful. More in front. Oh, okay. Maybe I'm taking that off. Okay. All right. So, congratulations on your 30th anniversary. You are one of our strongest chapters, and I'm just so excited today to talk about antithrombotic therapy and antithrombotic stewardship. That is an evolving concept that we'll need to take notice of. And before I do that, I just want to make sure that I have no conflict of interest, and I want to acknowledge my contributing authors here, Dr. Orr, a cardiologist working closely with PultMed, Dr. Ott, who set me up beautifully with her presentation last year, and then my new best friend, the pharmacist from the Anticoagulation Forum, Darren Triller. So, what I want to I do today, I want to talk about three things. First of all, we're going to go through guidelines of antithrombotic therapy. But second, and most importantly, I want to show you that antithrombotic stewardship, this concept, is a vehicle for you to implement those guidelines in a safe and effective manner. And then, what is always important, and I'm a little trigger happy here. But what I want you to be able to do on Monday, if you so choose, have tools to implement antithrombotic stewardship. And to get us all started, I'm going to start with this case that of a patient that I'm going to call Mrs. Woodruff. She was a 92-year-old dementia patient who had been diagnosed without a blood test, I'm sure, with Alzheimer's disease. She was fairly healthy. She was living in a assisted living, actually, in memory care, and was only on a few drugs: aspirin, 81 milligram, B12, levothyroxine, and vitamin D. She loved to walk, and one day the aide heard a big thump, found her lying on the floor, being unconscious. She regained consciousness, and she was found to have a slight bump on her occiput with a little bit of skin tear. 911 called. Of course, she refused to go adamantly. So, what did we start? Neurochecks. And the neurochecks were normal initially until they weren't. After about 24 hours, she leaned to the left. She was unable to walk. She was then transferred to the ED. And the CT scan of the head was pretty dramatic. She had three intracranial bleeds, including a subarachnoid and a subdural hematoma. She lost consciousness, was put on hospice, and expired within 48 hours. And um, she was on aspirin, 81 milligram, for 20 years for primary prevention. So let's look at what we know about adverse drug reactions to antithrombotics. So here's this study is going to cover ED visits related to AD. And what you see here in the last 20 years, we've made some inroads with antibiotics and with prescription opioids in ADs. But what you see here is that we have not done that in with antithrombotics, and in fact, it is getting worse. And that despite the fact that we've had two initiatives for medication safety. So what has changed? What has changed? What do you think? Think it in your mind and then see whether you got the right answer. Yes, Stoax. Stoax came on the market, and that's kind of counterintuitive a little bit because we all think drugs are safer. But drugs are prescribed more often now. They are very potent medications. We have seen an increase in prescription over the past years from 1.5, 5.6 million per year, in the anticoagulation form estimates that we're going to see an increase double or triple until 2050. So, what is happening right now that antithrombotics are the number one contributors to ED visits for adverse drug events. And looking at all settings, there is evidence that anticoagulants are causing adverse drug events, and 50% of those are considered preventable. So, what do we know about our space? What do we know about PALT3? And this is a real interesting study. From multiple perspectives, it was published in JAMA last year, and it looks at patients in 709 nursing homes in this country who were diagnosed with AFib and had no indication for an antiplatelet. And here is what we find. There are two aspects of this, which is interesting. One, 45% were on antiplatelets without indication, and 12% were even on dual anticoagulants without indication. On the other hand, there were almost 30% who weren't treated at all. So, friends, we have some work to do. So let's take a step back and look at our guidelines. And just a disclaimer, guidelines are fluid. They are always changing. So don't keep this in your data bank for the next 5 years. But these are good guidelines to remember. And these are the current chest guidelines. When you do your antithrombotic stewardship, look at those. So VTE, thromboembolism, what medications are recommended? Well, number one, the medications that are recommended are DOACs over warfarin. Number two, if you have cancer, low molecular weight heparin is recommended over any other anticoagulant. How long, and this is always where it comes down to, how long should we treat patients? So if they have a provoked, at times an unprovoked DVT, treatment duration is in general 3 months. Now, this is always in general 3 months. If you have a pulmonary embolus, it is there is no stop date unless there's a high bleeding risk. And how do you figure out a high bleeding risk? There are not only tools, but there's also an app. And I promise I have no commercial interest in this app. But this app, MedCalc, which is free, gives you a ton of great tools. And the HASBLAD score of 3 will indicate that your risk for bleeding is higher. So and I didn't do any fancy polls here, but let's talk about Mrs. Smith, which some of you may know from the Derive to Deprescribe initiative at PubMed. Mrs. Smith. So it's a fairly typical case, I would say. She's 86 years old. She's a retired school teacher, and she has been in your facility for 3 years. You recently took over her care, and she has advancing dementia. Her MMSE is 12, and she was initially transferred 3 years ago after a fall and pelvic fracture. Other diagnoses includes hypertension, depression, obesity, and a history of DVT after her pelvic fracture. Ambulatory status is getting worse. She can only ambulate with one person assist and a walker. He has involved daughters, so that's a strength. She is DNR, but otherwise full treatment. Her systolic blood pressure is in the 110 to 120 range. He has fallen twice, attempting to get up without help, and the DON and the case manager are asking you and the pharmacist to look at her. So here are her medications: amlodipine, donepezil, aspirin 81 milligram, apixaban 5, BID, pantoprazole, vitamin D, B12, trazodone 50, and escitalopram 10 and bowel protocol. Which of the medications would you prescribe? I'm going to give you a second, and I'm going to ask for a show of hand. Very high tech here. Aspirin. Anybody would prescribe aspirin? Some hesitant. Yes, we got some hesitant. 10%. How about apixaban? People are very hesitant. Okay. How about both? Yay. Okay. All right. And neither. Anyone for that? And then a bonus question, of course, would you prescribe others? And the answer is yes. So the recommendations was stop apixaban. Why? The TBT was 3 years ago. No further indication, and it was provoked. No further indication. Stop aspirin. Yes, because it was for primary prevention. We'll talk about that in a second. And then these are all the other opportunities we have in her case. So let's talk about antiplatelet. We talked about anticoagulants. Now we're going to talk about antiplatelet therapy. Folks, this is very complicated, and I need another 2 hours to dive really into it. I want to just talk about the most common scenarios that we see. Cardiac stents, bare metal, dual antiplatelets 1 month, then aspirin indefinitely, drug-eluting 6 months, then aspirin indefinitely, acute coronary syndrome, dual antiplatelet therapy for 12 months, not longer, then aspirin, cardiac stent, dual antiplatelet, carotid stent, dual antiplatelet for 1 month, peripheral artery stents for 1 to 3 months, then TIA, single antiplatelet only, but then that indefinitely, and then stable ischemic heart disease, aspirin indefinitely. So these are secondary prevention and acute treatment. Primary prevention, not indicated anymore in patients over age 60, and that's based on several studies who've seen bad outcome and no benefit. So here is where it gets difficult. What if you have somebody on secondary prevention with an antiplatelet and then they now need an anticoagulant, or the other way around, you have somebody on an anticoagulant chronically for atrial fibrillation and something happens with their heart, what are you going to do? And this is where the art of medicine comes in, and no AI is going to help you with that necessarily. The general principle here is, regardless of the underlying condition, ultimate goal is prevent thrombosis, however, also managing risk. And that is probably not going to be where you are making the decisions without help in the long run. So there's many charts like that. I have some that are much more complicated. Don't want to go there, but this is one where we are dealing with triple anti thrombotic treatment. And just the take home here, triple antithrombotic treatment, not long term, not now, not ever. But there are indications, and you have to know about this. And when a patient comes to you on triple antithrombotic therapy, you really need to know when to change that and stop that. So patients with chronic coronary artery disease who have had a PCI and now need an oral anticoagulant, triple NT therapy is required for 1 to 4 weeks. If the bleeding risk is to be, or the thrombotic risk is felt to be high, it can be given at the longer part of that 4 weeks. And uh, uh, so and when you have a patient who had elective PCI and the thrombotic risk is considered low, patients can be continued on an oral anticoagulant alone after 6 to 12 months. Another really important thing to remember, if you have dual or even triple antithrombotic therapy, the risk for bleeding is very high, so you do want to add a PPI. This is where a PPI is actually indicated. So when you talk anti-thrombotic stewardship in these situations, which are complex, here's what you need to know. What was the vascular event? When was it? Was it 3 months ago, 6 to 12, or over 12 months ago? What is the thrombotic risk right now? And what is the bleeding risk? Can you figure it out? And can I give you like the global overview? Yes, I can. But here are two things. This is very complicated. Your pharmacist can probably help you, but these are high risk patients, and you want to be doing two things. One, you want to know who the cardiologist is so you can stay in contact. And two, when those patients come into your facility, and if you take nothing else away from this talk, is have a plan on admission. And that's your best time also to contact the cardiologist and develop or cement a plan, or get his thinking or her thinking what the plan is. So here is our new partner at PulpMed, the Anticoagulation Forum. Darren Triller, who I mentioned, is really a part of that. We're so excited to be working with them and developing tools, calls for us all. So if you ask my why, that's my why. That's why I'm doing all of this. If there's a gap in care, if I can fill it, if I can give patients best possible care, that is my happy space. So Anticoagulation Forum developed anti-thrombotic stewardship And guess what? It looks kind of familiar because why? They stole it from antibiotic stewardship, and why did they steal it? Because it works. That's why they stole it. So you have seen this pyramid before, but you basically advance education, you facilitate transitions of care, you perform data collection, you implement systemic care, and you engage the disciplinary team. One other thing, and I don't know how many administrators are in this room, you have to engage your operators. If you do not, medical director, you are sunk because it is really, really important to have that operator on your side, and you have to make you have to make the business case for the operator. You know, this first case that I showed you was a legal case, actually, very expensive. Anytime in my facility somebody's on aspirin and they hit their head, they buy themselves a trip to the ED. Very expensive. Uh, you know, not that administrator only think about cost, but when cost and good care coincide, that's another one of my happy spaces. So you need to be able to speak the administrator's language as well. So anti-thrombotic stewardship, who are you gonna call? Oh, come on, you're taking my right. Ghostbusters, no. But that's what I got from the last audience. They said Ghostbusters. Okay. No, it's not Ghostbusters. These are my Ghostbusters right here. This is my team at Seattle Medical Center, Seattle Post-Acute and Medical Center. This is the fuzzy guy here that I'm making a picture of on the screen is the essential member of this team, my best friend, Grant Walker, the pharmacist. And to the left, you see our medical staff, Dr. Petrillo and PA Nuri, and actually our social worker. Our DON was on vacation at that time we took the pictures. But our social worker actually can help with families and history taking when we don't know why the hell somebody is on a drug. So great team. Um, uh, Initial targets for us was dual antithrombotic therapy, anticoagulants, aspirin. That should be a target for all of you since the guidelines change. And then can be very facility specific. And here's what you're going to look at when you ask yourself questions. Which antithrombotic or antiplatelet or anticoagulants is a patient on? What is the indication for each medication? When was the inciting event? What is the bleeding risk? And then you come up with, is this medication still indicated based on treatment guideline? Is it the correct dosage? And are there other medications on board that are contraindicated? So I'm going to just present to you what we did. You saw this team here, it's as simple as that. We all sat down and we looked at all patients on anticoagulation. We reviewed 8 cases. Required action was in 5 cases. One was a cardiology referral. One was stopping aspirin. We needed to clarify the diagnosis, and one patient remained with an unclear indication. It's a really scary situation to discontinue something at that time. Dual antiplatelets. Um, we had 2 cases, and we did not know why they were on dual antiplatelets for an extended period of time. One was then a mutual decision making with a cardiologist, but what we did do, we started her on a PPI. Then the other facility that I'm presenting here is again anticoagulation. We recommended to stop ibuprofen. We switched from Xarelto to apixaban, and we decreased the dosage. So it's not just is the medication indicated or not, but is it the best medication that you can give? And then dual anti-thrombotics, again, many cases where we were unclear, and we did a lot of cardiology referrals in that case. And then we reviewed all our cases on aspirin, and we had 2 cases where there was no indication, but the patients were diabetic, and we felt that looking at tools that the risk for ischemic disease was so high that we kept them on aspirin, and 2 patients we discontinued because they were for primary prevention. So then we did all that, felt really good. And then I said, we got to do more. We got to do more. Let's think, what would antibiotic stewardship do? A line listing. So again, our friend, the pharmacist, put together a line listing, and it's basically an Excel spreadsheet. It looks, and I cut off the patient name. It looks at the medication, dosage, the indication, the start date, and then we have notes and when it should be ending. And then I said, well, we need to do more. And and the next step is every antithrombotic will be reviewed on admission, and every antithrombotic will have a plan upon admission. So that is where we are at right now, folks. You can certainly do that. So what's next for you? I have to say, do something. Work collaboratively with your pharmacist and DUN. Make the business case with the administrator. Review your patients on antithrombotics. It doesn't actually take that much time. That's the other beauty. It didn't take that much time. This was 3 hours worth of work over 3 weeks. It once a week for an hour. It isn't. It wasn't taking that much time. Here on the right is this little pyramid. It is my favorite little visual. You might not be able to see it, but it's basically saying the administrator, medical director, and medical staff, and the DUN work together on a patient problem, on a care gap. There is nothing that you cannot achieve. And that's my plea to you. And now I'm going to entertain some questions.
That was great.
Thank you, Dr. Von Price. We have a few minutes for questions. So, would you like to come up here, Dr. Plachta, or I'll meet you halfway?
I heard through these slides and I was at 20 minutes.
The dose for secondary prevention for aspirin, should that be at 100 milligrams? The question being mostly, so if you ever see 81 milligrams, should anybody on that in our setting?
So, from what I know, so the studies show that the dose for secondary prevention should be between 75 and 100 milligram. So in the United States, my brother just got put on aspirin, 75. In the UK, that's apparently a standard dose there. But in the United States, it's 81, not 325. Okay, that's another thing. I also want to refer you to Pulse Connect, where we had a podcast with Dr. Orr talking about all about aspirin. So if you want to, and it's from last year, but I think it's still valid. So if you want to look at that, make a plaque for Pulse Connect over there.
Presentation. Could you describe any advice about use of SSRIs when they're on multiple other anticoagulants? Then selective serotonin reuptake inhibitors affect platelet aggregation, and they're not maybe as strong as aspirin, but they do cause increased measurable risk of GI bleeding, cerebral hemorrhages. So, what do you do with SSRIs when they're on these other?
You know, I have to say, I might have to refer this to the pharmacist in our audience or to the psychiatrist in our audience. I think we are all. I am not aware how strong the interaction is, but that is why you want the pharmacist in room. And then it's a question of what is most important. Is antithrombotic management more important than possible treatment of depression or anxieties? That will then again be a shared decision making. But for those kind of questions, it is invaluable to have your pharmacist really tell you the studies that are out there and look at whether this is applicable for your patient.
Thank you for your questions. Oh, is it Dr. Quarles? Come over and meet you halfway.
A common scenario we see in our world is elderly patient who did not previously have a diagnosis of AFib goes through maybe sepsis or some sort of a major medical event that results in hospitalization. They have a run of AFib in the hospital. They're then diagnosed with paroxysmal AFib and started on anticoagulation. their health deteriorates to a point where they come initially for some skilled rehab, transition to long-term care, and their goals of care are such that they don't want to be going back out to cardiologists and having additional studies. Is there any good data about really understanding whether they truly have paroxysmal AFib ongoing when it was limited to one acute severe health issue, a sepsis episode?
Yeah, and I think you bring up very important points. I mean, the treatment of AFib certainly, first of all, is changing. So that's really so maybe we won't need all these anticoagulants because nowadays we are doing early intervention. We are not doing the rate control only model anymore. So we're looking at early intervention and secondary. This is a conversation with a cardiologist. They may not want to go out there. Have you thought about telehealth? Or just plain old consultation with a cardiologist. And then remote patient monitoring would be one other way to look at it. And what is the bleeding risk of the patient? So these are all factors. Do I know all the studies, the cardiology studies? This is where I wish I had Dr. Orr with me on the panel, but I don't. But it is a very good question. Should this patient who had AFib in a specific setting be basically condemned to lifelong anticoagulation? And that's part of antithrombotic stewardship that you ask that question and then pursue the answer with the appropriate specialist.
Thank you, Dr. Rumprice.
Thank you guys.
Great job. So I know all of you are planning to stay here for the whole day, which is great. But in case you weren't, just wanted to make sure you know that the way to win a raffle prize today at the end of the day is to get your raffle card signed off by each of the vendors, turn in your card, and be here when we draw the winners at the end of the day. We also have cupcakes for each one of you, decorated with the CMDA 30th Annual Conference logo. So be sure to stay for that as well. At this time, Alicia Smith, our board member, will introduce our next speaker, our keynote speaker.
Hi. I'm going to be introducing our keynote speaker, Dr. Ann Basting. She is a writer, an artist, and a professor of English at the University of Wisconsin in Milwaukee. And she is the founder of the award-winning nonprofit timeslips.org. She is the author of numerous articles and 4 books, which all focus on the topics of elder care and dementia care. She has also produced a dozen plays and public performances. Today, Dr. Basting is our keynote speaker, and she will present her talk entitled Creating a Fabric of Meaning in Long-Term Care. I would also like to mention that Dr. Basting's presentation is co-sponsored by CMDA and the University of Colorado Division of Geriatrics. Welcome, Dr. Basting.
Hello, good morning, everybody. I was going to talk about meaningfulness, but I'm really fascinated by the DOACs. So if we could just keep talking about those for another hour, that'd be great. Just kidding. Just kidding. That was a wonderful presentation. I learned a lot, actually. I really want to start by and I also am going to wrestle this microphone to the ground. So if anyone, I'm going to win this contest between the not being able to hear parts of it. If at any point anyone in the room can't hear consistently, just wave and I will come back right to the sweet spot in the middle. Okay, so just let me know. I also just really want to take a moment and thank Rebecca and Singh for really making a humanities scholar and artist feel comfortable. I will say it started with a bit of a jump scare with an errant email asking me and saying, we're so excited for you to share your wisdom about detecting early sepsis. And I almost had a heart attack. I thought, I don't know if I can do this talk. But we got through it and I felt really comfortable. And I just feel very blessed to be in a room with people so committed to their why. And this is, the bulk of my work as well. 30 years working really to find the reason for being for people living term care, uh, cognitive disabilities or not. And so sharing this room with you is a real blessing. I will say I was a theater kid, um, and I loved it so much that I went on and got a PhD in it. Um, I was not in it for the stardom. In fact, I ran away from that. I was really in it for this beautiful thing that happens, which is that theater is the ability to make something out of absolutely nothing, right? So we are in a room right now, and I can just pull this butterfly wing out of the air, and I can pull another one from over here, and I can put them together and watch it fly away, right? We are in the realm of imagination in theater between people who share um, human presence. And in some ways, that is exactly the work that you do every moment. Um, Theater, all you need is imagination, another person. And that is really it. For a long time, I just retired as a professor of English from the University of Wisconsin Milwaukee, moved down to Atlanta. But so I'm embarking on my next endeavor. I quit one of my three jobs, so I now only have two. Um, but I taught storytelling, which at university is really just an acting class for students whose parents won't let them take acting. Yeah. And I would do this exercise with them that was, I like to use the image of an old fashioned lamp that has a string pull, those, right? And we would start out with this exercise of a light on, light off, light on. You can do it with a breath too, and light off. And I know this is actually what you do, whether you know it or not, the moment before you open the door to see a patient is light on, your presence is illuminated, or light off. I have to focus on a DOAC, like, right? Um, so it's really, that is sort of the bulk of the work. Um, and that actually is the essence of my work for 30 years, figuring out how to turn on that light, to invite another person to turn on theirs and to have that exchange, um, to come and play with, to make something out of nothing, which is just two people in a room together. That something out of nothing is called a lot of different things. It can be called connection or shared meaning, understanding, love, whatever it is that sparkle between the hands. So, what is that invitation? That really elegant invitation that can get someone to come play with you, to open up and turn on their light, which is really the only way you can tell who and where the person is in a given moment. What is that elegant invitation that helps tickle the person's curiosity into trusting you and playing and exchanging with you? I have a beautiful question. Would you like to hear it? Right? I'm going to do that again. I have a beautiful question. Do you want to hear what it is? See? So I arrived at that phrasing after a project where we worked with meal delivery through Meals on Wheels. And we were trying to do an arts based engagement, meaningful engagement, just with the meal drivers and with the well check callers. And they started by saying, these people want to do an arts project with you. Do you want to do it? No. Boom, every door. boom, 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 boom. Um, I have a beautiful question. Want to hear it? Of course I do, right? So boom, 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 boom. All the doors opened in the opposite way. Um, so that is what I'm going to talk to you about today. This tiny little communication loop. It starts with a beautiful question that comes after lights on and opens up the process of engagement. There's a couple of key principles before I do. Look, I haven't even started my slides. Holy moly. Okay. Um, Creativity, and I say this to a room of people, usually nurses are the people who are the most, have the highest tendency of saying, I'm not creative. I don't know why that is, but it's true. But I'm here to tell you that creativity is an innate human capacity. Somewhere along the line, maybe somebody told you you're not creative, or creativity can feel dangerous to people who are supposed to follow checklists. But creativity is an innate human capacity. Story is how we remember things. It is how we make sense of ourselves in the world across time. It is how we understand each other. I love how you guys do story and case studies all the time. This is what you're doing. The arts are point number 2. The arts are an emotional and symbolic language. You can use sound, you can use movement, words, expression, line, color, smell, light, objects. All of it is used in communication. You're already using it. You just might not know you are. It is just an emotional and symbolic language. Point 3, and my my guides here are going to be mad because I didn't put any of these points in my slides, so I can resend it out. Co-creation is just making something with another person. It involves shared risk and shared vulnerability. So one of the books I did is called Creative Care, and it is the sparkle between where you're making something new together. It only comes out of shared risk and shared vulnerability. So last point, and then I'm actually going to start the slide. While I was preparing this talk, I also happened to be reading a book called The Last Human Job by Allison Pugh. Has anybody read it? You're about to get a lot of snippets from it this morning. So it's fascinating. And I think she actually puts her finger on what's happening in this cultural moment. Um, I was just a mad woman with a highlighter while I was going through this book. And I include pieces here as interstitials in my own artistic way, which you'll see in a moment. I also happen to be a big believer in that point of connection across distance in a very old fashioned way called letters and postcards, if that gives you a hint. Okay, now I will put this down because that was all new this morning and start. There we go. Very first one. Dear humanity, in a crisis of depersonalization, the demand for human connection at the point of service can feel frantic. Last human job. So these are the old guiding questions. What does meaning making feel like? What are the steps of meaning making? Okay. What is connective labor? What are the strategies to support the flourishing of connective labor? In other words, a fabric of meaning making in our work. I'm clicking it so many times. I'm not sure if I'm wrong. It'll go. Good. I'm going to do flamenco. Okay, wait. Now I went too many times. So I'll just start with a beautiful question. You asked for it, you have it. If you could look outside a pretend window at this moment and see anything you wanted, what would you want to see and why? Just give it a thought for a moment. Sometimes closing your eyes and seeing out the window helps. Does anyone want to just shout out what they got? Who wants, yeah, a mountain? They're there, aren't they? In this city. Anything else? The beach? My kids playing? Anything else? My parents. Yeah, the magic of these questions is that it can be anything. All right. Thank you for playing. We'll come back to this. This is very strange dance that I get to do.
Yep.
Okay. Oh, I can point to you. Okay. Dear humanity, as interpersonal work becomes ever more scripted and automated, being able to have a human attend to your needs has become a luxury good. This actually inspired me to make a luxury brand for human connection, which is really kind of cool because my collaborator happened to be doing something at guiding performances at Hermes. So while we were thinking about this, we were sitting at the Hermes store on Madison Avenue in New York, drinking from Hermes teacups. And yeah, it was pretty funny. Okay, next. This is it. This is the little cycle of communication, starting with a beautiful question, yes, and offering proof of listening. Okay. This is much more efficient. Tapping. So, beautiful questions. What are they? I, of course, have these on a bunch of little, you can just keep going. Oh, I was failing. There you go. So they have no wrong answers. They invite us to express our strengths. So if you don't have words, it's possible to do this with sound or gesture. At least most exciting work that I do in advanced dementia, definitely with sound and movement. Beautiful questions invite us to reimagine our world a little differently. They invite exploration of the senses, and they are not yes or no. Yes or no, this is often the hardest possible thing for people, particularly if you're trained to ask questions that limit options for people. So, would you like this or this? I'm guiding you toward helping you with cognitive challenges to limit the options to make things less confusing and supporting you in that way. This is the opposite, where it opens up more poetic expression. Go ahead. Let's sit here together, actually. Yes, and. So, does anyone do improv here? Okay, well, we're going to do it in micro. And don't be afraid. It's simply accepting what's given to you in the moment, which you do anyway, I'm sure, and adding to it in a positive way. It is not yes, but it is yes, and, right? This you can see often if you see people with dementia with a family member or a caregiver, whether it's a child, an adult child, or a spouse. Oftentimes you'll hear the yes, but from them because they are rabidly trying to protect who the person was, right? And so if any sort of error in speaking, what he means is, you don't mean that, you mean this. It is an acceptance of where the person is and adding to it positively instead, which is a really radical way to help the person trust their own expression more, to move more into communication and expression. Whereas yes, but is a way to get them to silence themselves and edit themselves into silence more quickly. Go ahead. So, what is proof of listening? These are techniques I am sure use every day, which is echoing. It's really just a way to make the person know that they've been heard. Any way you have to do that. facial expressions, writing it down so that they can see it. You probably don't have time to do this, or you're writing it in the medical records. But for social workers or people who use this technique more broadly, you can write it on a big piece of paper so they can follow you, and you invite correction if you have it wrong. You change your behavior in some way, you respond to what they're saying, and again, inviting correction. Interstitial. Dear humanity, connective labor is how we see each other and how we convey to the other that they are seen. Allison Pugh really sets up the difference between emotional labor and connective labor. And connective labor is what she describes as what will be the last human job. So hopefully we'll all be on that list, right? Go ahead. So the other thing that I talk about is the art of the follow-up question. And I'm just going to skip ahead with this because we'll see this in action shortly. Belonging is crucial to human thriving. Psychologists say almost as compelling as a need for food. Head. All right, one more beautiful question. If you could, and I always do it like this so people don't think they're buying a plane ticket, because it's not this, it's this. If you could lift your arms and fly anywhere right now, where would it be? Just holler. Brazil. Oh, God, that's a good one. The Maldives. I think we need a big plane, everybody. We need a lot of. Anybody else? Just one more. Hawaii. Thank you. Heaven. Right? There's often a lot of people we want to see. Go ahead. So why beautiful questions? Go ahead. Between us, the person trying to help an older person who might be experiencing cognitive challenges, there's all kinds of things that get in the middle. Hearing, memory, capacity, executive function, a lot of families with denial, just the speed with which we're asked to move and live our lives, fears, and grief, particularly between family members. You'll see. Go ahead. There's a couple pieces on here. And the impulse is to ask a person, do you remember? Essentially, what this is doing is shifting us from that to imagining together. So it's shifting from the expectation of memory to relieving that expectation. And a really funny thing happens when you relieve the expectation of memory is that the person has a lot of different pathways that they can use to express themselves. So it just opens up a whole realm of communication that was otherwise shut down. And here is a quote that I really find enormously helpful for what is at the root of sort of a social determinant of health, clearly isolation and loneliness. Carl Jung once said that loneliness is not the absence of people, but the inability to express what matters to you most. And if you can imagine, particularly dementia or isolation, where you feel as though you can't get it out, no one takes the time to listen, people don't have the methods for listening or to elicit it, that profound sense of loneliness can take hold. Finding that expression with words or when words fail with movement, sound, or the framing of an image triggers a biochemical response that generates connection and pleasure and awe. A lot of new research about awe is anti-inflammatory, which I love. And it helps us find meaning and perspective. This allows us to create a pathway when we may have felt the future was uncertain. And that's Christopher Bailey from the Now, the disconnected World Health Organization and the co-founder of the Jameel Arts and Health Lab, which is also at YU. Okay, go ahead. So, what can you use? How do I think of a beautiful question? Where do they come from? What is a prompt? This is a little add on to that little simple cycle, which is that there's just something you respond to, that you ask a beautiful question, yes, and listening. And then there's possibility. This is where I see the fabric happening, is the product that demonstrates the commitment and value to the person. And you may be thinking, how do I, my limited time with a patient with so much to do, how am I making that fabric? I'm asking people to think of the larger network that they're in, that triangle of people that working with who are all part of that delightful team, and how that group can think about how they could make this as part of a larger fabric of meaning. The beauty of this, and I didn't even have a slide of this because it just came out about a week ago. There's a randomized controlled trial that our methodology, this communication loop happened to be part of, also with visual art, that said in that randomized control trial that 12 weeks of intervention with caregivers and a person with dementia reduced caregiver stress and burden, as well as improved quality of life for both the caregiver and the person with dementia. So this is one of those rare interventions that serves both the provider, caregiver, and the person they're caring for. It is a relational benefit, which I think we don't, maybe now we have the ability to do joint, fMRIs at the same time to see what's happening across that relationship. But we usually test an intervention on the individual. We don't test it on the relation. And I think that's what we're missing. When we overlook the benefit of these interventions. Go ahead. So, what is a prompt? Go ahead. Really, it's anything that tickles your curiosity. One of my favorite things to do in really boring conference rooms is just say, look around the room and just find a shape that interests you. Any shape at all. I mean, there's honestly not that shapes to choose from in here unless we look at each other, which you can do. I mean, the most interesting thing is your jacket. Thank you very much for wearing it. I really have to say, but any shape at all, and then just trace it with your finger. Okay, this is a weird shape here, but I'm going to do it. Okay, I won't make you do it because I'll run out of time. But this exercise I usually do is then have you trace it with your hand, your full arm. We teach each other at the table all those movements in sequence, and then we watch each other do the movement. Sometimes I'll even press music, and it becomes the most beautiful choreographed dance you've ever seen, just from a totally boring shape in a boring conference room. And the room fills with laughter and joy. I promise this would normally happen. No, I'm not kidding. Um, and it just, again, like pulling butterfly wings out of the air, you can make something out of absolutely nothing in the room. Just anything that for some reason tickles your fancy. So it can be an object, it can be something out the window or something out an imagined window. It can be a song or a sound, a shape. It can be something someone is wearing, an image, anything that tickles your curiosity and invites a sense of wonder. So the wonderful thing about the people who are working in long-term care settings or independent living or assisted living, memory care units, any of those things, they have all kinds of prompts on the walls as you're walking down the hallway. People have them in their rooms if you're doing room visits. The window, you can just look out the window. The window is a prompt. It is a way to open up a moment of expression just by pulling something in, asking a question about something you're seeing. Go ahead. At the root, we are really simply just talking about creative play. adding something new to the world that has value, which is my definition of creativity based on a couple of wonderful people, Gene Cohen included. Again, reminder that it's an innate human capacity and that there's a lot of research on this about creativity and the flow state, reducing stress, deepening connection by reaching a flow state. One of my favorite, it's definitely anecdotal, but it came out of it's actually a qualitative interview with somebody who participated in a big project that I did many, many years ago now with an entire long term care community, all levels of care, reimagined Homer's Odyssey together through a series of creative workshops that involve family, invited family to co participate, volunteers, professional theater company. And then in the end, we staged professionally produced performance, site specifically through all levels of care for an outside paying audience. I've done this a couple of times. It's kind of crazy, but it is totally a beautiful weaving of fabric of meaning in the course of people's lives. In one of the interviews, someone came up to an older adult in the skilled nursing area and said, "Did you enjoy participating in this project?" And she said, "Yes, it's the last important thing I'll do." And it makes you wonder, what are we doing with bingo? Do they really need the muscle reflex work with the balloon or the parachute? What is the fabric of meaning we're allowing themselves to build and connect to? Gosh. Here's a really simple one that sort of echoes the question that it was the first one that was asked. What is your why? When do you feel joy? Right? In some ways, it's now a social determinant of health. We should all be asked. Go ahead. So, first, I have to explain that I've been experimenting a lot with AI. And so I asked AI to make a stopwatch that said 30 seconds on it. And we've got that is what you see. That is how much to trust AI. So I know that you have a lot to do and you have a lot of people to see and you have a very little time. We did the same thing with the meal drivers who have 300 meals to deliver in about 3 hours. I mean, it's shocking how fast they have to do this, and the meals are hot. So let me just tell you, um, can you embed an opening connection, meaning making in some way that might deepen your connection? If you had the gift of those 30 seconds, what question could you imagine asking? Go ahead. And what if, as a team, you could gather those 30 seconds and make something out of it so that the person knew they were part of something bigger? It wasn't just your exchange, but they're part of something much bigger. You're probably like, what the hell are we talking about? But I'm going to give you some examples. And the example of the accumulated workshops we did, all inspired by themes from Homer's Odyssey. I did another project with 12 rural nursing homes across Kentucky where we retold the story of Peter Pan together over the course of a year. These are just some other projects that are smaller and simpler. You don't have to do an entire staging of Peter Pan. Go ahead. So here's the feedback loop that you would be creating. Beautiful question, response. Who's going to ask, who's going to get it? Gather and share them, and then share and celebrate it so that the person you asked knows that they were part of that in some way. So they have to be able to see it in some way or experience it. So that's the feedback loop. Go ahead. Here's how you build why you do this. building and evolving those relationships over time, even though you're only seeing a person a couple of times, it acknowledges that the person is capable of growth and learning. And I think this is what we give up in post acute care. There's a real discomfort with inviting people to learn and grow over time if we think they might not make it to the celebration. But the celebration becomes a living memorial that holds everyone's impact and honors the dignity of who they were in their lives, even if they didn't make it all the way to the end. It builds community over time. It allows more people to learn about it and enter, particularly family members and staff that might not otherwise be engaged. And it allows for a culminating celebration for people to really participate in. Go ahead. Go ahead. Skipping over this, getting to so ways that you could evolve joy, that question, do an ode to joy. Odes are very common poems. You can just combine people's answers into an ode to joy. Joy journal that everybody could contribute in. If it's at a long-term care community, it could be at the front desk. It can be on a whiteboard. It can be anywhere. I love miniatures. I love doing things like blowing up scale, making small things big and big things small. Um, Drawings, even stick figures. I've been trying to do a drawing a day and I'm terrible at it. So that is my gift to people for encouraging their creative confidence. Layering stories with movement and sound, particularly for people who can't use language. Go ahead. This is all pretty much, I've said this already, but playing with scale, creating characters and stories, and exploring the senses. Go ahead. Go ahead. I'm actually going to skip this one. Go ahead. There we are. So I'm just going to ask you a beautiful question about this, which is, do you have a story about a button? What does a button make you think of? Right? Oftentimes when I ask this question, answer is a grandmother who had a Band-Aid box, a metal, for some reason they were always metal Band-Aid boxes full of buttons. It's a very common thing to it, and the sound when you would shake it, right? Just even buttons as a sensory thing to have, triggering stories. Few words that come out, just say 3 words in response to the button. And there was an artist who did an installation that I saw that was a wall of buttons that people brought. Could you bring in a button next time I see you? And they made a sculptural wall out of a button. And then the next slide is actually another really cool artist rendering of what to do with buttons. Go ahead. This is just a piece of paper. It's about this big, maybe even smaller, blue circle. Beautiful question might be, what is the emotion that you feel when you see this piece of paper, right? You could also cut out different sizes of pieces of paper, different colors, and do things like that. And then next slide. This is a really stunningly beautiful art project done by an MFA student that I guided. She was actually an artist in residence. She lived in a long-term care community as a neighbor and would do these projects with her neighbors. Just having people cut out circles, tell stories, and have reactions while they did it. And then she made these black frames, and they just made collages themselves in the black frames. And then she put the black frames across the wall. And one of the these things, they level up the game of the arts in long-term care. Let me tell you that. Next slide. So this is origami paper, which is just, you can buy 500 sheets of it for $10 on Amazon. They're really beautiful. Um, what could you do with it? What stories? The same artist did the next project. She simply asked people to bring in an image of something that represents someone or something they love. She had them glue it into the middle and then just make 4 folds. And then she put them up. See, playing with scale in this way, she put them up across an entire wall. And it became the memorial. This was during the pandemic, the memorial to things and people we love. Go ahead. An old piece of clothing. These are prompts. People's clothing are definitely prompts. There's rich quilting traditions where pieces of clothing and the stories of who wore them get literally woven into something we can cover ourselves with, covering ourselves and sleeping under our own family stories. This project is based on an artist who's a friend of mine in Wisconsin named Brenda Baker, who's a curator at the Madison Children's Museum. And she did a project in rural Wisconsin with older adults telling them to bring in a piece of clothing. They dyed it together in a certain color. They had stories pinned to them. And then they did laundry day, which ran in these beautiful patterns across the farmers' fields. And they just put up the clothing and clothespins on the line. The community that gets built out of that is pretty astonishing. And she did another project in upstate New York that was very similar with farmers and farming families intergenerationally, and another exhibit outdoors of clothes. Now, of course, we have QR codes, so you can get the stories right on your phone. Here is how and why it works. We know that having a sense of agency and mastery offers a sense of control in meaning making and choice making. Purpose is actually preventative for dementia. Awe, reduction of inflammation, as I said, and stress. Learning is growing cognitive reserve. Generosity, again, linking to purpose. Flow in the process, which again, linked to reduction of stress. Joy and laughter in the process, and connection and social connection through co-creation and shared vulnerability. You may think I'm talking about this as an intervention for older adults. Y'all are the ones with the 40% burnout rate, right? And despair and burnout. This is an intervention that is relational. Listen. You can click all the way through to that one and keep it there, because I'll just tell you, because it's hard to click through. There's a real magic in how I click through this. You're just going to have to believe me. So when I go to visit my mom in memory care now, I've started doing a beauty walk. It's hard to get her to walk at all or to get out of her room. So I said, all right, Mom, we're going to go 10 feet. You pull your wheelchair with your feet. We're going to go 10 feet and we're going to find something beautiful. And you're going to tell me what it is. Then I'm going to photograph it. And you're going to tell me if I got it right. You're going to look at my phone. And if I didn't get it right, make me take it again. So the first stop was the pine cone. This was at holiday time. It's a gold sprayed pine cone. The next stop was this piece of glass. I don't know why. Maybe it's the curve of the coffee table that she found beautiful. No idea. The upholstery of the chair that actually she cheated. It was only about 5 feet away. And then cheated again. This coffee table that's very strange, but is interesting looking. I had to take the picture of the plants about 6 times because I kept not getting it right. This one is perfectly right. I had to retake the picture of this glass vase because she wanted it right from the top. And then it always ends with a selfie. And then I simply print them in a collage and have them on the wall. And so we can recreate the beauty walk in multiple layers. And oftentimes they look very similar. Not a lot of variation at the care home, but go ahead. Dear humanity, during my research for this book, a pediatrician told me that she was inundated by patient demands. Healing happens through relation, and we're just not doing the kind of caring that people need to heal, she said. But we've lost our village, all of us. Awesome. Actually, I'll say too that I talked with Allison Pugh. I wasn't a stalker, I assured her. Sort of was. And I said, why? She opens with chaplain, hospital chaplain. And there's a section of the book that says Moneyball comes for the chaplains, and that they have to log into Epic just to the medical records, even though their time is not billed. And they have to describe in very outcome-based terms what they're doing. And just the dehumanizing of one of the most humanistic jobs. Like, what are we doing? What are we doing? And I said, you use pediatrics, you use the chaplains. Why wouldn't you use geriatrics and long-term care? And she said, it's the first thing people think of. And I wanted to, and they also shut down when they think of it. So I wanted to actually open it up to others to make my point, but it is exactly what I'm talking about. Go ahead. A deep sense of belonging rests on not just shared sameness, but the purposeful integration across difference. We can be helped to connect across difference through seeing each other, and organizations, clinics, schools, neighborhoods can cultivate the social architecture that enables us to see each other better. Our social health depends on it. Go ahead. Thank you. That's it. I wanted to just have this slide because when you make the decision about whether or not to do the blood test, if part of that, I'm not kidding, if part of that is that you don't know what to tell people, I don't know if you've heard of memory cafes, but I am also kind of a stalker about memory cafes, a little bit obsessed. We're growing the national movement. They are simply social gatherings in the community where people with cognitive challenges can gather with a caregiver. It is respite, it is joy, it is friendship, it is respite together. We created a new national directory that is super easy to use. So people just put in their zip code and can find one near them. And if there isn't one near them, they can start one with 3 free training modules. So we just have been launching this, and I just want to share the good news that memory cafes are on the rise, and they are there for the people that you diagnose. So thank you.
Thank you, Dr. Basting. We didn't have a technical question. Yeah.
Oh, I was worried I was blathering on for a long time, but if you have questions, let me know. Happy to.
I have a question.
Yeah.
I wonder if you could comment on just how your relationship with your mother and care for her has affected your work.
Um, uh, well, it has been a burst of she asked in case her microphone went out too much for you. How, I've been doing this for 25 years, and then my mother gets dementia, and how has that impacted my own work? Every moment I go visit her is a little lab space for me, which is wonderful and challenging. It's made me understand another layer of challenge that family caregivers have. And now moving away from her, I have a new understanding. My primary role now is how not to annoy my sister, which is hard. It's really hard because it's so hard to be a distant caregiver. And then it's been a burst of creativity. I've, like the rest of the world, started a Substack, and I'm writing essays about moments of care with mom in particular. So
Thank you for Would anyone from the audience like to ask a question or have a response? Yeah. Reitman.
Yeah, this is great. This is what we don't have. This is why home care is more important than nursing home care. But what about the poor primary care person in the nursing home, the provider who has all of this digital AI stuff? Is it realistic for us to, de-stress and be, it's almost like a formula that you gave us, and it can become like AI without the emotion. So is it smarter to have a good social worker? I'm sure you've trained many of them to do this and make it a law that every nursing home, instead of a 24-hour nurse on duty, spending 33 minutes with every patient, have a social worker that once a week spends 33 minutes with the patient.
Well, my first response to that is that I would never want to take that away from the primary care people. If they can figure out a 30-second, if you can open yourself to that process, it's actually a process, it's not a script, which is the beautiful part of it. If you really open yourself to yes and, it's different every moment you're doing it. Um, it opens the moment and returns it to you out of automation. So I don't want to take that away, that experience away, because I think it can be soul filling, actually. I would actually say it isn't a social worker. I would wholeheartedly agree with you. I think that long-term care communities can actually partner. Um, I mean, we had artists and residents living in the care communities, right? As neighbors. If there's empty beds that aren't filling, have someone come and live, or just partner in the community. We're training students as volunteers, family members as volunteers, um, putting these methods of interaction and meaning making into the water of exchanges of what's happening. One of the first things that I do when I go into a long term care community is map the assets that they already have and just figure out how to open them and to allow meaning making to take place inside of them. Like like all the pictures down the hallway, let's just put Post-it notes for stories on them so that when you're walking someone to a meal or an aide is just, or you're walking down the hallway, you could write a story based on that image as a prompt so that it becomes, instead of a place where people are managing their health, waiting to die, they are learning and growing and opening up and sharing with each other in a fabric of meaning making. So, sorry, I get a little preachy about that stuff.
Anyone else with any questions? Follow up? Oh, sorry.
This is more of a conversation, I think, than a question. And I'm not necessarily expecting you to have the answer that none of the rest of us have found. Um, I guess to frame my question, I think of myself as a creative artist who has a day job as a physician. Um, and I've been a physician for nearly 30 years, and I worked in healthcare before that. And I've watched the industry and society change. And one of the things that I am keenly aware of is, especially in our environment, the disproportionality of caregiving roles. And any of us who are able to be sitting here in this meeting today, however burnt out and exhausted and stretched thin we may feel, and I'm a sandwich generation person taking care of multiple family members in different stages of life as well. I have all my own personal stories. We all do.
Um, but we're still at the most privileged and protected range of who is working in the caring economy. If I get to know, any of the CNAs in any of my buildings and their life stories, they are juggling a whole lot more with a whole lot less resources to draw from. And what I struggle with is those of us who, whether it's through training or through some natural inclination, have a skill set to build these deeper, more expressive, more creative relationships with residents and with our coworkers, people around us in this world. We are investing something of ourselves on our own time, on our own dime, in addition to the tasks assigned to us by the current framework of the reimbursement system, and there's no offset. And none of us in this room are able today to fix the structure of healthcare reimbursement or the structure of the bigger social questions. So my question is, how do we, as individuals and as professionals, find some sort of a healthy balance between doing the things we're uniquely capable of to enrich the lives of our residents and our fellow humans in general without once again accepting a disproportionate load as compared to the regulatory standards and the reimbursement model expectations, which are in an entirely different realm.
I'm a little shocked to say I actually have a couple of answers to that. I really am sort of shocked. Um, First of all, thank you for the depth with which you were wrestling with what I was saying. I appreciate that. Um, a place that I have found a lot of hope in the last 5 years is, besides memory cafes, um, the model of social prescribing that has been thriving and being tested in countries' national healthcare system. Sorry, where they have link workers that are doing this work of. We have this very false separation between arts and culture world in the community and the healthcare sector. It's very strange why we've done that, and people are studying that, but it's odd. But social prescribing in this country will look very different than social prescribing in countries with national health systems because those systems benefit from preventative public health work. It is not clear if payers would actually, because our system is so fragmented, who benefits from public health efforts and those social connective work. It's just not clear here. So, where do you invest and who gets the reward, right? But they're figuring it out. And it's coming. There's about, I think, maybe now at this point, maybe 50 pilots across the country where people are integrating arts and cultural experiences and even memory cafes. Cleveland Clinic is putting it on the medical orders, which is fascinating. And Medicare Advantage in particular, and for like Optum is behind a lot of these pilots where they're capitated pilots of identifying a cluster of people who have behavioral health issues. And then they're literally prescribing arts and culture for them. And that can happen in the outside world or in a care setting, right? So that to me is a really positive. There's really positive energy coming from the linkages that are starting to happen there in social prescribing. Um, you just Googled social prescribing USA, that's what they called the organization, Social Prescribing USA. That is, you'll see where they have a map of all the pilots. It's really interesting. They're baby steps, and it's a fractured system, as you well know, so it's very difficult to do. The other thing I'll say is that I think it's actually hard work to separate the parts of our lives where we get meaning and practice our work. And it is hard for the CNAs to do that too. And again, one of the first things I do when I go in to a long-term care community is I say, do you know, we do an asset map of all of the creative talent that they already have, that they don't even know they have because they don't even ask about it. And when they're onboarding new staff members, whether they're dietary or laundry or facility, in one of the facilities that we worked with in the Peter Pan project, we called it Wendy's Neverland. The story was that Wendy was on hospice, finishing growing up, and the whole nursing home wanted to retell the stories that she'd been telling them for years because they didn't really believe her, but they wanted to honor her. And it was glorious. But in one of the care communities, we did that asset map. And the staff, the person on my team who came up from the asset map over lunch said, okay, the entire building maintenance team has a heavy metal bluegrass band. So we're going to be using that. Nobody knew. Nobody knew. And in the Penelope project with the Odyssey, we asked we requisitioned an order to paint one of the empty independent living rooms to make it Penelope's room. And we went in this long explanation. Do you think maybe you could do a sky like a Greek island, like with clouds opening? This woman was a crazy talented artist who we felt ashamed that we, woman-splained how to do this cloud that she did more beautifully than we could ever imagine because nobody asked her. And she had to separate that part of her life, and I think we don't realize the effort it takes to separate those. That you must have to separate your parts of your life. I think we're just baby stepping our way into this interesting integration. And when people ask me, they like to say, because it helps them categorize it, oh, this is art therapy. That's how we bill it. That's how I think of it. It's in that category. And I go, oh, it's so much more than therapy. It has therapeutic benefits, and we happen to be using art, but it's in the water. It's in the framework of how we think of what these places are and what life is like inside of them. So, sorry, I think I got preachy again. All right.
Any other questions? Anyone? No?
If you want to see pictures of any of those crazy projects, you can go basting, for some reason there's a dash and basting.com. In the project section, you'll find all of them. They're all there. They're really fun, so might be fun. Thank you guys for listening.
Amazing discussion. We are I believe we're right on time right now, a few minutes before. So we'll take a short break until 10:35 and we'll reconvene then so you all can walk around and stretch your legs a bit.
Getting the next slides up here on the screen soon. Welcome back from the break. Our next speaker makes me think, sometimes when you're at work, you meet people who are mentors for you professionally, but sometimes also personally. Dr. Leah Watson is one of those people, and she is here today to talk about benzodiazepines. Thank you.
Yeah.
Love you so much and put them to you.
While we're getting the slides up, I just want to say that I'm at the university and we have a new consult service that is free to primary care providers. I put little flyers on your table. There's some down here. And if you call during the work week, 8 to 5, Monday through Friday, we can give you a call back within the day to help you with diagnostic questions, medication questions. It is me, a geriatric psychiatrist, my colleague, Alexis Ritvo, who is an addiction specialist and who helped me with this talk today, and Dr. Theta Thant, who is a consult liaison, the director of our CL service. So it's an amazing breadth of expertise. And right now we're grant funded for 2 years to provide advice to community providers that see behavioral health problems within their primary care practice. So please call that number. We would love to be more busy than we are. I can't believe how not busy we are. I hope that opens the floodgates, but we're very happy to help. So let me see if I can work this whole apparatus. I want to thank Anne again for her great talk. She may have left, but that was outstanding. We all need that. And I'm going to talk about benzos. Going to skip the objectives in the interest of time. So I want to talk about pharmacology because I think a lot of us think we know how benzos work, but we really don't. And to my pharmacist colleagues, hats off as usual. You are such an integral part of our team, and we value you very much. So benzodiazepines enhance the neurotransmitter GABA. We all know about GABA receptors. They do not bind at the site itself, but influence it through an allosteric effect, where they bind on the other side. And the consequence of this is it results in an increased resistance to excitation. So I think we often think of benzos as being disinhibiting, right? But we're actually resisting excitation. And this becomes important as we think about tolerance. So chronic administration of benzodiazepines leads to a negative feedback mechanism within the brain. If you keep these slides at home, this is the one slide that I want you to refer to a lot. It's the one Dr. Ritvo gave me that helps me understand prescribing the most. So there's a decrease in endogenous GABA, a downregulation of GABA receptors, and a cumulative decrease in inhibitory impulses. So what do you think then happens? There's an increase in the excitatory part of the seesaw, right? So an increase in endogenous glutamate, an increase in norepinephrine serotonin, and actually a cumulative increase in excitatory impulses. This is why you have intradose anxiety, why when people come off their benzos, they're more anxious, why people are more anxious than they would normally be prior to their next dose of benzos. Preaching to the choir here. All right. So really important to remember this. And contrary to popular belief, most people don't have a problem with benzos. I think we do have a little bit of a selection bias in our population at times. But if you look at the U.S. population as a whole, more than 80% of people take benzodiazepines as prescribed. And only 1.5% of U.S. population that takes benzos has a possible use disorder. And we'll talk about what a use disorder is. There is some misuse, but an actual use disorder requires physical dependence, which we would all get if we took benzodiazepines. That is not a use disorder. Tolerance and withdrawal alone is expected with regular use of benzodiazepines. It is not an addiction. It becomes a disorder when there's continued compulsive use. So we talk about the 4 C's: continued use, craving, loss of control of use, and consequences of the use. That's when it becomes a disorder. So the best way to prevent problems with benzodiazepines is to never prescribe them. I don't know. We usually inherit a bunch of people on benzos, though, don't we? I bet how many people, I'm not going to ask you to raise your hands, but we rarely ever are the first person to prescribe a benzo to the person for the very first time. We usually see quite the opposite and have to get people off. But if you have the opportunity to not prescribe them, don't prescribe them. We all know the adverse effects of benzos. They're a classic Beers criteria pioneer, so I won't go through these. We all know them. The only thing I will mention, in case people don't know this and are not aware of it, is that benzodiazepines can often disinhibit people with dementia and make them worse. So they have a paradoxical reaction. And as I discussed previously, they actually can increase anxiety, which is very counterintuitive. We know that the risk goes up with older adults. They're more susceptible because of their vulnerable brains. It can increase the risk for cognitive impairment. We know that motor vehicle accidents go up when people are taking benzos and that the curve goes up more steeply the older you get. And we know that benzos are associated with hip fractures. And just a reminder that Ambien is also not benign. Zolpidem is found to increase problems with all of these things as much, if not more, than benzodiazepines. There's been a lot of press and talk about the use of benzodiazepines as a risk factor for incident dementia. The data are actually fairly equivocal. On face value, it certainly makes sense that if you take benzos your whole life, you're more likely to have a risk factor for dementia. Causality cannot be established, however, because of the studies listed, none are actually RCTs. But given the prevalence of benzo use among older adults, the association is certainly something for concern. Overdose risk. We're all very familiar with opioid use disorder, the overuse of opioids, and in fact, the underuse of opioids. And we now know that the risk of opioid overdose increases significantly, at least fivefold, during the first 90 days of concurrent prescription with a benzodiazepine. So many of our patients are on benzos and opioids, and there's a great big black box around that as a warning now for potential risk for death. So we need to be very mindful when we have patients on both at the same time. We need to document those risks. And the FDA box warning came out in 2016. There's one caveat to this, though. I think many people think we have crossed over in that we are not actively treating opioid use disorder as well as we used to because people are afraid to prescribe buprenorphine and other opiate analogs to help with use disorder. So we can't throw the baby out with the bathwater on that. First line indications for benzos, of which there are some actually, Dr. Gum. Withdrawal from benzodiazepines and alcohol. I mean, when you withdraw, you can actually die. It's one of the things that can happen to you in the hospital if you come in fulminant alcohol withdrawal. That is a first line indication for benzodiazepines. Obviously, seizure disorder, status epilepticus, crisis anxiety without psychotic features, think acute grief reaction, a severe motor vehicle accident, several days for an acute stressor. The classic give Ativan before you go to the dentist order. Pain conditions, burning mouth syndrome is actually a condition that responds very well to benzodiazepines. Certain movement disorders. Catatonia, actually, interesting psychiatric trivia, is responsive to benzodiazepines, high dose benzodiazepines. And of course, end of life palliative care, which is very, very important. Appropriate second line indications are, as I said before, short-term use for prolonged sleeplessness due to grief or an acute stress reaction, like 1 to 3 days. Severe and acute anxiety, let's say someone has a new onset, first ever major depressive episode, they're nearly psychotic, catatonic, completely stressed out, and we're waiting for that latency of the antidepressant to kick in to provide a 1 to 2 week bridge with benzos is very appropriate. Again, seizure disorders and muscle spasm. And always start with the lowest dose, as we know. Start low and go slow. Relative contraindications to benzo use are active or long-standing substance use disorders. Certainly, we see this quite a bit. Concurrent use of opioids, as I mentioned. History of traumatic brain injury, because TBIs often behave similar to a vulnerable dementia brain, and that you can be disinhibited in TBIs. We do have patients with TBIs that are on benzos appropriately and tolerate them fine, but it is a relative contraindication. PTSD, it basically suppresses the recovery of PTSD because it obviates the need to process the trauma and can actually make things worse. And again, of course, older adults, it's a huge risk factor, and young people. So when you're trying to decide which benzodiazepine to use or to switch to or to think about as you manage your patients, alprazolam Xanax is the absolute worst offender of all. Okay, you've probably heard me talk about this a million times. It is the shortest acting, it is the most potent, and it's the most reinforcing. because you feel it wear off and that increase, that remember the seesaw? So the glutamate pops back up. And so lots of excitatory action in the brain. And there's interdose withdrawal and rebound anxiety. So avoid Xanax if at all possible. Clonazepam, we think of that as being a lot longer acting, but it's not that much longer acting actually. It's still classified in the short acting category and is also very potent. So taper limited by lowest dosing is a difficult thing to match. Withdrawal is the most difficult, obviously, from high potency benzos, and we'll talk about how to deprescribe as we go along. So do they actually work? They actually do work in RCTs. They're superior to placebo in reducing short-term anxiety symptoms. Interestingly enough, less than 2/3 of patients experience full remission of symptoms on benzodiazepines, and anxiety often returns after treatment discontinuation. In insomnia, it can induce sleep in about 50% of patients, but the therapeutic benefit is typically limited to 1 to 2 weeks. So for all of these people that are on chronic benzos for sleep, there's no data whatsoever to support it. And the worst part is, it actually does not help restorative sleep. For those that follow, the topical news about sleep being the most important thing we can do for our health now, restorative sleep, deep sleep and REM cycle sleep are the most important for memory consolidation, for recovery, for immunity. So people that take benzos think they're helping themselves be more healthy when they take them for sleep. All they're doing is like taking a shot of tequila before bed. So it helps you go to sleep, but then it destroys your sleep architecture over the night. And again, for short-term use, it can be helpful, but don't fool yourself and don't let your patients be fooled. That can actually be helpful long-term. The FDA box warning in 2022 talked about the dangers of benzodiazepines and the danger of protracted withdrawal. The recommendations were that we need to standardize warning labels, judicious prescribing, and gradual tapering of the medication, which we'll talk about. The important take-home message from this slide is physical dependence can happen in 1 to 2 weeks. It can even happen in a week. So just remember this every time you write a prescription for this, the risk that's involved. We're going to spend a minute talking about bind. So my colleague, Alexis Riffo, who's also on this flyer with me, and we work together, she was an integral part of this group that has now described with more precise language this long-term withdrawal syndrome for benzodiazepines. How many people have had patients that you just can't get off and have just horrible withdrawal symptoms? Raise your hands. So super, super common. And I'm not talking about the people that kind of miss it a little bit. We're talking about people that have physical zaps, brain zaps, muscle aches, nausea, vomiting. They're miserable. And you would think there's no way that could possibly be because they're on such a small dose of the medication. So bind is the term after many iterations of trying to come up with the right term. Benzo-induced neurological dysfunction. It's a constellation of functionally limiting neurologic symptoms, physical and psychological, that are the consequence of neuroadaptation and or neurotoxicity to benzo exposure. And it can last for a very long time. So deprescribing, we always want to try to deprescribe if we can. And there are certain indications for sure and benefits from deprescribing that we're all aware of. Obviously, we want to limit the impact of cognitive impairment, falls, and all of that. We know that the efficacy of benzos wears off over time. We can become tolerant. And every now and then a patient actually wants to come off of benzos. Actually, I'm being sarcastic. Many patients actually want to come off of benzodiazepines. So never assume that people don't want to come off. It's always a worthy conversation to have. We know that long-term benzo use actually increases mortality, so there's a good reason to come off for that. And then, of course, it reduces MVAs and falls. So in older adults, the calculus changes a little bit about why and how we reduce benzodiazepines. In younger adults, like in the clinic where I sit with Alexis, we see general adults that have been on benzos for a long time, and she's always doing this big calculation about how to switch to Valium, and there's this whole chart and all this stuff. With older adults, because Valium can last so long in your body, we typically try to stay on the shorter acting ones if they're already on it. So reducing the dose of a shorter acting agent before converting to a longer term agent
makes the most sense. Um, Consider using benzo, which has less likelihood to accumulate, such as Valium. Ativan is typically the best choice. So, about 30% roughly of benzo users experience withdrawal symptoms upon discontinuation. And these are not people that are abusing benzos, these are anybody taking them. Factors that may increase the difficulty of withdrawal include this kindling response, which is where people stop and start benzos. This is one of the reasons why I hate PRN benzos, because you increase the risk for kindling. So it's better to be on a scheduled dose for a short period of time than it is to leave someone on the occasional benzo. Advanced age, multiple comorbidities are obvious risks. About 10%, which is really high, in some studies, 15% of people on benzos actually have a protracted syndrome lasting months to years, possibly indefinitely. I have one patient who is on, she goes to a compound pharmacy and is on just a little few grains of sand of her clonazepam. And every time we drop 1 grain of sand out of her taper, she has a return of all of these symptoms, physical and psychological. So for some people, it can last forever. Other outcomes of discontinuation include suicidality, akathisia, so that's that sense of inner restlessness that can happen, and certainly disability. We have many patients that have had to quit their jobs that were very functional folks from a withdrawal syndrome. There's also a lot of fear and ambivalence about no longer being on them, as you might imagine. I want to flip the coin here. Donovan Moust is a pioneer in the field of benzo use in older adults, and he actually did a really elegant study looking at benzo discontinuation and mortality among patients receiving long-term therapy. It included adults up to age 103. And in this study, there was actually a small increase in mortality and other adverse effects, including suicidality and emergency department visits for those stopping benzodiazepines. So to return back to Anne's comment about yes and, benzos are bad, and some people need to stay on them. And you can all think of examples of people that have come to you that have been on 0.25 of Xanax for 35 years. And if they're not having any side effects and not escalating in opiate use, why in the world would you take them off? Is my question to you. And so you really have to see the patient first, and reduce harm, but really look at their quality of life. I'm sorry? Would I at least try? No, Cindy, I wouldn't. Oop. I miss being in meetings with you, by the way. I think, when you look at the regulatory environment where we're asked to try to taper as a rule, I think that quality of life is not talked about enough in the defense of leaving medication regimens alone that are not otherwise unsafe. And we'll talk about a case in a minute. So, and of course, if people are going to taper, you need to gear up all the resources you can possibly gear up in order to make it a successful taper. One thing I don't think we do enough of in the nursing home space is we don't spread out the dosing. So everyone wants to have a BID or TID dosing because that's just what we do, right? Even if it doesn't really go along with the pharmacology necessarily sometimes. The very first thing I do is I keep the same total daily dose, but I spread the doses out to 4 or 5 times a day for people, and then they panic less. And these are for the shorter acting, like alprazolam or clonazepam. So up to 5 times a day for alprazolam. Just can give a little tiny dose, depending what their overall dose was, as opposed to suddenly coming down on the total daily dose. We typically do it too quickly. The duration of clinical effects are also not necessarily related to the elimination half-life. So, for instance, Valium stays in your body forever, and its secondary metabolite forever and ever. But the efficacy, the effectiveness of the felt dose actually wears off fairly quickly. So while it's still in your body being eliminated, the patient will say, but I don't feel anything anymore. And that's probably true. But the risk, for instance, for respiratory suppression or the concomitant risk with opioids is still there despite a lack of felt benefit. And then, use your common sense. This is an art and not a science all the time. Clinical evaluation is better. I'm getting the 5-minute warning, so I'm going to roll on.
gonna skip this. This is the equivalent dose. If you guys don't have this on a sticky note in your computer, you should have it up there somewhere. You can find it anywhere online about the equivalent doses. Really important to have. And let's talk about a couple of cases, 2 real cases. 78-year-old female with lifelong anxiety was admitted to long-term care for chronic heart failure and dementia, had a fall, stood up too quickly and that's when she fell. On Seroquel, BID for agitation was recently added just because she moved in. Alprazolam, 0.25 milligrams TID for 15 years, multiple antihypertensives. The medical director wants to stop the alprazolam. What to do? Well, could it be the antihypertensives? Yes, maybe too much. Adjust to optimize the current recommendations for BP for age. You think that quetiapine could be a problem? Yes, so largely antihistaminic and sedating at low doses. We think of it as benign. Don't get me started on Seroquel. So yes, taper in DC, it was just added, probably just because she moved in and they were worried about behaviors evolving. And she had some just adjustment delirium to living in a new place could stop it. While the alprazolam can cause sedation and confusion and contribute to falls, she's been on it forever. And the other 2 meds are probably more likely to have caused the acute event. Okay, so just remember, it's not always the benzo's fault. Case number 2, a 65-year-old male with a history of PTSD and depression presented with complaints of significant sedation and cognitive slowing. I remember this guy in the clinic. He was basically unconscious. He could barely stay awake 6 hours a day. He was on quetiapine 50 HS, duloxetine 60 BID, alprazolam XR 3 milligrams HS, and brexapiprazole was on daily because he got too tremulous on Abilify. So he was oversedated by his combination of meds. So we simplified the med regimen and tried to stabilize the other psychiatric symptoms, especially sleep, anxiety, and trauma. We stopped the quetiapine. We stopped the brexapiprazole. It was very expensive and it was unclear whether it was helpful. And then we added a little trazodone to help with the insomnia piece because he had some rebound insomnia. We waited several weeks between each step, and then we started to decrease the alprazolam, which was his goal. You can go through this on the slide yourself about how slowly we did it, but we did it over 2 to 4 weeks between each steps, very slowly. He tolerated it very well until we got down to the lowest dose of 4.5 milligrams of Valium, where he actually became very suicidal. And so he's still on 4.5 of Valium and none of the other meds. So would that be considered a success? Yes. Okay. So he did well and he got into psychotherapy. And because we weren't suppressing his brain, he could actually process his trauma and do some real healing. Take home messages. Most people actually do not develop a substance use disorder with benzodiazepines. The best approach is not to start in the first place. Unintentional overdose deaths are often in combination with opioids. It can happen with benzos by themselves, but is actually quite rare. Deprescribing should be slow and strategic. Motivational interviewing and empathy can definitely help in this process. Very important. I wish I had more time to talk about that today. Some people with long-standing responsible use may be better off staying on their low dose. Benzos have a low rate of efficacy in chronic anxiety. They actually reduce restorative sleep. There is a prolonged withdrawal syndrome, this bind syndrome, which I really encourage you all to read about it. There are whole patient online communities of thousands of people talking about these symptoms. You may have patients that are on there. And there's a lot of help now. There's a lot of expertise in deprescribing. Dr. Ritho is one of them. They're across the country. There's a whole network of people that can help microdose deprescribe for patients that are unable to come off safely. And I think that's it. Thank you. And time for questions? We have time for any questions?
Yeah, but
1 minute, 40 seconds. Sabina.
Well, I can see. I was even tweet to you say if somebody stable
On a benzo and they have a good quality of life, you shouldn't try to decrease it. And of course, we all know CMS QSO, I think it's coming out actually. I think it's going to happen. So we are really encouraged to do GDRs. So where is an official statement by any organization? And I'm looking at
That's my official statement. Doesn't work.
yeah, that would be great. Maybe we can make that a PubMed official statement, or is there an official statement that we can refer to and
Here's
say,
the thing, you have to show that you thought about it. You have to show that you tried to achieve the lowest effective dose. Now, I'm not talking about leaving someone on 2 milligrams of Xanax 3 times a day. I'm talking about the person that has been on a tiny dose of Xanax or Klonopin for their whole life. They're good citizens. Everything else is cool. They're 90 years old. They're going to die probably within the year based on their life expectancy adjustments. Why would you do that to a person? And if they want to come in and scrutinize that, then I think you should have good justification for all the things I just said. So get them to the lowest effective dose. And I will tell you, I've argued these successfully, I would say 99.9% of the time. We can't make a blanket statement that you should always leave someone on their benzo. That's not what I intended to say at all. Yeah. It's a great question, though.
Thank you.
Anyone else? Oh, good. Thank you.
thank you?
All right. Well, it's my pleasure to welcome and introduce Jenny Albertson. She's a Director of Quality and Regulatory Affairs for CHCA. We're always thankful for her wealth of knowledge and being a trusted resource for our community. So with no further ado,
Okay.
Good morning, and thank you for having me. As the trade association representing nearly all the skilled nursing facilities in this state, your organization and ours are in direct alignment. And so I see it as just an extension of what we do that I am here today. Uh, and to that end, the winds that blow our leaves are also blowing yours. And that's why we're going to talk about partnering through regulatory change today.
Yeah.
So, the days of a passive medical director, next slide, please, are behind us. And of course, if you've worked with an administrator like me, you know that passive parenting or absent parenting has always been inappropriate as a medical director, right? However, now we're codifying it in surveyor guidance. So, as of April 28th, we are going to see a rollout of some additional guidance for our surveyors to interpret regulations that have been in place already since October of 2022 when we updated our requirements of participation. So, to that end, there are some intriguing uplifts of your responsibilities and also your visibility when it comes to your participation in our communities. So, the surveyors are going to look for some new things with respect to very specific deficiencies, and they're a little hard to see there, but I'm going to go into it in a bit of detail here. There's a shift toward direct medical director involvement. That's the theme here. And you'll see there's a shift also in the way that we are approaching our profession as I get through this as well. Next slide, please. So first off, these look like they might be my old slides. We might have some adjustments here. First off, we're going to be setting the standards as medical directors in a different way than you have in the past. So you're expected to participate in implementing resident care policies, not just saying, here, administrator, you roll that out as a policy and we're here on the side and tell us if you need us. That's not happening anymore. You're going to be part of the definition of the resident care policies, and there has to be documentation and quality assurance that you have actually been part of that process. And then when it comes to setting the standard, it's expected that the medical director will help the other practitioners in the community in applying those. So if there is something not happening for your residents that are under your watch, you are expected to be present in making that an actively intervened situation until it's remedied. And then we'll document that in quality assurance. For example, you might discuss and intervene if somebody is inconsistent with the current standards of care. Say, for example, they're prescribing benzos quite liberally. By the way, I just want to remark the amount of surprise I saw in the room when tequila shots before bed is not normal. Anyway, okay. So you're supposed to recommend, develop, approve facility policies, and then also participate in the facility assessment. Are you familiar with this term, facility assessment? Yeah, it's our new strategic guidebook that we develop as a team of leaders in the community to say this is the acuity, this is the resident population we have, and this is then what we do in response to all of that. It's like a business model, only it's a care model in conjunction with that. So you're supposed to be part of that. Next slide, please. So, quality assurance and performance improvement has always been something that you dread because it's 3 and 4 hours long. Right. Yeah. Okay. It's always been something that you actively participate in, along with psychoactive meeting and all the other things that you participate in that involve sitting in a chair and reviewing charts. Um, but it's going to include some additional elements now about subpopulations. Now, you may say, wait a minute, DEI is out of favor. We don't talk about subpopulations anymore. Yes, we do. In the land of CMS, it's in the terminology of health equity. So we know that dependent upon your socioeconomic status, your ethnicity, your gender, you may have had a different level of access to healthcare, and you may have had a different level of understanding of how to interpret the healthcare around that's being given to you and the environment that you're in. We now acknowledge that. And so it's part of our facility assessment, it's part of our quality assurance process that we incorporate that into our quality assurance and performance improvement. So you are going to now be expected to participate in the systems level identification of noncompliance for quality assurance. So if there's a performance improvement plan happening because of dining room issues, they might ask you about that. Is it something you're directly involved in? No, but you're expected to be present during quality assurance and performance improvement and part of the oversight of the improvement of quality of care in the building. So surveyors can ask you about that now. And health equity will be built into that. Next slide, please. There are other salient updates. You saw that list was like not just 3 tags, right? It's multiple tags that pertain to medical directors. One of those is infection control, enhanced barrier precautions, our new favorite intervention to prevent MDRO transmission. Is now incorporated into the critical element pathways and surveyor guidance for IPS, infection prevention and control F880. So you need to be aware of enhanced barrier precautions and how that operates. Does that mean everybody gowns and gloves all the time? No. If you are seeing your building do that, please look on the CDC's guidelines specific to nursing homes for how you are to implement EBP. It is pretty darn specific. And there are ways to preserve resident dignity in the process. Also, COVID immunization. Are we tired of this topic yet? It's been brought in to the surveyor guidance now, so it's not just a separate QSO memo, it's integrated. And we're trying to treat it a little less like it's its own pariah infection and, oh, it's part of the regular family of respiratory infections. And then pain management. This one is one of the most significant updates as far as a practitioner probably is seeing this circumstance of surveyor updates. And the reason is they're distinguishing in the surveyor guidance between various types of pain. So they're now going to be asking you, how do you select and monitor pain management interventions for residents with acute, subacute, and chronic pain? Do you even distinguish that in your documentation about pain management? I think it's kind of rare that we look at it from that lens. So now we are going to be expected to give some explanation as to why we think it falls into one of those categories. And what's more, the residents are expected to be collaborative in the pain management. Whenever they can express in some kind of way what their wishes are around their pain management, whether it's verbal, nonverbal, drug seeking, etc., they need to be part of that discussion and what they think will adequately manage their pain. And you are supposed to be documenting that collaborative discussion and integration of them into their care plan around pain management. So surveyors are looking at it from a resident rights standpoint at this point, or they will be looking at the survey. And so this is actually integrated into their guidance for them to kind of transition the way that they approach pain management and scouring for that. It's not just, did you discontinue something if it was sedative? It's not just, did you alter your approach if it was inadequately managing the pain? It's how do we actually create an overall plan and treat it differently if it's acute, subacute, or chronic? Next slide. Oh, okay. We're missing a piece in here. Sorry, these are not my updated slides. I apologize. One last piece I forgot to throw in here is there is a change, and this is not specific to medical director advisement in the surveyor guidance, but discharges are really, really going to change. And the reason why I'm mentioning it here is because whatever a provider documents about the level of care needed for an individual after they leave the skilled nursing environment can have a direct impact on whether we are cited for deficient practice. It's not going to be facility initiated discharge, resident initiated discharge, involuntary discharge any longer. It's going to be appropriate or inappropriate discharge. Should it have occurred? That's what's going to be the basis for compliance or noncompliance. And so that means, is it safe where they are going? Are they going to be receiving the level of care that they need and all of the services that they need? And did you justify that in your documentation as a provider? Or did the providers operating under your jurisdiction, I guess, do that? So it could require some training. I think a lot of times we leave discharge discussions to social workers. And again, it's a collaborative process with the resident. They want to see that in the record and that it's a resident driven process as much as possible. But often we know that there's a responsible party driving that. There are pay source cutoffs driving that. There are things that are kind of out of our control. The reasons for discharge remain the same. Okay, the regulations have not changed with any of this update in surveyor guidance. It's simply a way of changing how we're interpreting it. The regulations still say if your facility shuts down, you're going to be discharging people. You'll have to give them a notice about that. If they have a change in pay source and they can no longer afford the care or they've failed to pay for it, that would precipitate a discharge in a valid way. And then there is, of course, the reasons why we resort to involuntary, which often are behavioral, acute change in care need, those sorts of things. That's going to need a lot of robust documentation and collaboration to prove that we are doing it with the resident's best interest at heart. So know that there is now going to be a written notice given for every discharge with 30-day advance notice if possible and as early as possible. So it's not just for an involuntary anymore that your administrator is going to say, I need a provider's note to attach to this involuntary or this 30-day discharge notice. It won't be an involuntary anymore. It's a 30-day no matter what, so that they know they have a right to return, say if it's an acute discharge to a hospital. Okay, so these are very big differences in how we approach discharges. All right, so it's not just regulatory change that is impacting us, right? We also have shifts in our support structure. So I want to talk to you a little bit, and people have already mentioned it. We are impacted by funding sources. We are impacted by how federal and state government officials see our profession. So I want to give you a little glimpse into that as well, because we are partnering through this as well. Medicaid funding, and you've probably already looked at the slide. Medicaid funding in Colorado is in pretty darn good shape. I know I'm not normally a bearer of good news, so look shocked. I want to see owl eyes out there. Okay. All right. So we are pretty efficient in Colorado. We say about 96% of our Medicaid funding goes toward provision of care, not toward administrative costs. That's exciting and positive and wonderful and allows us to really talk a good game with legislators. They've agreed, for this year at least, to maintain our 1.5% year-over-year increase for long-term care. So that's a huge victory. We're still getting it through both houses for the final approval, but it shouldn't be a problem. There is very little appetite in our state to cut Medicaid. Now, federally, that's another issue because we are kind of a big bucket. About a third of our spending at HHS nationally goes toward funding care. 30% of Colorado's general fund spending goes toward it. We also need to recognize that there's been a shift toward a higher acuity patient that's covered by Medicaid. And I'm preaching to the choir, you all know this, but we absorbed another layer of people who were eligible for Medicaid during COVID. people that had not had access to care. So, what happens when you don't have access to care over a long period of time? Are you healthier? You are more costly. And that's just normal. And so our states are absorbing higher cost. It's good because obviously our population is being cared for, but it is costing us more. Quarter of our population receives Medicaid. It is a very valuable program. Next slide. And to that end, I want to note that we have something else to be incredibly proud of in Colorado, and that is our Pay for Performance program. We spearheaded this as a state and set an example, collaborating with our Colorado Culture Change Coalition way back when this was created. It's a value based purchasing program. You're expected to have quality performance and resident centered care, and they will up your reimbursement for your up game. So that's something to be very proud of. People recognize that this is a valuable program to the point where they doubled the reimbursement for this year over year this year, and they're looking at doing it again. Part of why I like that is it's secure. It's based on something. It's not just a budget line item that can be cut. This is based on our performance. So look at all the things that get impacted by this being incentivized. It's exciting and it's great to be part of it. And I want you to know that you are part of it. Next slide, please. So I apologize for the color on this. I did change it on my second one. I promise, Les. There are some changes in how we approach our profession. And there is a bit of a cultural shift with this that I want you to recognize. Because of funding being in question, there's a few things that are just driven off that on a national basis. And one of those things is that surveys are going to be a little more ramped back as staffing goes down on a national level at HHS. They won't have manpower to ride us so hard. Now, that doesn't mean that our state surveyors won't be present in our buildings. It means that their support infrastructure on a federal level is waning. And therefore, they're going to have to really focus on what matters and drive at the things that are truly driving quality. So risk-based surveys are being trialed. And we like this because it focuses the resources where the buildings need to really improve. And it also inherently sort of gives a deemed status to people that have had a history of good performance. So the idea is that you allocate longer surveys to buildings that need more investigation, and you give shorter, more abbreviated surveys covering only the basics to those that have had a history of positive performance and fewer complaint surveys, et cetera. This is something we're moving toward. They're still trialing it, but I want you to know it's out there because it shows a cultural shift to really try to hone our resources. I think we all feel scarcity, economic, whatever, and it's nice to know that there's some strategy going on to try to tackle that on a regulatory side. So CMS is trying to be focused in a new way, and with our new HHS director and so forth, it's definitely changing. We're expecting now to focus more on transitions of care also at a state level because of our OIG lawsuit that was just settled after 7 years. They've created in-reach programs that are encouraging people to transition out of institutional care, nursing home care, and into home-based care whenever possible. And they're actively seeking programmatically to make that happen in Colorado. That is intended to reduce cost, we will see. But more than anything, it's intended to increase quality of life. And I think we all support that. Unfortunately, we have a bit of a gap in our structure where we don't have Medicaid funding for assisted living level of care. I think that's kind of a misunderstood aspect in our care model. There is no state funding really for a custodial rate of pay for assisted living in Colorado. It is entirely private pay. There is a elder and blind and disabled waiver funding that can be supplemented, but it's only a very small amount per day. Other than that, it is on the person's personal cost. So that's a gap. We're looking to remedy that in the future, but know that transitions of care is a focus and it's highly supported at a state level because of the settling of this OIG lawsuit. And then also on that transitions of care piece, we've generated over the years a standard of quality in cross continuum communication that even got CMS attention. Last year, they came out with their quality team and observed our South Denver Care Continuum meeting. What do I mean by care continuum? I mean all the levels of care: home care, EMS, hospital case managers, SNFs, ALs, all getting together to do quality assurance about resident transitions of care. We have spearheaded this over a decade ago, and now it's spread all over with all of the metro areas represented to quality assure resident transitions and improve our continuum. So we are a very proactive state. We've done a lot of work on this, and I'm crediting all of you with this too, because you are inherently part of it. So that's exciting. We have one in every area. If you have any interest in participating, you are more than welcome. I already touched on the DEI being out of favor, but health equity still being very integrated into CMS's language. And then also, even though funding of care is at odds with the general climate for American self-reliance right now, we can count on Colorado. So lastly, thank you. I want to welcome you to join with us as an association, since we are in tandem, and with also our national affiliate, American Healthcare Association. If you want to join in advocacy and understanding what's happening legislatively, we have advocacy blogs, we have issue briefs. You can call me, text me, email me, and I'll tell you what's going on. You can sit in on our membership meetings. You're always welcome. We would love to have you by our side at our congressional briefing in June, where we actually visit our lawmakers. We are extremely active in advocating for all of our needs and our elder care needs in this space. Any questions for me? Okay, I did want to note my why in the spirit of the conference. I was a nursing home administrator and still am licensed since 2004. And when I did that work, I learned what it was to really walk in my purpose. And what you find, of course, as I'm sure you've experienced this yourself, there is a joy that comes from just being in the place you're supposed to be, uniquely suited to doing what needs to be done in that moment. And you just kind of look at yourself and say, thank goodness I was here. And you all do that every day. That is all of our why, I think, knowing that we are walking in our purpose and using the gifts that have been given us to support another human going through depth of human experience. So that's my why. Thank you. All right, thank you. I'm going to introduce our next speaker. I think we all know the valuable work that we do in this realm, and I think we're kind of in this unique stage in medicine where these organizations, these value-based programs are coming online, and also we're having more visibility since we are an important spectrum of the care for people that we see every day. So I'm happy to introduce Dr. Walter Lin. He's the founder and CEO of the Generation Clinical Partners. And the work he does is really important because he's helping organizations transition into this era of value-based care. And he has a very breadth of experience in various different organizations. So we are really excited to have him here today and look forward to hearing his talk. That's it.
Hi, good morning, everyone. I'm Walter Lin, and just really honored and excited to be here at the 30th anniversary of this conference. That's really special. Um, and I think the theme, excuse me, is really relevant, honoring our why. And hopefully, I can support that theme with this conversation we're going to be having around value-based care in PALTC. So, um, I am the founder of Generation Clinical Partners. We are a medical practice based in St. Louis, Missouri, that exclusively cares for seniors in senior living, like many of us here today. And our mission home, we started this company back in 2014 was to help senior living organizations transition into the world of value-based care by helping them take better care of their residents, our patients. Um, and so value-based care is and has been core to our identity as a practice. In terms of speaker disclosures, I guess I should use this. Uh, I we as a practice do a lot in value-based care. I personally work with a institutional special needs plan, an ISNP. The provider arm of the ISNP is called True Health. I'm the medical director for both Missouri and Kansas. I am the medical director for a PACE program in St. Louis, and I'm also LTC ACO's clinical strategy officer. Uh, and a few years ago, AMDA at that time nominated me to join PTAC. PTAC is a physician payment model advisory board for HHS. And so we make recommendations on payment models to the secretary. It's been a big passion of mine because I really believe that in US healthcare, care follows finance. So how healthcare is paid determines the care that we often are able to deliver. And so I think this is very, very important. In terms of the learning objectives for the session, I won't go through all of them, but just to summarize, I'll say I'm going to talk about how we're coming from a payment system that really hasn't worked, fee for service, and we are moving to a payment system that is going to change the practice of medicine, in my opinion, as it takes more and more hold within our healthcare system. And then I'm going to explain how the transition from fee for service to value-based care is going to take place. But most importantly, I want to leave everyone here with a sense of excitement that this is going to be good for us, that we should embrace this change as practitioners in PALTC. Change is often difficult, but hopefully we will be very supportive and actually excited about this change. All right. So this is hopefully going to grab everyone's attention. Medicare physician payment continues to fall further behind practice cost inflation. This was a graphic put out by the AMA, and it actually says that adjusted for inflation in practice costs, Medicare physician payments have declined at 33% over the past 2.5 decades. Just let that sink in for a while. And if you kind of squint and look hard at the red line there, since 2021, actually physician payments been decreasing, not increasing, right? So this is actually a really big deal, obviously, to us as providers, but also it's a really big deal to the kind of care that we're able to deliver. And so this is why everyone here should care, because as far as I know, we're all seeing patients and are dependent upon the payments that we receive to support that. Physicians are working more but generating less revenue. This is an article that was recently published in the hospital CFO report. Our national organization, published a policy snapshot last year talking about how in 2025, we've had another 2.8% reduction, marking the 5th consecutive year of cuts to Medicare payments. Kind of small and hard to see, but that's what that says here. So I mentioned that I work with HHS on payment models, and so I go up there to DC every quarter and roam the halls of CMS and the HHS. And there's a lot of talk about making fee-for-service increasingly uncomfortable because they want, they being CMS, HHS, wants providers to be more accountable for the care of their patients. So they want to shift the payment system from fee-for-service to value-based care. And I think the way they're doing this is by making fee-for-service more uncomfortable. And we see that in the annual payment cuts that we've been experiencing. It's a really harsh reality, unfortunately. And so the rest of this conversation is going to be around 3 areas. One, where we're coming from, fee for service, and why that hasn't worked. Value-based care, where we're going, the future of medicine, and why we should very be supportive of this trend. So first, fee for service. So I think most people are very familiar with fee for service. It's what we've all been accustomed to for really decades now, and there are several problems though that I'm not sure if people have realized. One, it incentivizes quantity of care over quality, right? So it's fee for service, it emphasizes volume. Um, the more patients you see, the more you can bill, the more income you can generate. Um, Same with hospitals and other providers as well within the healthcare um, delivery chain. There's a lack of focus on patient outcomes. So if I see a patient and the patient doesn't do well, I still get paid the same no matter what, right? If someone else sees the patient and spends a lot more time with the patient and the patient does well, they get paid the same. So there's really no focus on patient outcomes from a payment perspective. And in fact, it penalizes efficiency and prevention. And I think a good example of that are hospital readmissions. Before value-based care, hospitals were paid again for readmissions. So a hospital sees someone for CHF, discharges the patient. A week later, they come back, they get paid again on a DRG basis for that. And that was kind of before the readmission penalties. But that just kind of is an example of how fee for service doesn't really focus on outcomes, but in fact can penalize efficiency and prevention and good care. Uh, and it results in fragmented and siloed care, right? So you kind of think about how this affects our world. A lot of times we refer people to specialists. Oftentimes it's a black box. What happens? Sometimes, if I'm lucky, I'll get a letter back from the specialist, but it takes time, right? And often people don't take the time to provide really good coordinated care because it's not incentivized in their fee for service. So what's happened is that fee for service has resulted in an unsustainable rise in healthcare costs without accountability for outcomes, and I think that's probably fair to say. But I'm gonna just show you some evidence of that. So we've all heard how expensive U.S. healthcare is. U.S. healthcare is amongst the most expensive in the world. It's probably the most expensive in the world, and you can kind of see how other developed countries stack up here. But it would be one thing if there was a lot of value associated with our spending, right? People will buy a Lexus and not a Toyota for good reason. And the question is, are we getting value back for all the spending? And unfortunately, the overwhelming evidence from a population perspective is no, we are not getting value for our spending. So under fee for service, there's higher spending, but it's resulted in poor outcomes. Just some examples from the Peterson Foundation around life expectancy, infant mortality, uh, and other metrics here. The US is the blue dot, right? And you can kind of see where we stack up compared to other wealthy countries. More in line with our world, here is an example of healthcare spending versus preventable hospitalizations. And we have the preventable hospitalization on the y-axis and how much per capita spending on the x-axis, and you can see kind of where the U.S. is right there, right, like off the charts, low value, right, very high spending and very high preventable hospitalization rates. And so what I'm saying here is that like fee for service has really resulted in some low value healthcare. What is healthcare value? The healthcare value equation is it can be defined at a very high level. It's more complicated, of course, but at a very high level, conceptually, it's essentially quality over cost, right? And under fee for service, what we see is low quality and high cost, and that's why we call fee for service a low value payment system from from a healthcare payment perspective. Um, and what are the ramifications of this? Like one very big ramification that we've probably all read about in the lay press is the looming insolvency of Medicare funds, right? Right now, the projected Medicare funds depletion date is 2036. It's actually been moved out a few years. I think a lot of experts think in part because of this focus on value-based care. We've been talking about value-based care really for the past 10 or 15 years now, and there's more and more um, institutions that are focused on this right now, and that's kind of slowed the depletion of Medicare funds. Um, so I'm going to end this section with a quote from William Edwards Deming. People might know Deming as the father of the quality movement, and he's famous for his contributions for quality management. We might be familiar with QAPI, performance improvement, and use the PDSA cycle. That's Deming. Deming actually estimated that 94% of the problems in the business are created by systems that aren't functioning as needed rather than individual actions. So I think a lot of the problems that we're seeing clinically in healthcare can probably be traced to how healthcare is currently being financed, fee for service, right? And so uh, I'm happy to talk more about that later, but let me just move on to value-based care and why this is fundamentally different than fee for service and why it's going to change how we practice medicine. I have a question here. Maybe I'll if you hold it to the end, if that's okay. Okay.
You know, two personally, it's with a two-part thing, ACO, the party answer. That's not but it's just that, you know, the other question, just skiing up in the bathroom, what did you?
I love skiing. I'll take you up on the offer. And then, yes, I think ACOs are part of the answer. And I'm going to talk about ACOs actually in this section. So thank you for that question. So, so where are we going? Value-based care, right? And why is this so different? So value-based care, what is value-based care? It's a payment system that focuses on accountability for outcomes. And is where providers are rewarded for delivering high quality, cost effective care rather than volume of services. It encourages preventative care and proactive management of chronic conditions to avoid costly interventions later. And very importantly, it relies on data analytics to track outcomes, identify areas for improvement, and then also measures the effectiveness of care. So it's very different than fee for service because fee for service essentially does none of that, right? We just kind of went through how there's no accountability in fee for service. But central to value-based care is the concept of provider accountability. I can tell you as a person who's still a physician who's still practicing medicine and uh, uh, for our group in general, value-based care is changing the way we think about patient care, the way that we are delivering care. Because if, as providers, we're accountable for something and you have data to show how you're performing against certain benchmarks, it changes how you think about taking care of patients. And so uh, I'm going to describe now how to think about value-based care from a framework perspective. This is like a big picture perspective before kind of going back to why this is so exciting for our field of PALTC. So the Healthcare Payments Network, Learning Action Network, back in 2016, put out this framework that is very useful to helping us think about how we're transitioning from fee-for-service to value-based care. There's four categories. The first category is just fee-for-service medicine. That's what we're all used to and where we're all starting from. Category two is fee-for-service linked to quality and value. So pay for performance. I'm glad Jenny talked about that a bit in her session. And by the way, that was a great session. A lot of the things that CHCA is talking about, MHCA, Missouri Healthcare Association, is talking about as well, and it's I think very important for us as medical directors to learn and focus on. But category two is just fee for service, but basically there are quality metrics that are incentivized. And examples of that include MIPS, which is the merit-based incentive payment system. I'll give an example of that. and HRP, which is the Hospital Readmissions Reduction Program, essentially the 30-day readmission penalty. So these are examples of category 2, value-based care. Category 3 is basically advanced payment models built on a fee-for-service architecture where a segment of a population or an episode of care is being looked at and focused on in terms of effective management and accountability. Examples of that are bundle payments and the comprehensive joint replacement program. There's actually going to be a new program out that focuses on bundles starting in January 2026 called the Teams model. But this is kind of taking more and more hold. But ultimately, the promised land, the nirvana of value-based care is category 4, which is essentially population-based payment. So now we're talking about payment is not directly triggered by service delivery, but rather it's linked to quality and outcomes. And some examples of that are ISNPs. There might be some institutional special needs plans operating in your communities right now, and ACOs to the question there, and we'll give some examples there. But if you kind of take a step back, this is what the transition to value-based care is looking like. It's kind of baby steps along the way where CMS is trying to link payment to outcomes, but eventually get to the initially, and then eventually get to the place where payment is focused entirely on outcomes and not at all on volume of services provided. So in the next few slides, I'm going to give examples of each of these categories, 2 to 4. The category 1 is fee for service, so we don't need to talk about that. And you'll kind of see a progression of accountability over the next few slides. So in terms of category 2, this is again fee for service where quality is linked to payment. MIPS is a good example. A lot of us might be familiar with the merit-based incentive payment system. And it looks at 4 categories of payments. One is quality, second is cost. We'll talk about that in a bit more detail. Third is improvement activities, and fourth is interoperability. Providers are graded upon each of these 4 categories. But why it's going to be virtually impossible for people like us in this room to succeed under MIPS is because of the cost category. Our patients are very frail patients, medically complicated, with functional and cognitive impairments, and inherently they're a lot more expensive to care for than, let's say, a outpatient 65-year-old who just recently retired, be seen in clinic, but still traveling the world and playing golf and backcountry skiing, right? So those are our patients, but we're all kind of lumped in the same category. And so most of the practices in PALTC have moved away from MIPS because of this reason. It's really hard to succeed under MIPS because of the cost weighting here. But this is what like a MIPS scorecard looks like, and you're rated based upon your performance in each of those 4 categories. And based upon that rating, there are payment adjustments that are made that can go, in theory, up 9%. In practice, it's really more like 1 or 2%, but it can also go down 9% if you're not participating. So there's a potential big bite here. This is an example of linking quality and value to payment under category 2. Category 3, this is a example of that bundle payments for care improvement, also known as episodes of care. I'll explain this kind of at a high level, and then if there are questions, I can go more into it. But this is where essentially there's accountability for a very limited episode of care. It's usually triggered by a clinical episode, which is a defined period of care triggered by usually an inpatient stay or an outpatient procedure, plus 90 days. So you think about that like as a time frame, and all the payments made for that patient is lumped under what's called total bundle costs. So all the hospital costs, the uh, physician visits, the Part A stay, the DME, the home health, all those costs for 90 days out are totaled and then compared against a target price. Target price is a benchmark that's predetermined by CMS, and it takes into account historical spending as well as the geographic variation, as well as some other factors. But at the end of the day, though, the target price is compared to the total bundle cost for that particular patient's episode. Um, and if the costs are more than the target price, then the provider has to pay CMS back that difference. But if the costs are less than target price, then the provider gets a share in those savings, right? So again, a very different way of thinking about things. Our practice participated in Model 3 bundle payments back from 2015 to 2018. And it really kind of changed our thinking around transitions of care, for example. It changed our thinking about warm handoffs, about med reconciliation, because we knew that these things that we focus on every day can make a big difference in our patients' care. And now there was a payment mechanism to support the increased time that we were spending with our patients, right? And so it really changed the way we thought about things. We did really well with bundle payments, and I'm happy to share that the things that PulpMed, that CMDA preaches, really works, right? Unfortunately, it takes a lot more time sometimes, which is why it's hard to do. But under value-based care, hopefully that will change, and we'll talk about that at the very end. So that's category 3, and then category 4 is kind of the promised land, where essentially a provider organization is accountable for the total cost of care of a population of patients. And ACOs are a good example of that. So I'm going to just start with the very basics. What is an ACO? So ACOs are groups of providers who come together on a voluntary basis to give high quality coordinated care to a defined population of patients. Providers participating in the ACO assume accountability for both quality and cost of care for this population of patients. And it succeeds when we're able to both improve quality and lower cost of care. So some fundamental ACO concepts. One, provider accountability. So I told you before, accountability is central to the idea of value-based care, and accountability is central to ACO performance. So basically, it's where providers like us are accountable for the quality and cost outcomes for a defined patient population, which is very different than fee-for-service, because who are your patients versus other people's patients, other providers' patients. It's really hard to know unless you have a defined population that you're caring for, and get data back, both cost and quality data back on that population. And so performance measurement is compared against benchmarks, and this patient-level data is provided by CMS that can be used to both improve quality and performance. And importantly, there are shared savings.
This one is
If you take better care of your patients from both quality and cost perspectives, provider groups can share in the savings they generate. And this is really important. These are essentially additional payments beyond fee-for-service that are linked to both improved quality and reduced costs. So mechanically, how does this work? So each participating medical practice in an ACO needs to first define a population of patients that are going to be attributed to them in the ACO. And the process of attribution is super important, but probably beyond the scope of this particular presentation. But once you know who your patients are, then you have to take really good care of them. And that's the hard part. But I think that's what organizations like this one, like our state organization of our state chapter of PulpMed and the PulpMed National Organization really preaches. And we have a lot of tools and ideas about how to take really good care of patients. But essentially, you have to exceed quality thresholds first, and then also take efficient care of them to generate savings. And so, how shared savings work is if there are savings, if because of the good care of patients, your patients cost less because they are going to the hospital less, they're going to the ER less, uh, the CMS will then calculate those savings and then distribute that to the ACO. And the ACO should be sharing savings with the provider group. Well, not should be. They will be sharing savings with the provider group by predetermined agreements, and then hopefully the provider group will. Oops, sorry. Um, yeah, wrong button there. Hopefully, the provider group will share the savings with the individual providers, and sometimes that kind of falls a bit short. But I think that's where really the credit should go to, right? It's the kind of frontline providers taking really good care of patients, generating savings, and as a result, they should share in the savings they create. I know as a practice, we make that kind of a key tenet to our practice, and it's really changed the culture of our practice and made our providers much more engaged in value-based care. So I'm gonna just put some numbers to this, right? Because I think kind of in theory, this is all sounds good, but I just want to show you the potential upside we're talking about here. So I'm gonna make some assumptions here, okay? And these are pretty realistic assumptions through and through, and not hard to do. So let's just say the annual benchmark for one of our patients is $40,000, and that's about right because our patients are much more expensive. That's probably about two to three times the average Medicare beneficiary annual cost, right? The average includes people I described earlier, 65 years old, still traveling the world and skiing. And our patients are essentially two or three times as expensive as the average Medicare patient. And let's say that because of the good care that we provide, the practice is able to come in 15% lower than the benchmark at $34,000. So that's $6,000 savings per patient per year. And let's say that through the ACO agreements, the practice gets 30% of the shared savings. So on a per patient basis, in this example, if the practice is saving $6,000 per patient, they're able to realize $1,800 of shared savings as a practice, right? Which may not sound like a lot, but that's per patient, right? So if you have like 100 patients, you can get almost $200,000 in shared savings. If you have 200 patients, that's over $500,000. If you have 600 patients, that's over $1 million in shared savings, in addition to the fee for service that payments that you generate, right? So this gets pretty exciting pretty quickly, actually, and I think it catches the attention of a lot of providers and appropriately incentivizes them to take better care of their patients. So a few kind of call outs here. So notice that I only said 30% of the shared savings in this example goes to the practice. The ACO in this example keeps 70%, and that's actually a negotiated number. Some ACOs share higher, some ACOs share lower savings with the practice. But part of that is, of course, to run the ACO. They need the shared savings to run the ACO. But most ACOs take the downside risk, right? So let's say you're not able to reduce the cost of your patient and you're not coming in at $40,000, but you're coming in at $45,000, the ACO has to pay CMS back that money, right? And so they take the downside risk. So most ACOs in our space will take the downside risk, but as a result, they take some percentage of the shared savings in addition to running the ACO. And so the bottom line here is that there is significant upside reward for practices who provide high quality, efficient care to its patients, right? And this is kind of the payment mechanism by which we can deliver high quality care by spending more time with patients and having clinical models that really focus on improved patient care. So where are we in this transition? Sorry. This transition to value-based care, initially we started on the kind of big yellow bubble on the left-hand graph, category 1. but we are actually well on our way to a, a, a full value-based care system. In fact, if I were giving this presentation, let's say pre-January 20th, the stated goal of CMS at the time was to have 100% of Medicare beneficiaries in a accountable relationship by 2030. 2030 is not far away, right? And we're actually probably a good 70 to 80% of the way there. Depends on how you view Medicare Advantage plans. Uh, but it's kind of well on the way there in terms of provider accountability. Big question I often ask as I speak about this is, well, what now, right? With the new administration, and I really don't know. I really don't know. There's a lot going on at the federal level, of course, but I think most experts think that value-based care is here to stay because the path to value remains very necessary to offset the high cost, low quality fee for service formula, no matter who's sitting in the White House, right? And especially if we're talking about tax cuts and other things, there's going to be pay fors that are looked at closely. And I think CMS is kind of all in here. So I'm going to just finish up here, and then I'll be happy to take some questions. I talked about fee for service, why that wasn't ideal, and why that kind of created a low value healthcare system that the U.S. is known for. In general, of course, that's not the case in every case, but in general, and why value-based care is going to change the way we practice. In this section, I'm going to just end with why we should embrace this change. Change is very difficult, but this is actually very exciting for us. And to do that, I'm going to first start with this one slide. So this is a slide from PTAC, the Physician Payment Advisory Committee I'm part of. We actually did a presentation on patients with serious illness and complex chronic conditions, our patients. And what this graph shows is actually really mind-blowing, right? It's saying a very small percentage of Medicare beneficiaries account for a large proportion of Medicare spending. And this graph is from MedPAC originally, which is a federal committee that advises Congress on Medicare payments. But MedPAC found that 1% of Medicare beneficiaries account for 17% of fee-for-service Medicare spending. The top 5% most expensive beneficiaries account for over 40% of Medicare spending, and the top 10% of most expensive beneficiaries account for almost 2/3 of the entire Medicare spending. Meanwhile, on the other end of the spectrum, the 50% least costly beneficiaries, the golfers, the skiers, the world travelers, only account for 3% of fee-for-service spending. And so you kind of think about that, and you kind of think about how our payment system works, or in this case, doesn't work. It becomes pretty clear why there's been such little attention paid to PALTC as a whole, right? Because a provider can sit in clinic and see 3 to 4 healthy patients in the same amount of time it takes for me to see one of my complex chronic patients who has dementia, if family issues, end of life care. I mean, the list goes on, right? We're all there. But from a fee for service perspective, I could be generating much more income focused on the 3% healthy patients, seeing 3 to 4 patients in the hour rather than just 1 or 2 patients in the hour in our world. And that kind of speaks to why it's been such why workforce challenge is such a big issue in PLDC. I can tell you the biggest hindrance to the growth of our practice is finding high quality providers that really care about what we do and will take the time to do it, right? And what's exciting is that we think under value-based care with shared savings that addresses that problem. So you might ask me, so Walter, what's why are Medicare costs so concentrated in these expensive beneficiaries? Again, top 10% of most expensive beneficiaries account for almost 2/3 of Medicare spending. And this is what MedPAC wrote. Costly beneficiaries tend to be those who have multiple chronic conditions, are using inpatient hospital services, are dually eligible for Medicare and Medicaid, and are in the last year of life. Sound familiar? Like these are our patients, right? These are our patients. And um, I think this is why I'm so excited about the future of PLTC. And that's because we can do a lot to both provide better care for these patients, but also participate in the savings that we create um, under value-based care. Uh, Really, this is like value-based care is in total alignment with CMDA's mission statement, um, providing, uh, promoting the collaboration and delivery of the highest quality care in PA-LTC medicine. It's also in 100% alignment with the PulpMed national mission statement. Uh, it's a world where all of our patients receive the highest quality compassionate care for optimum health function and quality of life. So it's mission alignment, number one, um, reason why the future is bright. But the other reason is that's what money is. Like I just showed you a graph where our patients are amongst the most costly beneficiaries that Medicare insures. And by doing the things that we all hear about at these conferences, including this morning, we can actually make a big difference in improving both the quality and lowering the cost of care and participating in the shared savings, ideally, right? Um, so I really do. And I should explain who knows who Willie Sutton is. All right. So Willie Sutton was a bank robber, I think in the early 1900s, who was on the FBI's 10 most wanted list. This guy was a character. He was fond of very expensive clothes. It was often described as being an immaculate dresser, right? But he was apprehended, and when he was asked why he robbed banks, Sutton simply replied with some bewilderment, "Well, that's because where the money is, right?" like, and that's like our patients. Our patients are where the money is, and by doing some very simple things, providing good care to them, we can actually uh, achieve the dual goal of improving quality and reducing costs. I really do believe that we are truly at an exciting moment in the history of PALTC. CMDA, PulpMed's mission and values have never been more critical or relevant because for the first time, federal payment models are aligning with what we already know to be true. High quality, patient centered, and proactive care in PALTC settings leads to better outcomes and lower costs. It just so happens that the PALTC population is amongst the most expensive beneficiaries that Medicare insures. There's some very kind of basic day-to-day blocking and tackling things that we do to that can both improve quality and decrease costs. So complete mission alignment here. So take-home messages. I think I started out by saying that we should expect continued cuts to the physician fee schedule under fee-for-service. Medicare is trying to make fee-for-service increasingly uncomfortable. The future of payment is value-based care, and the goals of value-based care is to both improve patient quality and decrease costs. I didn't really get to this as much in this presentation because I wanted to leave time for questions. But the other great thing about value-based care is it puts primary care providers in the driver's seat because of the way the attribution process happens. And primary care is pivotal, right? And maybe if I come back next time, we could talk about how that is really going to, I think, revolutionize the primary care field, I think, and increase interest. But from our perspective, though, PALTC is in the sweet spot for value-based care, and so the future is very, very bright. um, under value-based care. I'm going to end with one last slide, and I'll take questions. And this is another Deming quote, and it is him saying, "Every system is perfectly designed to get the result that it does. Things really weren't working well under fee-for-service. I think under value-based care, we have a different payment system that will hopefully help us achieve these dual outcomes of better quality and decreased cost." Okay, questions? Anytime.
Wait. Okay.
Hey, thank you for that talk. I'm just curious in your practice, have you oh, you want me to stand up?
Oh.
Anyway, I'm standing now. So have you seen a role for like case management, social work, or palliative services in your practice
Yeah,
that you've been utilizing?
absolutely. So, um, one of the keys that we all know to provide good care to our population of patients is highly coordinated care, right? And so, definitely, case management is super important in that function, whether it be from the facility level or the practice level. And then, in terms of how do you take better care of these patients and also reduce costs, a big part of that is palliative care and hospice and end of life care, right? So, understanding what the goals of care are for our patients and then providing goals and coordinated care is at the core what value-based care is all about. And a lot of that is appropriately having these end of life discussions and providing palliative care and hospice care.
Thank you so much for your talk, Christine LaRocca from Intelligent. So I really appreciate your optimism. I think for a nursing home audience, with the tension though, is that ACOs, bundle payments, any value-based model incentivizes shorter lengths of stay in nursing homes, Medicare Advantage plans in particular. So how do you have any sense of, since skilled nursing facility beds are paid per diem. So what's the optimism for the nursing home? Uh,
That's a great question. So I could answer the question on several different levels. So at one level, right, what we're talking about under value-based care is a bit different than Medicare Advantage plans because the way I think about it is for Medicare Advantage plans, we have an insurance company in charge of the patient's care. We have UR that we have to answer to, right, in terms of last cover date decisions and that kind of thing. Under what we're talking about here, value-based care, like for example, under ACOs, it puts the provider much more in the driver's seat because how ACOs work is providers will just continue to bill fee for service throughout the performance year. All those costs are added up uh, the year after and then compared to the benchmark. So it's fee for service. And it puts the provider in charge, but there is a kind of a true up, which is what makes the big difference there. So I'm much more kind of optimistic in many ways about uh, providers and control of kind of payments and clinical decisions. But at the end of the day, though, I do think that we want to provide high value care, and so we want to um, you know optimize length of stay, right? Like we want every day in short stay to be a day of value for our patients, and that's why providers are so important. We want to control their anxiety, we want to control their pain, we want to make sure that we catch any increasing shortness of breath because of CHF, potential CHF exacerbations early, so we can treat in place. And so that's all very much incentivized in value-based care, and we want to be known, I think, as an industry as providing high value post acute care in this case, and getting people back to where they need to be quickly.
It seems like lots of organizations have tried to form ACOs and have not been successful. Why do you think that's so?
Yeah. So that's a great question, and it gets pretty complicated pretty quickly. But essentially, uh, at a high level, it's because a lot of organizations mix different patient populations, right? So I gave the like bookends of the spectrum before, where I said your ACOs that focus primarily on outpatient care, like 65-year-old skiing, traveling the world, and then the other end is our patients, right? And when you have like for example, a health system or a university forming an ACO, it often mixes the whole everyone under that practices care. The university practices care, and so you don't have the appropriate benchmark that's set. The outpatients uh, dilute the cost of the nursing home patients, right? And so when it comes to kind of how ACOs work, it's really important to have a homogeneous population so that an appropriate benchmark can be established.
Thank you.
Hi, I'm wondering if you could comment on how value-based care may impact healthcare disparities and social determinants of health. And let me kind of give you a little framework. So, in the early section of your slides, you had a slide that showed the relative per capita healthcare expenditures of the major OECD nations. And there is a corresponding slide I've seen out of the World Health Organization that shows that graph, and then coming in from the opposite side of the screen, the matching bar graph for expenditures on social cares. And when you put the whole thing together, everyone's got net fairly equal per capita spending. And what that graph kind of speaks to is the reality in the US that, other OECD nations tend to socialize medical care. We in the US medicalize social care. And so my experience, I have two main buildings that I cover. One is in a stable middle class community and has a very stable population of middle of the road patients. The other one is located in a very affluent community and has extreme dichotomy of about half their patients come from the wealthy families needing long-term care, and the other half are the extremes of lifelong social, I hate to use the word failure, but people who have really been outside of the mainstream of society from birth and come in with all of the medical complications of their social problems. And the impact on the two buildings is so drastically different. And yet, from a conventional healthcare standpoint, I could see them, calculating as similar populations based on their medical diagnoses. And, you get a few points here and there from a couple of diagnostic labels for social determinants of health. But how can value based care actually address the realities of the social disparities that affect our patient populations?
Yeah, that's a great question. I think it'll probably be out of time, so we can talk more about this kind of offline. But what I would say is, of course, value-based care is not going to solve all of society's ills, right? I mean that's probably outside the scope of value-based care. But what value-based care does create, though, are funds that can be used to better care for people in different settings of care with different STOH factors. So, for example, if you get shared savings, some practices have decided to invest those shared savings in a care manager that will be calling patients up to make sure their medications are refilled, to check in on them, to see if they have any new symptoms that develop, knowing that that care manager is being paid for by keeping the patient out of the hospital and sharing in the savings, right? So it does create resources to address some SDOH factors, which we all know impact our patients in many ways, right? So it's not a panacea to everything, but I think there is kind of at the margins there help that value-based care can provide to SDOH issues.
Yeah. It is too. It's just.
Thank you so much. We're going to break for lunch and we'll see you back here at 1 o'clock. Also, there was a small pendant, circular pendant with the diamond in the middle that was lost. If anybody finds it, if they can bring it to the front desk, I'm sure the person will be very grateful. Enjoy the lunch. Thank you.
This
Good afternoon, everyone. Gosh, that's a little loud. We are so excited to start the afternoon with our partners from CDPHE, and we're so lucky to partner with them every month, every day. Unfortunately, Joe Tansey is not able to be with us today, but we are so excited and so lucky to have Chad Fear come and present to us today from CDPHE. And I know you want to know more about Chad, so hold on. Okay. So Chad has been a surveyor for over 15 years, and he served nursing home facility supervisor for 6 years, becoming the section manager in 2021. He has been a phenomenal partner with all of us and has really advocated for high quality patient care. So it's really my honor to introduce Chad Peer.
I didn't write that last part, but yeah, so I apologize if you were anticipating being able to come here and hear Joe Tansey talk, sit in the audience and listen. I thought I was going to as well. So we're sorry for the bait and switch. And here we go. So I guess falling in step with what's our why. Just wanted to cover our mission here a little bit. I normally joke that I'm seeing these slides for the first time myself, and actually today it is true. So bear with me just a little bit. But it is our mission at CDPHE and with health facilities and emergency medical services to protect the health, safety, and welfare of all healthcare system users, ensure access to quality healthcare for all Coloradans. In healthcare facilities, in emergency medical services division, we have been following this philosophy for a number of years. And when we come out and we do surveys, we share this at every opportunity. And that's because we want to establish our relationship with you and the purposes for our visit. The R, we reach. Hopefully we're reaching high. But the R is reliability to all stakeholders, citizens and visitors. E, 3's, efficient, effective, and elegant in all services and interactions. We are public servants, and we hope to fulfill our roles very much in this manner. Accountable, transparent, and have collaborative interactions. I really want to emphasize the collaborativeness. I think that the relationships that I believe Joe had started many years ago, and that I've hoped to carry on, have all been about the collaboration that we have between us as regulators, you as the community, and of course medical directors and their role within the community. Compliance through balanced sanctions and fair practices, and we try to be helpful when possible. Nursing facilities, we have 211 currently licensed nursing facilities. The figures that we have are for last calendar year. We had 2 closures during that year, Flatirons and Brookside Rehabilitation and Wellness. I believe this year we've also had another closure. We conducted 150 recertification surveys out of the 211 facilities. 376 federal complaint investigations were completed in addition to 54 state complaint investigations. I can say that our workload with complaints, as well as the facility reported incidents that we triage and have to come out and conduct visits, have increased significantly, even above these numbers. So nursing facilities. First off, where's Jenny? Jenny, you did a great presentation. I could just stand here and say any questions that I can answer for what Jenny presented. You did a really good job of pulling that all together.
Um, in its entirety, it doesn't appear to be so much, but when you look at the application of all of these changes and how it affects the responsibilities that everybody has, it is enormous. I was having a conversation earlier, and so 35 years ago, I was a brand new social worker in a nursing home. And my first experience with the medical director involved donuts because that was, I don't even know for what it was called back then. It was the quality assurance meeting. We'd meet at 7 o'clock in the morning before everybody went to work at 8, and we met with the medical director who brought donuts. And that was my experience until, leaping forward to these more modern times, I guess, if you will, that that have been able to engage with many of you and to understand the relationship that we have, particularly with the regulatory requirements and now the growing regulatory requirements. Back then, and I'm not sure every setting was like this, but this was my setting, the medical director was a figurehead by name. Today, your being a medical director is a verb, it's an action, because it's going to take a lot of action to fulfill your role. By definition, the medical director will be the physician who oversees the medical care and other designated care and services in a healthcare organization or community. So not only is the medical director, as you're aware, responsible for helping to develop policies, your facility assessment, which is so fundamental to everything the facility does, the emergency preparedness program, and the plan that's developed. But the medical director is also responsible to ensure that those policies are being implemented. That's the action. That's more of the action. There's been a lot of changes to our our survey process. And in they're called critical element pathways. It's guidance that we have to conduct the survey. There are more instances now, maybe not today, but when is 28th? Monday? Yeah. So on Monday, there are going to be more instances where we interact directly during the survey. We have lists of questions that we're going to have to discuss with the medical director, whether it be about your involvement in a specific care issue or area, or whether it is discussing the quality assurance process that you're engaged in to self-identify and correct any sort of issue that the facility may have identified, and looking at the medical director's role in that process. It's up to the community to decide how the medical director will fulfill those responsibilities in order to effectively implement those care policies. Because the community must ensure that all responsibilities of the medical director are effectively performed, regardless of how the task is accomplished or the technology used. So that's to say, this doesn't mean you have to be in the facility 2 or 3 times a week or whatever that looks like. There are, modern advancements that allow us to interact with each other in so many different ways. But I think what it comes down to is, if you ask the question, how much, I think the answer would be how much is needed. And that's going to depend upon, I believe, the strength of the policies and the staff who are implementing those policies and the ability, you as the facilitator of all of this, the ability of staff to follow those processes. Medical directors' responsibilities must include, as I said, implementation of those care policies. And then it's the other piece. It's your ability to interact with your peers. And one of the big things that you'll see with the changes is that whole unnecessary psychotropic medication thing, right? PRN medications, psychotropic medications being prescribed, antipsychotic medications being prescribed in the absence of schizophrenia. And looking at the medical director's role in communicating with the prescribing peer and working through a process so that the resident is getting the care that they need in a manner that allows the facility to be compliant with the regulation. We, Dr. Eber and I had this conversation just barely, and so no, we don't expect that if you admit somebody on a Saturday, that Sunday morning you're going to be trying to get a hold of your peer professional saying, "Hey, we got a problem with this," right? Because you shouldn't discover it then. It may have been discovered through the admission process. We're bringing somebody in with this situation. Let's try to resolve it before the person's admitted to the facility. Or if it's a change that happens, what we're going to be looking at is the process that you've engaged to address the issue. There really shouldn't be a situation where we would expect the overnight turnaround to resolve the issue. We want to be reasonable in our approach, and I think that gives you an opportunity to address those concerns. I'm getting the warning, and I always do this. Other responsibilities, you're at the administrative decisions, ensuring the appropriateness and quality of medical care, assisting in developing, underline this, the educational programs for staff and other professionals. Know the needs of your residents and see that staff are being educated to address and be able to meet those needs. Providing support, promoting person-directed care, assisting in identifying performance expectations, so your involvement in the quality improvement process, and being able to help facilitate feedback to those other professionals who are the primary physicians, perhaps for other residents living in your facility. Discussion, intervene with those professionals when there are disagreements with compliance with the regulation and perhaps the guidance or direction that professional is wanting to follow. So I've got some figures for you to kind of end here, and these are some figures that are going to include not only nursing facilities, but in later slides, it's going to be the congregate numbers for health facilities. State fiscal year, and this is going to be from July 1st, 2024 until current. 1,684 deficiencies were cited. Okay. Initial inspections, and again, these are congregate numbers for the health facilities, not just nursing homes. You can see from year to year, our numbers of initial inspections are relatively the same. Relicensure inspections, we have more facilities that are being relicensed. License infection control surveys. So these are facilities that may not necessarily have federal regulations around that. We conducted 5 of those. Occurrence investigations. We're pretty consistent with over 5,000 occurrences. So through the occurrence reporting system, the things that the facility types that need to report through that system, we're 5,000. Complaint intakes, you can see an increase from one state fiscal year to the other. I would anticipate this is upcoming state fiscal year, those numbers are going to be even bigger. So enforcement, just to let you know, we had 104 changes of ownership occur. I'd like to also point out the intermediate conditions, including fines and requirements to retain a consultant. In 50 settings, we required some more intensive or advanced enforcement remedies. Recent projects, we have some openings in our programs, as you can see, and we are working on train the trainer concepts, because when you bring in so many new people, it's going to be very difficult to have 1 or 2 trainers. It creates a bottleneck. So we're working on precepting, we train the trainer concept so that we can get people trained and educated to be able to have those good, solid interactions with everybody. Projects that are going on, behavior health entity projects. I think you'll all probably get these slides as a result of being here today. So just wanted to cover a few of these things. The BHEs, the behavioral health entity, have been transitioning from CDPHE, where they were housed previously, to its own entity, the BHA, which began oversight in July 1st, 2025. EMS, I think I'm going to have to talk really fast again. You can look at those figures later, apparently. And you can see that even through the EMS programs, there are a number of complaints that have to be investigated, background applications reviewed. So the renewals and for new providers, 298. Some leadership changes. I do definitely want to stop here and mention this. We have a newly appointed emergency medical treatment services medical director, Angela Wright, who started in April 2024, and our newly appointed deputy division director, Jackie Irwin, who is over nursing facilities, is one of the programs that she's over, and acute care. And she started in February 2025. I don't know if she was able to make it today as well, but I think you'll be seeing her around for some of these meetings very, very soon. So with that being said, and a few more slides, if there's any questions that you want to email me, I'll make sure Joe gets back to you very quickly. All right, thank you.
Yeah.
So we are now, we have a panel on medical marijuana and long-term care. And that panel consists of Dr. Danielle Fixon, Associate Professor of University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences. Her research interest includes cannabis use in older adults and transitional care management and medication deprescribing. She actually gave an excellent talk at one of our CMDA journal clubs on use of medical marijuana. You can find that on our website. We have Alan Horowitz, who is an attorney at healthcare practice at Arnell Golden Gregory, and is a member of the post-acute and long-term care industry team. Alan has also given several presentations at CMDA monthly meeting. The last one, I believe, was medical aid in dying. So we really appreciate his collaboration. Dr. David Shepard is actually just learned an MBA, who is the CMDA treasurer. So we are hopefully in good hands. And Dr. Shepard has also given multiple journal club talks, most recently CHF. Last but certainly not least, one of the best physician assistants I know, Allison Villegas, and I know that she's good because I helped train her. So I'm going to let you start.
Thank you. So hi everybody. I know it's a hard time to present after lunch, but this is a super exciting topic. So hopefully we'll get a lot of interaction. We do have a Slido. Hold on.
Hopefully.
There we go. So if everybody wants to take a minute and log in, if your QR doesn't scan, you can just go to slido.com. And I listened to too many podcasts because that just sounded like a podcast. Okay. So keep in mind, these questions that you submit will be anonymous unless you accidentally click the button and type in your name. Or if you have an account already set up, like our fearless leader saying had one set up. And so it does show if you have an account. Otherwise, your questions will be anonymous. They will be shown to everyone. So try and keep your questions, on topic. Which it is cannabis. So what can we say? So we have an excellent panel here, very interdisciplinary. Oh, there we go. Nope. See, no. Oh, it's the wrong way. There it is. Okay, we're obviously going to start with a case. This is Mr. THC. He's a 66-year-old male. He resides at your long-term care facility, which I think it would be fun to call it Green Acres or Indica Hills. I don't know. I'm going to see how many
cannabis related puns I can pack into this bad boy. That was your third one if you caught that. This gentleman has a past medical history of protein calorie malnutrition, schizoaffective disorder bipolar type, pseudobulbar affect, PTSD, chronic pain syndrome, and naturally a history of falls. You discovered that this gentleman has been vaping cannabis in the facility and admitted to use over the last 6 months, but we didn't really know. So we're finding this out now. While we're starting, 'cause we do have a few slides and some content to kind of set the stage and give some context about the discussion, I want you guys to start thinking about your first thoughts. What's your first reaction when you hear about this gentleman who's been vaping in your facility? Do you have questions for him? Any concerns? You saw his past medical history. So maybe start noodling on that. And that would have been an opportunity for a pun somewhere. I can think of it later. But while we're setting the stage, we're going to start with Alan.
Thank you, and it's a privilege to be here and speak to you folks from Colorado Medical Directors Association again. And just by way of full disclosure, I used to represent CMS in Region 3, but I saw the light, and for the last 13 years, I represent providers around the country. I usually spend an hour or two talking about this topic, but since I only have 10 minutes, I'm going to talk fast and ask that you hold your questions until the end. I have no financial interest in this whatsoever, no conflicts to disclose. But what I want to talk about for the next 9.5 minutes are the legal issues that each of you face, and as well as your facilities and potentially all of your employees as it relates to medical marijuana. So here's the conundrum that we all face, not just in Colorado, but in the other 37 states that have legalized medical marijuana. There are 38 states that have legalized medical marijuana, which creates a problem because while it's legal here, both medical marijuana and recreational marijuana, it is absolutely illegal under federal law. And the problem that presents for you and your facilities is when you agree to be a Medicare provider, you sign a form that says you agree to abide by all state, federal, and local laws. So you're basically breaking federal law if you allow medical marijuana in your facility. But the good news is, and I'm here to tell you that you're not likely to be prosecuted at all so long as you strictly comply with state law. Marijuana, as the slide indicates, has been legal. Medical marijuana has been legal in Colorado since 2000. It was first commercialized in 2009. I'm not going to go through the numbers of users, although what we're seeing in Colorado mirrors what we're seeing in the other 37 states that have legalized medical marijuana, which is exponential growth. Again, medical marijuana is not FDA approved. Clearly, as I'm sure most of you know, last year in August of 2024, HHS had recommended, after an exhaustive study, that marijuana be reclassified as Schedule 3. It's currently Schedule 1, which means it's in the same category as LSD, heroin, and I don't think any reasonable person would argue that marijuana belongs in Schedule 1. There's currently some tension between HHS and DEA, and with the new administration, it's hard to see when we're going to see the change to Schedule 3. I predict we will see the change to Schedule 3, and once that happens, it's going to be several months before the FDA rolls out regulations dealing with it. So it's going to still be a while before it's legal at the federal level. So here's the schizophrenic approach from a legal perspective. Again, it's absolutely legal, both recreational and medical marijuana in Colorado, but it's absolutely at the same time, it's illegal under federal law. So what's a provider to do? And when I do these presentations, I get asked by docs, NPs, PAs, DONs, administrators, what's my liability if I allow a resident to use medical marijuana? Again, assuming it's in one of the states like Colorado that allows for medical marijuana. Well, let me back up a little bit. So in Colorado, here's the law. Any MD or DO can recommend medical marijuana for a disabling condition such as AIDS, HIV, cancer, and there are about a dozen other conditions. NPs, PAs, even dentists can recommend medical marijuana for debilitating conditions such as PTSD or any condition that would otherwise require opioids. The requirements for somebody to have a card, a medical marijuana card in Colorado, are that the individual be 18 or older. They must have a qualifying medical condition, which is not hard to do. There are at least 12 or 14 conditions, and there's even a mechanism that the state legislature has enacted to allow other conditions to be added to the list. So it's not very difficult for somebody with a bona fide medical condition to qualify for a medical marijuana card. It's good for, it does require physician certification. And if there's going to be a caregiver involved, the caregiver also has to register. The application process takes about from anywhere from 6 to 8 weeks. In terms of the physician who's going to certify someone that's having a qualifying medical condition, those certifications are good for 1 year. For a debilitating condition, a disabling condition, the card is good for 60 days, could be up to a year depending on the circumstances, and the application fee is $29.50. And this is the last slide I'm going to use because if you take away nothing from my portion of the presentation, it's going to be the things I talk about here. And these are some of the practice tips that I advise clients around the country. When I say clients, I'm talking about skilled nursing facilities and hospices primarily that ask me legally, what can we do? Our residents want it. We just admitted a resident who's been using medical marijuana at home. He or she is a registered user. Their physician has recommended it, but we're a skilled nursing facility covered by Medicare. We don't want to get in trouble with the feds. What about the surveyors? Well, don't worry about the surveyors. The surveyors don't even have guidance about this. CMS has taken a hands-off approach so far. They're waiting for DEA and the FDA to act. So I can almost assure you, you're not going to be surveyed or you're not going to be cited with the deficiency dealing with medical marijuana. If anything, I would argue if a facility did get a deficiency regarding medical marijuana and then complied with state law, then it's residents' rights. And as you all know, at 42 CFR Part 483, which are the requirements for participation, you have an obligation to accommodate the residents' needs. Residents have autonomy. So I would argue that it's a violation of resident rights not to allow a resident who's a qualified medical user who has a recommendation from a physician to not have medical marijuana. The good news is, as I said, you're not likely to be asked any question, not even asked a question on a survey dealing with medical marijuana, at least for now. What I absolutely recommend is that you have a policy and procedure dealing with medical marijuana. There are 4 possibilities that all of your facilities are going to fall into now and in the future. You allow medical marijuana, you allow recreational marijuana, you allow both, or you allow none. Whichever of those 4 positions your facility takes, my recommendation is that you have a policy and procedure that explains everything. A key component of that is staff education. Many of the staff may feel that it's not right for grandma or grandpa, and I'm using the terms advisedly, to be vaping or eating gummies. Well, just like with sexual intimacy and other areas that residents can be involved with, it's not up to the caregivers. We're talking about resident rights. So it's important that there's an education for the staff also, so the staff knows what to report. If you're in a facility that doesn't allow any form of medical or recreational marijuana, the staff needs to know that. I always recommend whatever your policy is, whether it's about smoking, about medical aid in dying, although I see that more in hospices and skilled nursing facilities, let a prospective resident know at the time of admission. I mean, rather than have somebody admitted and down the road, that person says, well, I didn't know I couldn't use medical marijuana. My doctor has recommended that for the last 3 years, and it helps my pain. I don't have to take opioids when I'm using medical marijuana. And you don't want to be in a situation where at that point you're saying, well, we don't allow it. So I recommend, just as I do with all policies and procedures, letting prospective residents and their families know up front. A couple of other points very quickly. And these two things are somewhat controversial, or at least there are some people that have a different view, and I respect that. But if you're asking me, to give you legal advice, I recommend two things. Number one, have a signed consent, a simple consent that says, my physician has advised me that medical marijuana is not FDA approved. Well, I have discussed the risks and the benefits, and I've chosen to consume it or not. That would go a long way towards defending the physician, the DON, the administrator, and the facility. If a resident falls and plaintiff's attorneys sues the facility and they get the medical record and they see that the resident was using medical marijuana, and they put the doc or the DON on the nursing stand, and they say, well, isn't it a fact that you allowed resident X to use marijuana? And is it also a fact that that's not FDA approved? So again, having a waiver goes a long way at defending against bogus lawsuits. And the last thing, other than a consent form, which again takes 2 minutes to draft, you don't even need a lawyer if you do that right, is I recommend putting marijuana use in your MAR, just like any other drug. I know that some facilities have a don't ask, don't tell person. I personally don't believe in that. I don't make that advice. I think that it's important to, for example, if you've got a patient a resident with pain of 8 on a scale, and after consuming a gummy, they rate their pain as 2, I think that's clinically significant. I think that the team, everyone involved from the physician, social workers, certainly the nurses, PA, NP, everyone on the healthcare team needs to know if the medical marijuana is effective or not. So I think including the type, the dose if possible, and the time it was consumed, I think it's appropriate to put that on the MAR form. My time is up, and I'll be sticking around for some questions later. Thank you very much.
All right. So I'm Danielle. I am a pharmacist. And so most of my information, just a few slides, is going to be in relation to safety that we should consider in our older adults. So this slide, again, I usually provide this presentation in like an hour, hour and a half. So this is just like a quick snapshot. But what I want to say is that when I started looking into cannabis use in older adults and trying to determine if it was safe with other medications, there was no sort of drug information resource that was available to actually look at interaction. So I was like looking on PubMed, looking at, any case reports that were out about cannabis and different drug interactions. Now, at least the two drug information resources that I use, which are Micromedics and Lexicomp, they both have CBD and THC. So if you have a resident's medication list, and you know that they are utilizing, maybe it's a combination product that has both THC and CBD, you can actually type that in and see if there's an interaction. Kind of some other big clinical pearls to think about. THC very much has CNS depressant effects. So if they're on a lot of other CNS depressant medications, then it could either even further exacerbate some of those effects. And so that's just something to think about and keep in mind. And then in terms of CBD, really we can see some sedation at higher doses of CBD. So that's just something to keep in mind if you have patients who are on other medications that can cause sedation. And then the last thing I do want to point out, I know we don't have a ton of patients that are on warfarin anymore. However, I would say that's probably where most of the evidence is in terms of both THC and CBD with drug interactions really causing INRs to skyrocket. So if you have a patient who's utilizing warfarin and you know that they are, using a cannabis product, then I kind of treat it like I do my leafy greens. I say, if you're going to utilize cannabis, I need you to be consistent with that.
So, you're not able to take a big dose on Friday and then not use it again. We need to really keep those doses consistent, just like you would with, the leafy green vegetables. Okay, contraindications and warning. This is another thing that I really like to, look at in a patient's medical history to ensure that cannabis would be safe and appropriate. For THC based products, there have been a lot of reports in patients that have either prior history of psychosis or maybe even unstable psychiatric conditions where THC can cause a patient to have a psychotic episode. And so this is a patient population, that I would be really cautious with use of cannabis, specifically THC. I wouldn't even mess with it. I will say, in terms of studies that they've looked at, in seeing, maybe what some risk factors are, it does appear that women have a higher risk than men, and younger age. So, maybe our older adult is a little bit more protected. However, again, this is something that I really think that we should be having that risk versus benefit discussion over. Cardiovascular disease and histories of, heart attack and AFib. THC can actually increase the heart rate. There's been reports that it can increase heart rate up to 40 beats per minute. So that's pretty significant. And then there's also been reports of patients who have recently had a cardiovascular event where when they utilize a THC-based product, they can have a recurrent event. So another patient population that I would, be very hesitant to use a THC-based product with. CBD, these are the warnings that are actually from the FDA. We do have one FDA-approved CBD product called Epidiolex, but it's used for a rare form of epilepsy. And so a lot of these warnings are just, saying, hey, we want you to know that there's, the potential of liver injury. There's also caution with other medications, specifically those CNS depressant medications. Okay, and then, oh, sorry, this didn't show up exactly how I wanted it to, but I will give you the highlights. So, for comparisons of THC and CBD, what I want you to know is that THC, and you probably already know this, is it's the product that really causes those feelings of euphoria. Patients, may have a feeling of being high, whereas CBD really doesn't cause those types of side effects. A lot of patients have reported that CBD actually has anxiolytic properties, so it can really help decrease anxiety, where THC is kind of, some patients have had reports where it decreases anxiety, but then others that may actually cause a little more anxiety related behaviors for those patients. Both CBD and THC are antiemetics, and so they could be useful in patients who have some nausea. And then again, you can just see at the bottom that really more reports of tachycardia with THC compared to CBD. So for me, whenever I look at the two, and I would say these are the two main components of our cannabis-related products, CBD appears to be a safer product. In terms of just some of the effects that it may have on patients. However, there are side effects that we have to think about. Patients that I've talked to that have utilized CBD, I think one of the biggest side effects is GI-related side effects. So, maybe some nausea. I think that's the biggest one that I've heard patients complain about. So if they're on other medications that could cause nausea, or if they have issues with nausea, then again, we need to really think about if CBD is going to be that best product for that patient. I mentioned the sedation and drowsiness, which generally occurs at higher doses, and then both of them can cause dry mouth. So for our older adult population who's probably taking at least one anticholinergic medication, this is something to consider. So THC definitely appears to have a little bit more anticholinergic side effects compared to CBD, but both can cause dry mouth and be a side effect that patients experience. Okay, so with that, we'll get to your questions.
So just I meant to ask this before. Has anyone been in a situation with a Mr. THC? Or am I the only one who has seen somebody who's like, I want to use some cannabis? It's less common, and this actually kind of surprises me. Can you guys raise your hand if you've heard something up here so far that has made you raise your eyebrow or kind of surprised you? No. All right. Oh, okay. Well, Dr. Gone. There you go. Yeah. Yeah. I did not know that dentists could be recommenders, so that's interesting. So we're gonna just kind of go through that case, and I'm checking on Slido to see because I do want you guys to put in your questions because we do have such a great panel, and I know that this is really a nebulous topic that is coming more and more seen, at least in my facility. So I'm surprised by the very few hands that were raised. So anyway, I'll start because I've got lots of questions for them. So this case specifically, we didn't put his medication list, and we did that intentionally. But I think looking at his past medical history, you can envision what meds he might be on, and maybe I'll toggle back just so you guys can see his past medical history again. It was protein calorie malnutrition. Here we go. Schizoaffective bipolar type, pseudobulbar, PTSD, chronic pain, and falls. So you can imagine maybe what meds he might be on, and we didn't include them specifically because we didn't want to get into the weeds about specific drug-drug interactions. Oh, yes, someone laughed, and I didn't even realize I made a pun. That's great. Thank you, whoever was paying attention. Okay, so for the panel, what specific questions about his medication, his current medication regimen, would you want to ask Mr. THC before you have a conversation with him?
Start there. Start doing them. Hand them up to funds.
All right.
Yeah, I for sure would want to know, is he on an antipsychotic? Is he on a benzo? I mean, I would start looking for drug interactions pretty quick. And then, I would want to compare the efficacy of potential cannabis versus what he is on and kind of weigh your risk benefit there.
Yeah, I agree with that. I think knowing what medications, which ones, if he's having any side effects from medications, like sedation, if he's having, some CNS related side effects before, and even seeing if, since he's already vaping, if there's a point to where, we can try to figure out if we can taper off of a medication or balance some of the risk of the medications in combination with cannabis.
Apart from the pharmacological approach, from a legal perspective, I would be very cautious about recommending medical marijuana for this particular patient. I see 3 red flags. He has a schizoaffective disorder. You've already heard the psychoactive effects of THC. He's got PTSD. There's evidence that cannabis actually exacerbates episodes for individuals with PTSD. And finally, the third red flag from my perspective is he has a history of falls. Again, if he falls again, the fact that he's on medical marijuana is going to be used in a lawsuit against the facility. So from a legal perspective, even apart from the medications, I see 3 red flags here.
Perfect. That one's yours. I get my very own. No, I'm just kidding. So the great responses. So Mr. THC, if you guys remember at the beginning, I told you, he's been using this for 6 months and none of us knew. And this is actually a real case. None of us knew. And the story of how we found out is actually kind of entertaining. We'll save it for another day. But he didn't have any adverse reactions, side effects, or drug interactions that we noted in his 6-month journey that he was on. He reports several benefits to you from his use, including improved lability in his mood. He's sleeping better. He's finding that pseudobulbar affect is less prominent, and he wants to continue using. Knowing what you know about Mr. THC's current and past medical history, where could he potentially be seeing benefits from use? And what about potential risks?
Yeah, so I think we've already talked about the potential risks. So just with, the schizoaffective disorder, PTSD, I think with cannabis, probably some of the most evidence that we have is related to chronic pain. And so potentially if pain was something that was keeping him up at night and he's maybe vaping in the evening before he goes to sleep, maybe that's helping with some of that pain. I will say most of the evidence with chronic pain relief is specifically for neuropathic pain. And so that's where, I think he could be seeing most of the benefit of cannabis.
Stop.
All right. And you guys are putting in questions. These are fantastic. So I'm going to kind of cruise through mine because I want to get to some of theirs. I think we will address some of them through these. So Mr. THC, incidentally, does also have a guardian, just to now cloud our clinical picture a little bit more. And they've requested a care conference, and we want to talk about Mr. THC's recent use and his desire to continue using. How would you manage a risk-benefit conversation with the resident and its guardian?
Not flying under the radar on this one, am I?
Because
I really worry. I'm assuming that he's probably on some kind of an antipsychotic. So I think that really clouds it for me, the risk benefit, because you can increase your chances of psychosis, right? So to me, it's got to be a very specific conversation. And hope, is this person decisional? No, doesn't sound like it.
he has a guardian appointed.
And so that can get even harder, right? Because
Yep.
if he's not decisional, but he's adamant in the guardian per se, so it gets difficult quick. But yeah, I think you have to be pretty specific about your risk benefit discussion, given that he's probably on some kind of psychotropics here, at least one, I would guess. And he's got a history of falls as well. If his chances of psychosis are more, is his fall risk going to go up? Yeah, so there's a lot of aspects here to specifically address, I think.
And I like this case because it is so difficult, right? Like we're seeing this in our patient population so complex, and then we add in the legal complexities, and then the differing between federal and state law, and it makes me scratch my head every time. So I'm really glad we're here to have this conversation. So of course we're planning this care conference, and our fearless leader, the director of nursing, and the nursing home administrator certainly want to be there, given the content matter, right? So they're going to attend the care conference, and they're concerned about their legal liability. So this is a great one for you, Alan. If the care team decides to work with me at Mr. THC around his desire to use cannabis as part of his treatment plan, what would be their legal concerns, which you kind of touched on, but love to hear more.
Yeah, well, let me speak generally about legal liability for the caregivers. As long as you comply with state law, you have no liability under state law. That's number one. Let me also add, as long as you're complying with the facility's policy, if the facility has policy that is marijuana free, then and by the way, facilities can still forbid the use of medical marijuana in Colorado or any of the other 37 states, and do so on the basis of the fact that it's still illegal under federal law. What I would say is that, first of all, I'm not aware, and I've been doing this for over 10 years, I'm not aware of a single facility, skilled nursing facility or hospice, any place in the country that has been prosecuted for medical marijuana where they complied with state law. Likewise, I'm not aware of any DON administrator or others. So I think under state law, you're safe. And I'll go out on a limb, and I think you're also safe under federal law. And the reason for that is there's been a lot of back and forth over the last 3-4 administrations in terms of attorneys general taking positions. But apart from the fact that the last position from the Department of Justice is we're not going to prosecute anybody that deals with, uses, consumes medical marijuana so long as they comply with state law. In addition, every year since 2014, there's been a rider to the Budget Act. In 2014, it was the Rohrabacher-Farr Amendment. What that rider says, and this has been tested in the courts, is that we, Congress, we're authorizing some money to the Department of Justice. However, you may not use any of these funds to prosecute anyone who uses, possesses, otherwise consumes medical marijuana, so long as they're doing so in accordance with state law. We, the Department of Justice, have bigger fish to fry. We're going after terrorists, cybercrime, so the feds are not pursuing this. So at a federal level, there's virtually zero liability. I will hasten to add, a couple of years ago, there were 10 cases of felony arrests for medical marijuana for individuals in California and the state of Washington. They each, in all cases, they were registered users, recommended medical marijuana by their physicians. Department of Justice brought the case in federal court saying they violated the Controlled Substance Act. This is Schedule 1 illegal substance. The defense said, well, wait a minute, not so fast, Judge. The Congress just passed a budget that said DOJ, Department of Justice, is not even supposed to be here. And the case went all the way up to the Ninth Circuit. And the Ninth Circuit slammed the Department of Justice. So the law, at least in the Ninth Circuit, is Department of Justice can't even bring a case against anyone who uses or consumes marijuana, medical marijuana. Again, the caveat is so long as they're complying with state law. So I don't see any liability at all under the feds. And currently, if you comply with state law, there's no liability. The third part to your question, it's a complex question, is in this case, in the case of Mr. THC, there could be liability. If he falls, there could be liability. Anytime a resident falls, there's potential liability. And we all know that there are those firms out there that make a living on quote unquote nursing negligence. So there could be liability. But that's secondary to the accident that would happen if, for example, he fell.
I just wanted to add one thing here. You didn't say whether or not the facility has a policy yet.
They do not. They do not have a policy.
They're about to make one.
They're going to make one now after
So
this.
you might want to think that through before you get to the point where you need to lean on that policy.
Yeah. And I think I'm going to ask them all their takeaways. And my takeaway would be, we should think about this now. We probably should have started thinking about this. When did recreational become legal here in Colorado? 2007? Something. Anyway, we should have started thinking about it then because, we knew that this was an inevitability. Or again, at least in the facilities where I practice, I see a lot of it. So you talk about a policy and procedure. What would be something like components in that you would recommend for a facility to include to kind of protect themselves? Now, if they want to write one, maybe they're calling you up and they're saying, hey, Alan.
Okay, so your policy and procedure should indicate under what circumstances medical marijuana can be used. I would suggest that you articulate that recreational marijuana is not used unless you have compelling reasons to allow it. So specify the kind of marijuana. Is it recreational or is it medical? If it's medical, the policy and procedure should indicate that a physician has recommended that, and that's on record is documentation of that you have a photocopy of the residence registry, that they do have a qualifying medical condition, that you've done staff education, that there's a mechanism for agency staff to know what your policy is, as well as new hires that you onboard. And oftentimes facilities, even great facilities with great policies, overlook this. Include your employees. What do you do, or what will you do when it turns out you have an employee who falls out of work or has a work-related injury, goes to the ER, and cannabis shows up? You're in a drug-free workplace. Now, some states have actually terminated employees who've tested positive, who were medical marijuana users, who had a registry card and a recommendation from a physician. And in California, which is really surprising, coming from California, the courts in California upheld the termination. Same set of facts. Actually, in both cases, it was a supervisor at Walmart who had a workplace injury, and as required by policy, they had to go to an ED. Cannabis showed up in their blood, and what happened in Arizona, they fired the employee. Again, the employee used medical marijuana at home, consistent with the physician's recommendation and their registry card. There was no poor performance at work, but they were fired. In Arizona, the courts ordered the employee to be rehired, back pay and interest. California, that's not the case. So I recommend whatever your policy is, whatever your governing board decides, how are you going to handle employees? Are you going to allow employees to come to work and use medical marijuana if they say, I need this for my pain, it's the only way I can work? Or what about employees who say, I only use medical marijuana when I go home because that's what my doctor has recommended? So to answer your question, I think your policy needs to anticipate every conceivable situation, and I would be over-inclusive rather than under-inclusive.
And just to give an example, I think it's the Minnesota Health Association. They have quite a few like templates of different types of policies. So one that's like we do not allow medical marijuana at all. To we allow medical marijuana, but it is like stored in a locked box. It's added to the patient's medication record, and so that's a good place to find some example templates.
Yeah, I just want to thank you for that. The Washington Healthcare Association also has some excellent policies and procedures on their website.
Do you want to talk about Dr. Palace? Because I don't know if they can model Zachary Palace. Is it Palace? Dr. Zachary from the Hebrew Home? Like, because they have a protocol.
Yeah. Okay. How many of you are familiar with Dr. Zachary Palace? Zach Palace is a different. He's a brilliant medical director. He's a member of, I was going to say AMDA, PALTMED, sorry. Actually, Zach, I commended an article for those of you that are PALTMED members. You can get this online. There was an article that was published in JAMDA, the Journal of the American Medical Directors Association, that Zach authored a few years ago. Zach is one of the pioneer physicians and medical directors who uses cannabis consistent with New York State law. Zach is the medical director of the Hebrew Home, and I know they have been very much on the vanguard of policies dealing with sexual expression, use of medical marijuana. I once asked Zach when we were doing a presentation a number of years ago, I said, well, how do you know and how do the physicians and PAs and PAs can't prescribe it or recommend in New York. I said, how do the physicians you supervise, how do they know how much to start, what dose? And in New York, there is a specific dose. And Zach told me, he just smiled and said, Alan, it's like everything else in medicine. I tell the docs, start low and go slow and gradually build it up. And the experience that they have at the Hebrew Home, they've been written up in the New York Times, other magazines, very positive. Anecdotally, Dr. Palace has reported that he's been able to wean a lot of the residents off of opioids who are more active, obviously, because they're not sedated and they're not taking habit-forming opioids, and they're replacing that with cannabis under physicians' supervision.
Great, thank you. And we're winding down on time, and I knew that this 45 minutes was going to go super fast. We're not going to get to a fraction of these questions, but there are great resources that we'll send out to everybody because there's a lot of questions on here about evidence-based and how do you know when to use. And there's the Skagg School of Pharmacy has a great cannabis use for medical providers. It's like an 8-week course, and that's where you can get like the up-to-date information on that. I think the last question I kind of want to leave you with is what if they adopt the policy of don't ask, don't tell? And what potential pitfalls do you see both as a clinician and a lawyer and a pharmacist? Where is the danger in that? Because that's, I think, the primary PMP that we're seeing now.
Yeah, I think from a medical standpoint, that's a horrible idea. We want to know if our patients are using, substances outside, whether it be marijuana, cocaine, alcohol, smoking even, right? We want to know those things because all of those things can affect their treatment plan. And they can have drug interactions and it can be life-threatening to mix a lot of these things. So I think sticking your head in the sand is probably a bad idea in this case. So I 100% agree with the idea that we've tried to outrun this for a while now. And we're running out of runway here. It's time to probably develop a policy. I know myself, I need to get much more educated on it, whether or not I choose to prescribe it because of the legal liabilities. That's something I'm going to have to grapple with and come to some kind of decision. But I don't think ignoring it is going to work.
I'll just quickly echo what Dr. Shepard said. I think it's absolutely horrible and a dangerous policy to have. Just a couple of quick examples. If you take the policy, don't ask, don't tell, you don't record it in the MAR. When the pharmacist does the medication regimen, the pharmacist may miss something significant. There may be a drug-drug interaction, or as Dr. Dixon pointed out, there are some drugs that are not necessarily compatible with cannabis, but the pharmacist wouldn't know if it's don't ask, don't tell, and you're not recording it. Plus, if there's a completely unrelated adverse outcome, and there will be adverse outcomes, obviously, in SNFs, there's an adverse outcome, And some plaintiff's firm sues and the case goes to trial, believe me, that plaintiff's attorney is going to make it look like you concealed something of significance. I see no legal benefit whatsoever, or no medical benefit, in don't ask, don't tell.
So what you don't know will hurt you, basically, is what I got away from that. All right, we have 1 minute left. Do you guys have any closing last minute thoughts that you want to share with the group?
Yeah, I was just thinking we talked about tequila now.
Oh, yeah.
We've talked about benzos and we've talked about tea.
What a
medical
party
marijuana.
we're having as
Yeah, so I can't wait till next year.
Yeah. Next year, I don't know what we're going to include.
You guys have been great. The only parting thought I have, first of all, thank you, all of you, for what you do, including the three esteemed speakers. When you're developing a policy, when you're meeting with your executive director, your board member, the decision makers, are just consider, what's best for the residents, because that's why we're all here. So I would, recommend that think about what your residents will benefit from when you're developing a policy.
And just thank you for your attention today. It's great to be here.
The same.
Well, all right. Do you want this back over in the middle?
Sure.
How's that? Is that good? Are we back up in where we want to be? Yeah, that looks great. I'm not reading anything from it, but yeah.
That's partly.
All right. Well, that was entertaining. Yeah. Okay. Well, I am here to introduce our next speaker, Christine LaRocca. She is a fellowship trained board certified geriatrician and medical director for Telegen. She's going to talk about early sepsis identification in nursing homes, something so very important. And I tried to do some digging on Dr. LaRocca and online, do a little search there. Didn't find anything at all, which surely means she's not associated with the LaRocca crime family.
Hi, everyone. It's such a pleasure to be here today. Thank you for the opportunity. So I get to be after lunch and after marijuana, which is challenging. And we had a saying in medical school that the mind can absorb as much as the butt can endure. So how about if we have a standing ovation for Dr. Singh, the board, and the volunteers for today's conference? Awesome. So I'm a little on the tall side. Here we go. There really is a LaRocca crime family, but I'm not related to them. Anyway, so I don't want to ever miss an opportunity to express my admiration and respect for the work all of you do every day. I know that it is calling, it's your dedication and commitment is respected and it's noticed. And so we used to talk about heroes during COVID-19. I still think you're all heroes. I picked this very challenging topic today. Am I too close to the mic? Oh, okay. But it's really an extremely important one because early identification and appropriate management in those initial hours after the development of sepsis can really improve outcomes. Before we begin, I just have a couple little housekeeping items, but we're going to focus on the identification of sepsis, but not management because 20 minutes just isn't enough time. And I refer you often to the 2021 Surviving Sepsis Campaign guidelines. And I'm going to use nursing home to include skilled nursing facilities. I hope you'll notice my disclaimer. And as Valerie said, I'm a geriatrician, but I'm not an infectious disease doctor. I'm not really a sepsis expert, to tell you the truth. But my expertise is more on the side of quality and system improvement to enhance patient safety. And my experience also stems from the fact that Telegen was fortunate enough to have enrolled over 1,700 nursing homes over 4 states in our last Quality Improvement Organization contract. As many of you know, Telegen's QIO contract concluded on March 7th. Former QIOs and contractors around the country are currently awaiting information from CMS regarding QIO contract awards. But in the meantime, I hope you'll visit our website, Intelligent QI Connect, because our long-term care resources and tools are there for you. So next slide, please. So what is sepsis? Let's start with that. It's the body's extreme response to an infection. It is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. So sepsis happens when an infection you already have triggers this exaggerated or chain reaction response throughout your body. Sepsis is a life-threatening medical emergency requiring rapid diagnosis and immediate attention. And you all play a critical role. Act fast, because without timely treatment, sepsis can rapidly lead to tissue damage, organ failure, and death. And we know it leads to long-term disability. So next slide, please. Bacterial infections cause most cases of sepsis, but it can also be the result of viral infections like COVID-19 or influenza, or fungal infections. Infections that lead to sepsis most often start in the lung, the urinary tract, the skin, or the GI tract. You have to have an infection somewhere in your body for sepsis to occur. So no infection, no sepsis. And therefore, your hard work to improve infection prevention and control is critically important. We prevent infections by following those infection control practices, including hand hygiene, appropriate use of PPE, being vaccinated and promoting recommended vaccines, decontaminating equipment, following standard and transmission-based precautions, and many other practices. And I applaud you all for following those every day. Next slide, please. So sepsis is common. I try to share tools and services in my talks that you can use in your homes and in your staff trainings. There are some excellent resources available at this link from the CDC. These 4 sepsis statistics show that sepsis is common. 1.7 million adults develop sepsis every year, and at least 350,000 people die from it. 1 in 3 patients who die in the hospital had sepsis, and in 87% of cases, this is important, sepsis or the preceding infection started before that patient ever got to the hospital, so can start in nursing homes. Next slide, please. Sepsis is the most common admitting diagnosis for patients transferred to the hospital from nursing homes. And compared to non-nursing home patients, nursing home residents with sepsis have longer lengths of stay and higher mortality. And this paper that I'm quoting is from 2013, so it doesn't even include COVID mortality. The increasing incidence of sepsis, especially among older adults, its high mortality rate, its often subtle and rapid progression, make our efforts for prompt recognition and treatment extremely important. Next slide, please. So who is at risk? Anyone can get an infection, and almost any infection can lead to sepsis. Some people are at higher risk. Those 5 boxes from left to right that you're looking at, those are our nursing home residents. And if we needed another reason to avoid unnecessary antibiotics, I found this very interesting study by Baggs, who found higher rates of sepsis within 90 days of discharge in people who received high-risk antibiotics during hospitalization. And obviously, nursing homes receive these patients from the hospital, and so heads up that they may be at higher risk. Next slide, please. There's no single sign or symptom of sepsis adding to the challenges. Residents with sepsis may have 1 or more of the following signs or symptoms: high heart rate, low blood pressure, fever, shivering, new onset or increased confusion, which may actually be an early symptom, shortness of breath, extreme pain or discomfort, clammy or sweaty skin. So consider displaying these free CDC posters to encourage staff, residents, and as ways to engage families and visitors to think sepsis to help with early recognition. Next slide, please. So many people think that antibiotic stewardship efforts and treating for sepsis early and with broad spectrum antibiotics are somehow opposed to one another. Not true. Antibiotic stewardship is about improving the prescribing of antibiotics to decrease overuse, underuse, and misuse by treating with the right antibiotic, the right dose, right duration, right time, and for the right reason. So therefore, the appropriate treatment of suspected infection or sepsis is part of antibiotic stewardship. Next slide, please. And once those antibiotics are prescribed, don't forget to take a timeout. This tool was co-created very joyfully. I look back with it very proudly by CHCA, CDPHE, Colorado Hospital Association, and Telegen to help you take an antibiotic timeout to reassess every antibiotic within 48 to 72 hours after starting. We know antibiotics get started in the middle of the night because you're worried, you didn't know what went on. But take a timeout, 48 to 72 hours. Ask yourself, what am I really treating here? Because these antibiotic reviews provide clinicians with an opportunity to reassess the ongoing need and the choice of the antibiotic when the clinical picture is a bit clearer and you have some more information. Next slide, please. So now that we know what sepsis is, what causes it, signs and symptoms, and who's at risk, what are some opportunities in the nursing home setting to increase the early identification of sepsis? The International Surviving Sepsis Campaign guidelines is led by multidisciplinary international experts, and they include the following strong recommendation. For hospitals and health systems, we recommend using a performance improvement program for sepsis, including sepsis screening for acutely ill, high-risk patients, and then standard operating procedures for treatment. So here's my biggest takeaway from today's talk. If your facility does not have one, consider designing and implementing a sepsis performance improvement project, or PIP, using the Quality Assurance Performance Improvement, or QAPI platform, with the goal to improve early recognition of sepsis, standardize communication, and that important initial management. Key components are planning and implementing process changes so that you're just a well-oiled machine for standardized communication, care pathways, and workflows, and include the use of sepsis screening tools. The pathway can also maximize adherence to those IP&C practices, and your pathways can include your rapid response and initial management. And I'd be interested in hearing, maybe if time permits at the end, if anyone is using any sort of electronic alert system for sepsis. I had the extreme privilege of talking to Dr. Bernardo Reyes. He actually published an editorial on this topic in 2018, and he's conducting a study that's looking at the role of machine learning to help with the early identification of sepsis by analyzing historical and real-time data and looking at trends. Next slide, please. So data. In your sepsis PIP, it is important to map out the process for data collection so that you can measure and monitor the use of these pathways and your standardized communication and tools. The data collection process includes specifying what data collected how often, by whom, who's going to review it, and how will it be acted upon. And a really rich source of data, I want to emphasize this, comes from retrospective review of residents who were admitted to the hospital with sepsis to identify opportunities for improvement and perhaps earlier identification. These reviews can be conducted by using the Interact QI tool for review of acute care transfers. Training and education, always vital and key components of your PIP. So implementing Interact, we know, is a team sport. So it requires support from your very important infection preventionist, staff development coordinator, directors of nursing, administrators. We've heard earlier about the important role of the medical director and your primary care clinicians. Identified champions can support training and effective use of these Interact tools or other preferred tools, with a special emphasis on use in everyday practice of the early warning stop and watch, change in condition, and the S-bar. These can be really, really important in your efforts to identify early signs and symptoms and to heighten sepsis awareness. Education should emphasize the importance of obtaining vital signs and use of sepsis screening tools, a complete set of vital signs, and I'll speak more to that in a moment. And hopefully with all of these measures, we can decrease the risk of getting a citation on failure to rescue because you're trying to identify things earlier. Next slide, please. So my title is Opportunities and Hurdles. Here are some hurdles. Atypical presentations of illness are not uncommon in our nursing home population. The signs of both infection and organ dysfunction may be quite subtle and very difficult to recognize in older adults with multiple comorbidities. It may be difficult to detect mental status changes because baseline cognitive status may not be normal, or it could be a medication side effect. Respiratory rate changes could be due to common conditions such as COPD and asthma. Low blood pressure might be due to cardiovascular medications, poor oral intake. The increased heart rate or tachycardia may not occur due to cardiac conduction disease and use of beta blockers, and fever may be absent, or nursing home residents may have a lower baseline temperature, so you don't appreciate that they have a fever. Next slide, please. Additional hurdles includes, and I don't know why I chose this topic because I am really big on what does the literature say? Well, the literature is vanishingly rare on this topic. So there's a lack of specific recommendations for long-term care settings. The recommendations in the Surviving Sepsis Campaign guidelines are for the clinician in the hospital setting. And we know the setting matters. Resources are different. They're very different setting. In the nursing home setting, early identification of sepsis and early interventions for sepsis have just not been well studied. I was hoping Dr. Levy was still here so I could put this on the academic horizon. But to quote Dr. Teresa Rowe from the CDC, we have a lot to learn about sepsis and how to define it. Also, there's no sepsis screening tool that's specifically validated for the nursing home setting, and all sepsis screening tools have their limitations that we have to consider. A problem in sepsis screening is that there's many different risk scores and screening tools, and the accuracy of these risk scores is highly variable depending upon the setting. So, as a consequence of this, the SSC guideline does not recommend any one particular tool. They advise that physicians should be aware of the benefits and limitations of the tools that they use, and choices should be made on local preferences, which I have to admit is a little bit vague. So, other hurdles are that rapid diagnostic testing and result availability varies considerably among nursing homes. It is not uncommon for me to hear of turnaround times that exceed over 8 hours, which is too long when you're considering sepsis, and a clinician may not immediately be on site. Next slide, please. So, another hurdle is, as I mentioned, few published studies, but I'll reference this one from Sloan and co-authors because they asked this really great question. Can sepsis be detected in the nursing home prior to the need for hospital transfer? Now, it's a small study, it's a retrospective study. It had several limitations that could impact the usefulness, and the authors themselves said that these findings need to be confirmed. But their objective was to determine whether and to what extent simple screening tools might identify nursing home residents who are at high risk of becoming septic. And the design, as I said, was retrospective chart review, but it was of all residents who had been hospitalized and then returned to the nursing home during the study period. They looked at 5 screening tools for their ability to detect residents with early sepsis during 2 different time intervals prior to hospitalization. And in their findings, a prerequisite for effective screening for sepsis in the nursing home is documentation of vital signs, yet they found 1 or more vital signs was absent in up to 1/3 of cases. And this clearly represents an opportunity to be addressed in that PIP that I hope you leave today and start designing immediately. So during the 12 hours prior to transfer, only 19% of the sepsis admissions had a medical note or any other indication of a physician NP or PA examination, which is another opportunity. And Sloan concluded that while no tool adequately screens for early sepsis in the nursing home population, several show promise. And the 100-100-100 early detection tool and a threshold of a temperature greater than 90 degrees Fahrenheit performed better than the other criteria and screening tools studied. So next slide, please. So we've got opportunities and hurdles. What's new in our industry? Okay. So a primary focus of many performance improvement programs is identifying and using screening tools to identify sepsis early. What tools might you consider when you're designing your sepsis PIP? So the nursing home setting requires tools with high sensitivity because we don't want to miss sepsis. What does that mean? Sensitivity refers to a test's ability to correctly identify individuals who actually have the condition or disease. It means there's few false negatives. Many sepsis screening tools exist, but let's go over 3 of the tools that were used in the Sloan article. A long-established tool is the SIRS, the Systemic Inflammatory Response Syndrome criteria. And so the way you use it is that in the setting of suspected infection, SIRS criteria are met if 2 or more of the following 4 signs are present: body temperature greater than 38 or less than 36 Celsius, a heart rate greater than 90, respiratory rate greater than 20, and a white blood cell count greater than 12,000 or less than 4,000. The SIRS criteria do not include systolic blood pressure, you'll notice, and it requires a lab result to assess risk and for scoring. The tool that is validated and for which there is published literature includes the white blood cell count. I've seen this used as like 2 out of 3 criteria, but the white blood cell count was in the validated tool. And that need for laboratory data with a fast turnaround time limits its rapid use at the bedside in the nursing home. Of note, I wanted to emphasize this because I've seen it in my work. Old labs should not be used, so you can't use the white count from a month ago. Okay, so Sloan found that SIRS had a low sensitivity for sepsis. It was 36%. Next slide, please. So the QSOFA is the Quick Sequential Organ Failure Assessment. It doesn't require lab data, which is an advantage, but it uses the Glasgow Coma Scale, which I'll tell you is not well suited for the nursing home setting. It's complex. It presumes a normal pre-test cognitive status. And actually, the SSC guideline recommends against using the QSOFA as a single screening tool due to its poor sensitivity. Next slide, please. So the third sepsis screening tool from the Sloan article, and the one that had the highest sensitivity, 79%, which is respectable, is the 100 early detection tool. Now, it was developed by the Minnesota Hospital Association as part of its long-term care specific Seeing Sepsis Toolkit. This tool is really attractive because it's easy to remember and learn and use. 100 criteria are met if 2 or more of the following are present. Temp over 100, heart rate over 100, systolic less than 100. Even I can remember that. Okay, so next slide, please. So it's hard. There's no best tool. Signs and symptoms are difficult to detect. There's limited number of studies outside the hospital setting. And we're just left with the perfect is the enemy of the good. So until further research is available, consider combining tools in a multi-pronged approach and combining tools also with an emphasis on those interact tools. So changing condition is identified using the interact stop and watch, the change in condition decision support tools, or any other change in condition alert, and combine it with the 100 early detection tool and elements from the SIRS and the QSOFA. So what might that look like? Next slide, please. So this Act Fast tool for long-term care includes the 100 screening alerts, plus next steps for the medical providers in the event of a positive sepsis screen. You can see that they've combined those elements that I talked about, and I really appreciate that this tool includes review of advanced directives and attention to goals of care. Highly important. And I just want to throw in a word of caution. Even if only one criteria is met, and so it doesn't score high, obviously rapid assessment and action may still be needed. You know, you get called with a systolic of 60 or something. They're not going to meet the 2 criteria, but something's going on there. Anyway, so you can't look at the score in isolation, have to consider it in the overall context. Next slide, please. So many of you are familiar with this guidance, but for those who are not, the Interact team recommends that all patients and residents with a suspected or confirmed infection and possible sepsis be considered for transfer to an acute care hospital unless they meet either of these 2 criteria. And their rationale is that the guideline recommended management of sepsis is beyond the capability of most skilled nursing facilities. If the patient is being transferred, don't forget that there is an Interact nursing facility to hospital transfer form. And on it, you can include the reason for transfer to both document your concerns, possible sepsis, and to enhance your communication so that you don't get, an emergency room doctor if you send them over. Why? And after recognizing possible sepsis, early management, to the degree that your nursing home is able to do it, should be initiated while that hospital transfer is being arranged. Next slide, please. So my key takeaways: since sepsis results from infection, improving infection prevention and control practices is critically important for preventing sepsis. And a major takeaway is that a well-designed and implemented sepsis performance improvement project using Interact tools and/or other resources can really help nursing home teams standardize and improve early recognition, communication, and initial management. Would your home benefit from having a sepsis PIP? And I'm going to emphasize again the use of some of those Interact tools, especially that stop and watch early warning tool. In the absence of a best tool, consider combining tools until further research is available. but we cannot rely solely on tool scores due to limitations of some of these tools. And I'm going to end with quoting the panel of geriatricians and medical directors who addressed this topic at a past PulpMed conference. Sepsis identification and management is as controversial and vexing as ever, but efforts in nursing facilities to identify and track changes in condition, use tools for structured communication, and initiate early management can make an impact. So next slide, please. I've included all my references and sadly have left time for questions. Okay. And say, yeah, thanks. Hello. Okay. Sorry. Wow, you guys, that was powerful. I was just wondering, in your experience with working with different facilities, have you seen like a standard of like what people are using for frequency of vitals? Because it is really hard to do like more frequent vitals based on the resources, like the lack of staffing and those kind of things. So sometimes like Q shift is the best that you can get, but I didn't know if you've seen anything different that's been effective. That's an excellent question. I might be one of those people who puts it back on the crowd because I don't have a definitive answer there. Does anyone have experience with getting those more frequent vital signs or the hurdle there? And I think that's one of the reasons that the Interact team arrived at its. These folks should be transferred if that set of vital signs, knowing some of those hurdles. But anybody have any? We're going to make this a group thing. Okay. It sounds like it's a common challenge. Karen's going to save me.
Just I write repeat for just for 24 hours.
Yeah.
So yeah. Just write for the frequency just to be for a shorter duration. Because then for the first 24 hours, you should be able to know, especially if you already started therapies, and then you can know if your therapies are going to be effective.
Perfect. Karen saved me yet again. Okay.
Any other questions?
I wanted to just say my why before we break. So I really love that Deming quote that was shown earlier. Bad systems beat good people every time. And my why, my passion is helping you all, good people, to improve your quality and your systems of care. So we got a question in the back.
That I. Why? Why? But memory.
And coming from a surveyor, that's important. Yeah. Mm-hmm. And I will say, I have seen that somebody's, trend in their systolic blood pressure is 160, and now all of a sudden it's 105. Well, they're not going to trigger the 100 tool, but it's all got to be customized care. But thank you all. I appreciate it.
Good.
So good news. You get another break. And we encourage you to go next door, thank our vendors, make some connections of your own, and we will see you back here at 3:00. Thank you. Oh, and you guys have been so great that you guys get a prize, each one of you. Because it's our 30th anniversary, you each get an individualized cupcake. So please go outside and help yourself. We want to thank Leah for organizing the cupcakes, and thank you all for being here.
I like one say it. They lose. Or it was big.
Okay, everyone. Time for the last 3 amazing presentations. So next we're going to invite Dr. Gom to present the CMD Ducky. And Dr. Gom's a geriatrician and medical director for several nursing homes in the Denver area, as well as past president of CMDA. He's been at the forefront, as many of you know, in long-term care for many years, and has led educational initiatives such as the monthly Geriatric Journal Club. And in fact, his passion for geriatric care influenced my decision to work as a new grad in long-term care at Evercare many, many years ago. So please join me in welcoming Dr. Gom.
Let's get introduce the whole slide and that you and that you. That'll be I just about
Dave, are you going to talk about Slido?
yeah.
Okay.
So this is going to be done through Slido, which is another audience participation app. We've been using it earlier. So there'll be a QR code that will come up here in a minute, and you guys can take a picture of it. There's also a number. So if the QR code's not working, just go to slido.com, punch in the number, and that should take care of it. So we'll put the QR code up here in a minute and give you guys a little bit of time to get logged in, okay?
Yep. Yeah, as you're doing that, I'll just entertain you here for a second. It is late in the day, so the first thing, I know a lot of you went next door, and that was good. Everybody else, you stand up and sit down 3 times. Let's get the blood flowing, okay? And get your fingers going, because these are going to be quick answers. We're going to read them, and you have only 20 seconds to answer, and we are not going backwards for any reason, or we'll never finish. And there are prizes at the end. Okay.
Stand. Is everyone ready? Okay.
Think the come back.
And the last thing I'll tell you, if you came to Journal Club this year, to everyone, and you came to CMDA, you don't need to worry. You will know every answer. There you go.
Okay. So first 5 questions are from last year's race that I'll be reading. Go ahead. The American Dental Association recommends antibiotic prophylaxis for A, patients with prosthetic cardiac valves, B, tooth extractions, C, patients with prosthetic joints, D, patients with cardiac stents, or E, all of the above. It'll come up.
No.
No.
But we should have to keep the question.
It'll come back.
Yeah, we're going to try to get the question back up here. This is AI. Thank you. Chair and line. There you go. There's a question. We'll leave the question up there.
That's good. Yeah.
And then is it closed now for answers?
Yeah.
There's a way.
So, last night's here. Yeah, so we just need to go 2 next time. Okay.
Right? You got a lot of time with this one. Don't call your dentist. Your dentist won't know the answer.
That is true.
Okay. All right. I think that means it's closed now. This is it. Okay. And don't believe the dentist if they send them back on antibiotics for other reasons. Okay. Next question. Go.
According to evidence-based recommendations from the 2023 AGS Beers criteria, which of the following would be the most appropriate anticoagulant as initial therapy for treatment of non-valvular atrial fibrillation in older adults? A, warfarin, B, rivaroxaban, C, dabigatran, D, apixaban, or E, low-dose aspirin?
Good fun. Here we go.
Yeah, our speaker back here better get that one right.
Right. Good job. Very good. All right, and it was D. The GOLD guidelines recommend all but which one of the following, i.e., which answer is wrong? A. Inhaled LAMAs, LABAs, and steroids are the standard of care. B. While steroids may be useful for a few days during exacerbations, they have no role in chronic daily COPD treatment. C. Inhaled steroids should be reserved for those with blood eosinophils greater than 300 microliters and are rarely beneficial when this is less than 100. Or D. LAMAs, LABAs are preferred over short-acting agents except for patients with only occasional dyspnea.
Nice one.
Very good. Very good. For a patient with iron deficiency anemia, what is the most effective treatment regimen using a normal dose of iron? A, once daily, B, BID, C, TID, or D, every other day?
Let's make sure you're not yelling out those answers. I just heard the correct answer over here. I think less right. Let's try to get it out.
Very good. Whoever A is, you're in the lead. Okay, question 5. In regard to using aspirin for prevention of cardiovascular disease, A, benefits of low-dose aspirin for primary or secondary prevention outweigh risks of bleeding. B, benefits of low-dose aspirin for primary or secondary prevention are offset by increased major bleeding and other cancer, by increased major bleeding cancer. Or C, benefits of low-dose aspirin for secondary prevention outweigh risks of bleeding. D, risks associated with low-dose aspirin outweigh potential benefits for both primary and secondary prevention.
Yep. You guys are doing great. Thank you, Vanna. Okay, now you're stuck with me. An English cohort study of more than 170,000 patients, which means it's really a good study, with dementia showed, in addition to strokes, heart attacks, and heart failure, those treated with antipsychotics were at almost twice the risk of having all but which of, I'm not going to read them, I'll let you read them, all but which of those in the first 90 days? You guys are still right on top of things. That's really good. Okay, number 7. Which of the following commonly used medications significantly increases risk of bleeding in patients on a DOAC? Cholinesterase inhibitors, muscle relaxants, PPIs, migestrol, or SSRIs? And if you were here this morning, you heard the answer from the audience. Thank you, Dr. Anneberg. Oh, you were listening. You should be proud. Okay. Yeah, that big long word is used in the management of heart failure with a preserved ejection fraction. Which of the following best describes its primary mechanism of action: inhibition of renin-angiotensin system to reduce afterload, direct vasodilation of coronary arteries to improve myocardial perfusion, sodium glucose cotransporter 2 inhibition leading to natriuresis and reduced preload, or blocking beta adrenergic receptors to decrease heart rate and myocardial oxygen demand. You had to really pay attention for this one. Yeah. You can thank Dr. Shepard for this question. There we go. It was up there briefly. Okay. According to the 2022 ACC-AHA heart failure guidelines, which class of medication is not included as guideline-directed medical therapy for heart failure for reduced ejection fraction? Beta blockers, sodium glucose cotransporter 2, GLP agonists, mineralocorticoid receptor antagonists, or renin-angiotensin inhibitors. You should be proud, Dave. They were paying attention. Nice work. All right. Okay. Same guidelines. Which of the following regimens follows the guideline-directed medical therapy for reduced ejection fraction? Losartan, carvedilol, eplerenone, yeah, that one. Actually, I'm just going to let you read these. That's better than me trying to work my way through. Let's give them a few extra seconds. Whoops. There you go. Nice. Okay. All right. This one is thanks to Travis, who's right back here. Serum magnesium levels only account for about 1% of the body's total magnesium. Which of the following approaches to supplementing with magnesium is best suited for geriatric patients? And I guarantee, let's leave this for a few seconds. You can read this faster than I could read it to you.
Yeah, I think, right?
Okay, go ahead. There you go. Who was D? There we go. And there's the references. You can tell it was Travis just by the number of references. Okay, here we go. American Academy of Sleep Medicine recently, in January of this year, updated restless leg syndrome guidelines. Key provisions include all but which one. So read through these, which one is not correct. I hear people whispering those answers again. Unless you tried to whisper the wrong answer. That would be clever. The answer is not benzodiazepines. Thank you, Leah Watson. Okay. Okay, here we go. Emergence of multi-drug resistant organisms has recently been associated with which class of medications? Calcium blockers, opiates, antipsychotics, or gastric acid suppression? Very good. That's part of the reason we get rid of those PPIs at 4 to 6 weeks. Okay. Drugs that make their way to the updated beers list include all but which of the following? This is sort of a trick question, but good luck. So again, we're looking for which one doesn't go there. Pretty good. Okay. For the 5 medications here, should soon be available for use for the condition noted. Which one of these is not a real drug?
But you need that. Sure. Father, what the fuck is in Qatar? Wait. After
Which, by the way, means 4 of the 5 of these are real drugs that have recently really been approved.
Yeah.
Oh, very good. Twyla, we're going to make you come up here. All right. Cobenfy, see, there we go, is recently approved medication for schizophrenia, which targets cholinergic receptors rather than dopaminergic. It's a combination of xanomeline and what? Uh-oh. Gotcha. Okay, here we go. The FDA recently approved a pain medication. Oh, this table, you guys better get this. With effects equivalent to opiates with no addiction risk. What is it? How does it work? And I'll just let you read through these. Give them an extra few seconds here.
That.
I'll even tell you that it's made by Vertex Pharmaceuticals. And I'm putting money there.
Wait.
Yeah, it won't take that long. I think we're down to about 4 questions. Okay, well, goes pretty well. Okay. How effective are statins for secondary prevention? Those people that have already had heart attack or stroke, and I'll give you a few seconds again here to read through this. Which one of these is closest to true? And this only becomes important because patients think that every time you put them on a drug, it is going to work every time. So pick the right answer.
Yeah.
Yeah. There you go. Doing great. All right. According to the American Society for Parenteral and Enteral Nutrition, which of the following about albumin is false? And again, you can read faster than I can, so go ahead. Again, we're looking for the one that's false. 4 of them are true. Okay. Recent review of antiviral medications for treatment of non-severe influenza found baloxavir probably reduced risk of hospital admission for high-risk patients in time to alleviation of symptoms. Tamiflu reduced risk for hospitalization and death if given within 48 hours. And the adamantines once again showed modest benefits, though only against influenza A. Which one of those 3 is true? Of course, it's Dr. Gam, and there's an influenza question. So, oof. Yeah. By the way, Tamiflu just doesn't work. Not using it anymore. Okay, here we go. Guess what? That's the end. Twyla, stand up. How come you're Twyla?
And Twyla's my dog's name, and that's what I'm
Nice work. And I will tell you, I'm going to leave here, but I will tell you that that's 3 years out of 5 that a non-physician has won this. Thanks, you guys.
What ever soon? Name hair, bro. He's not different. Dude. What about you? How about you?
All right. Nice job, everyone. That was fun. I love doing the Kentucky Derby every year. So
Our next talk I am excited about because I don't know about you. When I went into geriatrics, I didn't know that I was going to be a part-time neurologist. So I am super excited to have Drs. Nicole Semler and Atana Lamb. They both have their doctorate in pharmacy, and they're currently completing their one is in their first year and the other is in their second year for their clinical neurology research fellowship at the University of Colorado at Anschutz, and it's within the Skaggs School of Pharmacy. So please help me welcome them to the stage.
Well, thanks, ladies. Oh,
Hello, everyone. Thank you for having us here today. Okay, so we're going to start off with seizure management in the nursing home. We have no disclosures to have, and it'll be listed here. For objectives, we're going to first design monitoring plans, labs, and adverse effects according to a patient's anti-seizure medication regimen. Second, adjust medication dosing according to a patient's renal or hepatic status. 3, will identify common interactions between an anti-seizure medication of choice and other commonly used medications. 4, design an abortive medication regimen appropriate for the patient's status. 5, develop a plan to switch patients from an oral medication to an injectable or oral option. So please excuse us really quick. We're going to go a little bit fast. Okay, so so for the importance of nursing homes in adults, it's not put up on the slide right now, but we do have a study from 2017 of all of the nursing home residents is from Medicaid and Medicare. They showed a 7 to 8 times fold of patients who are in nursing homes in comparison to community dwelling adults. On top of that, patients who do have neurologic comorbidities such as stroke, if they're hemiplegic, that increases risk as well, traumatic brain injury as well, and including primary brain tumors. So those would cause a 7 to 30-fold increased risk of epilepsy as well. And something else to know about is that at least 22% of patients who come from hospitals end up in long-term care facilities that end up with epilepsy. So for monitoring anti-seizure medications and therapy prior to starting, first you're going to want to do liver enzyme tests. And the reason why is because drug-induced liver injury is very possible with anti-seizure medications. So first you're going to do ALT and AST specifically. Those are just for hepatocellular injury, and then alkaline phosphate or GGT as well for bile obstructions. Continually, we'll do comprehensive metabolic panels, complete blood counts and platelet counts, including neurologic exams and patient reports. The most important one we have on here is the ASM serum level. The reason why is because most ASMs have very short half-lives, so about 8 hours. And the reason why we say measure the trough level is when the drug should be at its lowest concentration in the body. And that is the reason, so you'll be taking trough levels immediately before their next oral dosing. So continuing on for serum levels, we have it listed here, and it's a lot to take in, we understand, but we're going to go through them pretty quickly because of the short amount of time. So please stay with me if you guys can. I won't be listing all of the serums, but I'll just talk about the important ones. So the important ones to know is phenytoin. Phenytoin has a 10 to 20 microgram per milliliter serum that you're going to want to reach for. And the reason why you want to reach within these serum levels is because if you go low, it's insufficient enough to stop a seizure. But if you go too high, you could have toxicity, such as with phenytoin. So phenytoin, you want to obtain 5 to 7 half-life, so at least 7 to 10 days after treatment initiation, dosage change, or addition or subtraction to another medication onto their list as well. Yeah. Now, next, we're going to go with lamotrigine. There is a long onset unless there is a bridge. The reason why we say there's a long onset, it's about 6 weeks. So usually that is not preferred for prophylactic seizure accommodations for treatments. And then for okay, and then for most of these medications do have short half-lives, so most of the only one that has a long half-life is phenytoin. The other ones that do is all these other ones that are listed probably will have a shorter half-life, and we'll kind of go more into that. And the reason why there's fluctuations in drug levels, it could be internal or external. So absorption, distribution, metabolism, and metabolism we'll talk more with Dr. Semler, who will go over it more, and also external values. So like nutrition status, their diet, how well are they doing as well. So for monitoring ASMs and common ASMs, for levetiracetam, I want to point out is that behavioral abnormalities are very common. So psychiatric or non-psychiatric, so aggression, agitation, anger. Also somnolence and fatigue, that will be highlighted as well. So that may lead to coordination difficulties. But keep in mind with levetiracetam, it can resolve after a month. But the thing is, do you want to put your patient and watch over them for a month as well? Something to consider. For valproate, we'll talk more about this as the early osteopenia. I'll call and talk of it in more of a collective. But for this one specifically, I want to mention is the fluid and nutritional intake, making sure they're hydrated because dehydration can occur in somnolence as well, especially when you're increasing dose in older patients. Another one is hyperammonemia. So make sure you assess their ammonium levels if they're having lethargy or unexplained changes in mental status as well. It can also happen in topiramate, but not as often. I just want to let you know that there are elevated ammonium levels with patients taking valproate, but they don't always have these symptoms. So that may also happen as well. And then for topiramate, I want to really highlight is kidney stones. Make sure you see and they're hydrated. A lot of them I'll mention kidney stones. And also with the serum bicarbonate can lead to metabolic acidosis as well. So with phenobarbital, for sure you want to see QTC prolongation. So you need to monitor their electrolytes and get an ECG as soon as possible. Also may have respiratory depression. For phenytoin, kidney stones as well, and monitor their ECG. Also may have acute toxicity, so behavioral issues like confusion, delirium, lacosamide. It really depends on if it's adjunctive or monotherapy, so you should titrate up weekly, especially with its long onset. With lamotrigine, kidney stones again. So make sure they're really hydrated, guys. On top of that, the incidence of rash is really likely if you titer them fast, so less than 8 weeks. And it's weight neutral. With gabapentin and gabapentin, pregabalin, they both show actually edema. So please make sure if your patient has heart failure to watch out for that. So for carbamazepine, eslicarbamazepine and oxcarbamazepine, hyponatremia is very, very likely, but carbamazepine seems to show the most. So usually when you look for their serum sodium levels, 130, they may show symptoms, they may not, but that should be a sign of hyponatremia may occur. Okay. Another one that I would believe is the MAOIs. Usually avoid using them. We usually recommend 2 weeks, but you could just avoid using them too. Okay, and then, so oxcarbamazepine actually has been shown to have the least drug-drug interactions. Is actually better tolerated than the other two. So just something to highlight. Okay, this is also what I wanted to go back into. So adverse effects of older ASMs, specifically with, as you can see, there's classic AZDs, carbamazepine, phenytoin, phenobarbital, and primidone. Valproic acid is more of a newer one that has been shown in recent studies. And the reason why is that ASMs may lower calcium in the body and may lower phosphate as well. So this could be harmful for the patient's bone health. And on top of that, the anti-seizure medications also can cause somnolence, fatigue, or dizziness. So on top of the dizziness, lack of balance, and they're likely to fall, fractures are may likely to happen as well. So that's something to keep in mind of in assessing their 25-OHD levels. The bone markers, there's no clinical significance of yet, and it has yet to be studied, so mostly focusing on the other levels I mentioned. For hypersensitivity, you're mostly going to want to avoid using these drugs together, essentially. On top of that, because there may be likelihood of rash, systemic convulsion, so DRESS, drug reaction with eosinophilia and systemic symptoms, and Stevens-Johnson syndrome, both are rashes. SJS, you most likely have a 10% rash, and with DRESS, it's mostly systemic organ involvement, so fever may show up. We kind of just put in genes, but pharmacogenomics, if you guys ever decide to test them, it's up there. So for other indications for anti-seizure medications, gabapentin and pregabalin, of course, are used with neuroplegia or neuropathic pain. For other medications, so levetiracetam is head-related injuries to prevent with seizures. and oxcarbamazepine. Another one that I wanted to mention was, I think, what's it? Kimmy was the mental one? Yes. Topiramate also is used with like mental disorders and bipolar. So that can also be used for like two birds, one stone kind of a thing. I kind of have more here, but you guys can reference. Thank you guys for understanding. Okay, so Nicole will be taking over.
Yeah, sorry about the slides. There's updated ones on the CMDA website. But so just really talking about when to stop ASMs, this is a big one. So when a patient is on polytherapy, especially more than two, you're not really getting any benefit. You're just getting a lot of side effects. So we really want to see 2 or below. Even adding on the second one, you're only getting about a 25% benefit, and only about 25% of patients actually respond to that second ASM. So to come off of anti-seizure medications, we really want to see a patient be seizure-free for about 2 years to even consider a trial. That is controversial. We do see sometimes that people want to wait 5 years that they're seizure-free. It's really a risk-benefit. And we'll go over the predictors of if they're going to have another seizure, if they're likely to have a seizure. But one thing to really note is that if you're going to taper off phenobarbital just because of how it works, you can precipitate more seizures if you take it off too quickly. So that's one that you definitely have to taper off slowly. Some predictors of seizure recurrence. So if they've had epilepsy for a long time before they got into remission, then you're more likely to have seizures again. Age of onset, if they're in adulthood, they actually have a higher risk of having seizures. Focal seizures is another one. So the type of seizures that they have or the type of epilepsy, and then also the number of anti-seizure medications they were on before the withdrawal. So again, if they're on 2 or more, you're going to have a higher risk of seizures when coming off of those medications. And then just female sex and family history. So if they have a family history of epilepsy, they're most likely going to have another seizure. One that I know that we do a lot of is if our patient has a fall, then you're going to put them on either Keppra or phenytoin. Keppra is now the drug of choice. But according to the Brain Foundation and a neurosurgeon board, after 7 days, that should be stopped. You get no benefit for either early or late onset post-traumatic seizures. So again, 7 days, stop it. If they do have a seizure after that 7 days, that's where you're going to go to the more chronic therapy. There was a study that looked at 404 patients, and that was phenytoin versus placebo. So that's where we get that 7 days from, because after that 7 days, they had no benefit. They had more side effects, no seizures after that. So really, that's where our 7 days come from. And then the levetiracetam just came from a comparative study. So for renal dosing, what I really want to bring your attention to is which ones are actually going through the kidneys. So levetiracetam is our big one on this slide. We usually see a dosing adjustment around 80, a creatinine clearance of 80. I'm not going to go through all the dosing. They'll be on the slides on the website. Phenobarbital and glucosamide, we don't really worry about as much. This one, carbamazepine, we don't have any adjustment. That mostly goes through hepatic metabolism. But I do want to bring your attention to topiramate. When we get to a creatinine clearance of lower than 70, we reduce it by 50%. But you can also go off of GFR if that's what you have. And then also phenytoin. This one has more, it's 70% renally cleared, but we're always going to go off the serum concentration for that one. So the big ones that we're doing serum for is the phenytoin and valproate. Those are the ones that you really want to get a serum on. The other ones, only if they're having side effects or signs of toxicity, really. And then on this slide, so gabapentin, pregabalin, another one that are very much through the kidneys. We'll start seeing dosing adjustments when they get below 60. So for the hepatic dosing adjustments, like I said, levetiracetam, topiramate, phenytoin, gabapentin, and pregabalin are not going through the liver, so we don't have to worry about that. And then the rest of them, the rest of them we start adjusting around class A, but it can depend on if they have ascites or cirrhosis, so that it's very drug dependent. So look at those if it's not, again, levetiracetam, topiramate, phenytoin, gabapentin, or pregabalin. Now, there is some interactions between ASM, so they're not working well together. How I like to think of it is that glucosamide and oxcarbazepine are bullies, and that topiramate, carbamazepine, lamotrigine, and phenytoin are the ones to get bullied. So if you're using those together, then you really have to look out for interactions between those. And then interactions with all our other drugs. So our pain medications, especially tramadol, meloxicam, and opioids, we're going to see interactions with carbamazepine or all the mazepines of phenobarbital, phenytoin, and topiramate. We have a lot of enzyme inducers, and especially carbamazepine will induce itself. And another big thing to look out for that I did not put on the slide, but it's in the chart, is our antithrombotic therapies. Those interact with a lot of our anti-seizure medications, so we really need to look at levels of that. If you're doing warfarin, you want to look at INR. If you're doing apixaban, rivaroxaban, we just need to look out for side effects of those. For antidepressants, we really want to avoid the tricyclic antidepressants. We want to use SSRIs if possible. And duloxetine is a low to moderate risk. So that one, if they're really prone to side effects, look out for that. Antipsychotics, if we're going to use them, risperidone, quetiapine, and aripiprazole are recommended in those with ASM therapies. And then we'll talk about abortive options with Atana.
Oh, okay. So for abortive options, we have the FDA-approved ones for seizure cluster rescue medications. So diazepam rectal gel, the intranasal midazolam, and diazepam nasal spray, so Nazolam. For the FDA-approved for status epilepticus, it's only IV version so far. There is a longer list, but it's mostly these IV diazepam and IV lorazepam. And for benzodiazepines, they're Schedule 4 controlled. So they're usually in locked compartments. Exception is single unit packages or doses. Sometimes you can use single-use dose of FDA-approved rectal or intranasal. So it depends if the patient has it, but I also understand insurance is not a thing. We actually do have the dose up there. It's not up there right now, but lorazepam is 4 milligrams max. Diazepam, avoid use in elderly due to its long half-life. Midazolam is also another option as well. They should be on there so you guys can check it out. Okay, so for the seizure abortive plan, number 1, notify your attending, nurse practitioner, PA, whoever you can notice as soon as possible. Number 2, do not leave the resident alone. Okay. Number 3, next, put them on their side and don't put anything in their mouth. So that means oral medications. So which is why they prefer the IM, IV, or intranasal or rectals, because usually patients with seizures, you can't put anything in their mouths. Administer first aid and any prescribed seizure treatments as quick as possible. So for the post-ictal state, it can last from minutes to hours, but keep in mind the patient may have confusion and psychiatric symptoms that long last after the post-ictal state as well. So residents with seizure disorders, they may have recurrent or repetitive seizures. They may occur for 24 hours. I'll talk about status epilepticus a little bit later. And then prolonged, it may occur for several minutes. If it's prolonged, we kind of have it on the bottom. I'll talk about it over. For potential risk of delayed treatment, so you may increase the risk of status epilepticus. The patient may continue to have seizures. Another one is that functional disability or death if the patient is not treated for their epilepsy or seizures. So make sure you treat them as soon as possible. This is when you would consider emergency services. So like I spoke about, what we mean by prolonged seizures, if it's more than 5 minutes, call EMS immediately. You could call EMS, of course, as soon as they have a seizure, but after 5 minutes, for sure, please start calling EMS. Or if they have injury or cyanotic, so if they have bluish lips or bluish skin, please call EMS, guys. Thank you. Okay, Nicole.
All right. So there is going to come a time in a patient's life where they're going to have trouble swallowing. So what options do we have when it comes to that time? So for oral solutions, carbamazepine, oxcarbazepine, gabapentin is a big one, topiramate, valproic acid. And then, of course, we have our IV options, which have been around for a while, but the valproic acid, phenytoin, phenobarbital, levetiracetam, and lacosamide. Our rule of thumb, usually in pharmacy, if it is a delayed release or an extended release, do not crush it. If it's immediate release, you can open it, put it in applesauce, whatever it takes to get the medication to them. The only exception to that is carvedilol, which is the delayed release of carbamazepine. That can actually be open, but the pearls inside cannot be crushed. And then for switching medications or switching formulations, the phenytoin IV to PO, it's a 1-to-1 conversion, but the phosphonitoin, which is also IV, is dose in phenytoin equivalents. When you're changing that dose, do not convert the phenytoin dose, just go off of that PE. So, for example, if they're on 100 milligrams of phenytoin, you're doing 100 milligrams PE of fosphenytoin. And then levetiracetam, that's a 1-to-1 conversion when they're going to IV or oral solution. Depakote, which is the divalproex delayed release, that one, when you switch to ER, you're usually going up by about 250 milligrams. It's actually 8 to 20%, but the average was 250. So that's just a good rule of thumb. And then valproic acid, when you're going to IV, the valproic sodium, you're increasing the dose by 10%. And then from the valproic sodium IV to a Depakote DR dose, those are completely equal, so 1-to-1 conversion. And then oxcarbazepine, eslicarbazepine, that is a 1-to-1 conversion, but then carbamazepine to eslicarb is 1 to 1.3. That's just because of the active metabolite in escarbazepine, sorry. It theoretically could be switched overnight because they are basically the same drug, just a different enantiomer, but we usually do it over 1 to 2 weeks just to watch for side effects. All right, any questions? Thanks. Here was it.
Thank you very much. My head's still spinning with all those drug names, but we appreciate that overview and that great presentation from our pharmacy fellows. So our final presentation today is another annual tradition. We're going to have the Best Pearls presentation. And the two people who are presenting today, actually, before we get to that, because you're going to be wrapped up in their talk, remember at the end of the day to pick up a cupcake on your way out, take an extra lunch. We have a few extras, and make sure you come back next year. So, so our next two presenters are board members here at CMDA. Allison Villegas is our education coordinator. Dr. Leslie Eber is immediate past president. So not only are they advocating for Colorado residents, but they also both serve on the board for our national organization, PALMed. So they are standing up for patients across the whole country. I'm very fortunate to call them fellow board members and friends, Dr. Leslie Eber and Allison Villegas.
I think this is our favorite part of the conference. And so this is the time when we get to review what things you can do on Monday morning to make a difference in your patients' lives. So these are our top pearls.
Or if you're taking calls right up till 5 on Friday afternoon, you can use these tonight too. So pearl number 1, vital signs are vital when screening for sepsis. I like the 100, 100, 100, so thank you for bringing that one up. You want to look for hypotension, tachycardia, fever, tachypnea, hypoxia, and altered mental status.
So cute. Pearl number 2, please do not do that non-FDA approved Alzheimer's dementia test or even consider it unless your patient has objective, not subjective, cognitive impairment. If you do the test and the patient has no cognitive impairment, the chances that the test is going to be accurate is only 50%.
Use antiplatelet therapy after CVA. Well, I was trying to make it easier for us, and then it's easier to move. Although I can get my squats in, and you guys can hear every other word. Okay. Use antiplatelet therapy after CVA and TIA for coronary artery disease. And pro tip, after 12 months from a procedure, there are very few reasons to use dual antiplatelet therapy, right?
Please invest in one another. Invest in relational care and social health are crucial to overcome health of the caregiver and the care recipient. And use yes and, not yes but, not no, but yes and to add positivity to the conversation.
It's the improv. I was going to yes and right off of you, but then I
couldn't think of anything because it's late on a Friday. Pearl number 5, good old Dr. Watson, please avoid alprazolam and clonazepam. And remember, withdrawal is particularly difficult from the high-potency benzos, specifically the 2 I just said.
As we have just learned, low albumin is absolutely not required to diagnose malnutrition.
And as we even more recently just learned, if a resident is seizure-free for 2 years, consider trial off seizure medications. And I've been doing this for a while and with great success. So, and I wrote down the exact pronunciation, levetiracetam and phenytoin for early post-traumatic seizure prophylaxis can be stopped after 7 days. And boy, do I recommend it because we add and we never take away.
So Pearl number 8, the contraindications for THC include acute psychosis or other unstable psychiatric conditions, and we warn people with cardiovascular disease, especially arrhythmias and other CNS depressants. For CBD, we want to be very careful to note that, that's it. We want to definitely note liver disease and also a combination with CNS depressants.
Pearl number 9, benzodiazepine efficacy for insomnia. Short term, it can help induce sleep, but the benefit is short-lived, only 1 to 2 weeks, and it does affect that restorative sleep. So don't do that or the shot of tequila.
Okay, Pearl number 10, SSRIs significantly increase risk of bleeding with our patients who are on DOACs. So beware and watch for it. And then we have a bonus.
Bonus Pearl. The most frequently identified pathogens are Staph aureus, E. coli, and some types of strep. And remember, sepsis is the leading cause of readmission. So use those early indicators and screens. And join us next year. We saved the date for April 24th, 2026, which feels, I can't believe we're in 2026. And then I think we have a question. No, oh, look it. Now that's Twyla. The one on the left is Twyla Beans. That's my puppy. And that's Axel and Rosie.
Yep, those are Axel and Rosie. They're rescue dogs, and they're very interested in high-quality care in post-acute and long-term care medicine.
Because they're geriatric puppies. No, I'm just kidding.
Thank you, everybody. Now we're going to turn it over to Rebecca and Sing to give away some stuff.
This is fun.
Pass them out?
Yeah.
So maybe we want to just take turns to draw?
Yeah, we can definitely do that. So these are from our wonderful vendors that participated in our trade show this year. So thank you to them. Let's give them a round of applause, actually, because it was a great trade show. So, all right. We have a Netflix and chill basket. And I'm not sure, who is that from?
Is this CMDA? This is from CMDA?
Oh, that's from CMDA. Look at that. All right. All right. And the lucky winner is Heather Ross from CDPHE.
I think we should just keep going.
Yeah, it's great we have here.
I'll jump up.
Oh, great.
The next gift is a gift basket from Brighton. Quinn Liu.
All right. We have, see what I say? Sorry. I felt weird bending over to talk into the mic. This is from Longevity. So we have a golf bag and package, and this is going to Carrie Schultz from Rocky Mountain Senior Care.
CMDA.
Oh, this is another CMDA gift bag. We've got it's a s'mores and more basket. That's a cute name. And we're going to give that to Gabriel Silversmith from Innovage.
It's CMDA gift card.
Another CMDA gift card and it's for Tabitha Seamock from long-term care rehab. She's still here. Awesome, thank you. Everybody stayed, that's amazing. This is from Calabria. It looks like it's a picnic basket with a lovely bottle of wine in it. So, and our winner is, can you tell me how to say that last name? Right.
Tu Nguyen.
Nope, okay. I didn't want to say it. Well,
CMDA.
another CMDA gift bag with a gift card in it for Elizabeth Keltz from Stone Mountain Healthcare. Awesome.
Oh, longevity.
Ooh, Longevity did a Woodhouse spa, which is lovely. I've got Brittany Cootie from Columbine. That's our group, yeah. So we have, it's a barbecue basket from NCH Health Partners, and it's going to Adrian, I'm not gonna say, I don't know, I can't read the writing. Is that Podilla? Podilla? Yeah, CDPHE. Sorry.
Wow, it's a plus here. Oh, it's court here. Oh, $100 get us on gift.
Okay, and we're gonna give away a $100 gift card to Amazon from Core Care, who was amazing in helping us set up this this whole conference. Ian has been fantastic. So just that gift card is gonna go to Jessica Holt from Shamar Village.
This is Maher.
Oh, okay. I don't know where else to. Okay, sorry about that. All right, this is from Maher Rehab, and it's Breckenridge whiskey. Oh, I know. I was going to volunteer myself.
Here.
Alina Solorzano from Liberty Heights.
I think this is the last thing we have optimism. Not at them cooler. We got one for Valerie.
And then Optum is giving away a cooler. Looks like another picnic thing for Valerie Shade. All right, that is the end of our 2025 conference. Thank you so much for coming and being a part of the day. We are really grateful for our community here in Colorado. So have a safe trip home, everyone.
Thank you.
Can you turn that?